A very good morning and warm welcome to all experts on the dais and the learned audience. Myself, Dr. Shomik Ghosh, I am working as an assistant professor in Department of Cardiology, IMS BHU. And I really feel proud that Varanasi is one of the hub and spoke model in this STEMI ACT research project of ICMR. And I am also privileged to deliver this lecture, which is very important with regards to this project. And the title of my lecture is Time Sensitive Management of STEMI Assessment of Successful Thrombolysis. So this lecture not only entitles the time sensitive management of STEMI that is to be followed by physicians per se, but it is for the entire medical fraternity. Only physicians cannot deliver this service, but the entire medical fraternity, I mean the nursing staff, the administration, the lower levels of the workers, they from all strata of medical fraternity, they should be knowing what is this time sensitive management of STEMI. Now, many times people do not recognize the STEMI, what is colloquially we known as a heart attack, and many times they know that is stroke. The stroke is two types: one stroke of the brain, one stroke of the heart. So we have to first educate the people what is STEMI and it is and what is the importance of time-sensitive management of this condition. So, what is challenges of ST elevation MI system of care in India? The PCI, the percutaneous intervention, remains inaccessible to majority of patients, and alarming treatment delays exist in patients presenting with chest pain. So, time is to diagnose the ST elevation MI and initiation of reperfusion therapy in India is variable. So, and the delay in the treatment will lead to myocardial loss, and the start of the treatment in golden hours is the key for myocardial salvage. So it is important to know that when to diagnose, how to diagnose, and as we diagnose, as soon as we diagnose, we should treat the patient because as we delay, the myocardial damage will occur in multiple times. So the concept is time is muscle. So as the seconds are clicking by, we know the heart is pumping in every second. So as the heart is jeopardized with the loss of blood flow due to coronary thrombosis or the coronary standstill of the blood due to the thrombosis in the coronary arteries, so the blood gets jeopardized. There is ischemia and there is hypoxia in the tissues, and so there is the impairment of the cardiac muscles. So for every second, every minute, it counts. So role of thrombosis in ST elevation MI. Now the AHA guideline dictates that on the onset of artery occlusion, there is a time lag, and so the patient there is a symptom awareness, and then the patient has the first medical contact. So this time is already patient-related delays, and this can be done by educating the people, mass awareness that whenever you have a chest pain, you should have the first medical contact as soon as possible because this delay has to be from the this delay can be curtailed from the patient point of view. So we can transfer the patient can be transferred to any of these three types of places like emergency medical service where the patient the attendants call the ambulance and the pre-hospital ambulance comes and there should be a pre-hospital ECG in the ambulance itself. So this is one of the criteria, and then the patient may land into a PCI capable hospital and a PCI non-PCI hospital. So this PCI capable hospital, this is also there is some logistics around it. So there should be a 24/7 round the clock program for PCI availability. And then if the patient lands into a PCI capable hospital, then the patient has to be arranged for the primary PCI. And if the patient is not in the PCI capable hospital, then the question of the fibrinolysis comes, and the door to needle time should be as less than 30 minutes. So if the patient is in PCI capable hospital, then we can do the primary PCI as soon as possible. So this fibrinolysis or PCI. These are both modes of reperfusion therapy. One is pharmacological and another is interventional. Now, reperfusion strategy as recommended by the ESC guidelines. So, at the strategy clock, which is ticking by at the 0 hour, now when the patient has the first medical contact and then the diagnosis of ST elevation MI is done, then the, if the patient is transferred to a PCI capable hospital, then primary PCI strategy should be started within less than 120 minutes, less than. And during the transfer of the patient from the patient house to the primary PCI capable hospital, the hospital ambulance, it should be alert, and during the transfer, the PCI capable hospital should be alerted that this patient is coming so that everything is ready, that no time is wasted. And the wire crossing and reperfusion should be done in less than 90 minutes. So the wire crossing, the PCI, the PTCA wire we use, that is hardware where we cross the wire and we successfully pass the thrombosis, then the first flow can be established. That should be less than 90 minutes. And if it is not possible for a, PCI to be done, then fibrinolysis strategy, and there is non-PCI capable hospital, then bolus fibrinolytic is to be given. That is to be given at around 10 minutes, and the landmark is less than 30 minutes. And then if the patient is can be transferred to a PCI capable hospital, then you should be transferred immediately within 60 to 90 minutes. And if the patient is still meeting the reperfusion criteria, then he or she should undergo for routine PCI strategy. If not, then if the patient is still having pain and signs of ischemia, then he or she should go for urgent rescue PCI. So major issues for the delay seen in Indian settings is a lack of awareness is the first. So first and foremost, we have to increase the awareness in the mass population, and mistaking the myocardial infarction with acid reflux disorder. So these are the mimickers. So whatever the mimickers are, we should have the patient understand that each of them should have a ECG done at least to rule out that he or she is not suffering from a myocardial infarction. And also, if the patient is traveling from his or her home to the medical contact, then the traffic jams are there, which is very much in India. Lack of proper trained personnel in ambulances so that an ECG can be done. And trying to get too much many opinions from real doctors as well as Google doctors, and also the financial issues are there where the patient can bear the financial cost. Now, selection of reperfusion strategy in ST elevation MI. PCI is a gold standard. But preferred, but it is less accessible. It is no doubt it is less accessible because we don't have the primary PCI facility in each and every corner of our country. So we go for the thrombolysis. Thrombolysis is also a type of reperfusion therapy, and it's a very good pharmacological reperfusion therapy. It is easily available, economical, and it has been evaluated in clinical status, and it can be done at every medical contact if the contact center is trained. And the thrombolysis followed by PCI, this is another concept. This is called the pharmacoinvasive PCI, and it is also an attractive and good option which bridges the gap between the patient's symptoms and the delay of management. So why this approach has to be stressed so much? Because time is myocardium. Again, I'm stressing on this. For each 30 minutes delay in treatment in the ST elevation MI patients, 1 year mortality increases by 7.5%. So this is very important. And the mortality benefit with primary PCI is lost if the PCI related delay exceeds the 60 minutes duration. And practically, early fibrinolytic therapy can compensate for the PCI related delay. So we should always vouch for this pharmacological reperfusion if PCI is not available. And proportional mortality reduction was significantly higher in patients treated within 2 hours with thrombolytics. So if we can institute thrombolytics within 2 hours of patient chest pain and symptoms, then the proportional mortality reduction has been shown to be significant. So these are the list of thrombolytic agents that are currently used. tissue plasminogen inhibitor, the fibrin selective ones, and the altiplase. This is the tissue plasminogen activator produced by the recombinant DNA technology. It has a half-life of only 3 to 6 minutes, and it acts very fast. Fibrin enhanced conversion of the plasminogen to plasmin and produces limited conversion of plasminogen in absence of fibrin. So it is very site specific. And retiplase is also widely available and used. It is similar to altiplase, but it has a slightly lower fibrin binding and superior penetration ability. Tenecteplase, similar to altiplase, greater affinity for fibrin. Streptokinase is our age-old thrombolytic agents. It's quite cheap and available everywhere and affordable also. Irreversible binding and activation of streptokinase to plasminogen, and it is vaguely fibrin specific. So it is a bit fibrin non-specific. Anastrobase and urokinase are other fibrinolytic agents. What are the contraindication to thrombolytic therapy? So this we have also to keep in our mind. There are certain absolute contraindication. Any prior intracranial hemorrhage. So we have to just rule out the checklist. Any prior intracranial hemorrhage, known intracranial malformation or neoplasm. These are the questions to be asked very fast to the attendants, whoever they are within the vicinity. Ischemic stroke, if it is within 3 months, suspected dissection, recent surgery, major surgery, recent head trauma, and recent means within 3 months, and bleeding and diathesis. And relative contraindications are age more than 75 years, current anticoagulants, pregnancy, cardiopulmonary resuscitation more than 10 minutes if had been done, recent internal bleeding of 2 to 4 weeks, uncontrolled hypertension, systolic BP of more than 180, remote ischemic stroke, and major surgery within 3 weeks. Assessment of successful thrombolysis. This is another very important aspect of STEMI management. And this successful clinical reperfusion term is used, SCR, and it is defined as presence of at least two of the following criteria and 2 hours of thrombolytic treatment. So, the first criteria is there should be significant relief of pain, and according to a scale of 0 to 10 on a scale, the patient should have at least 5-point reduction of the pain symptom, and the more than or equal to 50% reduction of the sum of ST segment elevation in all the leads. And also the abrupt initial increase of creatinine kinase level, this also reflects that the patient is in ST elevation MI. And there are certain other indicators also, like there is a appearance of AIVR, idioventricular reperfusion arrhythmia. Now, acute coronary occlusion, it occurs, then normal ECG, then first is the ECG changes. This is a hyperacute T wave. This occurs within minutes to hours. Then there is an ST elevation. It occurs, persists till 12 hours. Then the Q wave start developing. This is the sign of myocardial injury. And the ST elevation with T wave inversion then occurs at around 2 to 5 days. And then T wave recovery, it occurs within weeks to months. And then if the patient has been not successfully treated, the myocardium, the LV becomes aneurysmal and there is persistent ST elevation with Q wave tube formation. And this is the final ECG of an ischemic cardiomyopathy patients. But if we can treat within the first and second hour of the patient with a successful reperfusion therapy, either interventional or pharmacological, then this terminal T wave inversion, we can get this amount without the formation of this Q wave. The Q wave, this myocardial injury we can avert, and then there is a later symmetrical T wave inversion with a successful thrombolytic therapy. And then with days and weeks, we return to the baseline EKG. So with that, I would like to thank the dignitaries and audience for having a patience for listening my lecture. Thank you.
So thanks, Dr. Soumik Ghosh. Now I need some comments, expert comments from our ICMR experts and panelists, so that it can be re-emphasized. So things very nicely told by Dr. Soumik Ghosh, the importance of time. Time is muscle. In the various changes you have seen in one last slide that the ECG changes are different if we thrombolize them or reperfuse them on time. So reperfusion can be done by primary PCI or thrombolysis, and in within golden hour, its results are excellent and comparable. So thrombolysis, which is very simple, just push injection, जैसे आप प्रोग्राम देते हैं वैसे ही इसको पुश करना है. Contraindications are not there. Contraindications बहुत अच्छे से सर ने स्लाइड में दिखा है डॉक्टर सौमिक ने, और वो उसमें रिलेटिव भी है और कुछ वो भी है जो एब्सोल्यूट है. एब्सोल्यूट में तो नहीं दे सकते, तो आउट हो गया, आपको थ्रोम्बलाइज नहीं करना है, और वो फिर पीसीआई के लिए जा सकता है, तो उसको इमीडिएटली पीसीआई का बेनिफिट इफ अवेलेबल तो कैन बी सेंट देयर टू द. और यदि रिलेटिव है तो देन यू कैन मैनेज देम, इफ सम ऑफ देम लाइक बीपी है थोड़ा सा मैनेज कर सकते हैं, तो देन इफ इट कम्स इनटू द रेंज देन यू कैन स्टार्ट. एक्सपर्ट कमेंट्स सर.
So, first time of some patient. What needs to be understood here is that why do we call it as a golden hour? Is maximum damage or with maximum amount of myocardial damage after will occur in first hour. Unfortunately, our work starts when the patient us. हमारे पास जब पहुंचेगा तभी हम काम शुरू करें. हमारे पास जितनी जल्दी पहुंचेगा चेस्ट पेन केस के आधे घंटे में our effort has to be faster and more decisive. अगर 9 घंटे 10 घंटे में पहुंच जाए तो मायोकार्डियल डेथ भी होनी थी, जो कौन सा मायोकार्डियल which will be designed to be closed, it will already have. So that means the management or reducing this time gap involves two parts. One is to form or make a mechanism by which patient understands that this is a pain of myocardial infarct. That is what he pressed upon, that predominantly patient has to reach earlier rather than waiting here and there and not paying attention. So probably various discussions. Patient has to remain aware of that. Pain is not a symptom. And second is our initiative and the patient. It has to be. More and whatever available means that if thrombolysis or you give PCI means angioplasty. For that, I would also like to stress upon one more thing. Aspirin must be given immediately. Impact of aspirin in saving life is same as thrombolysis. In number of lives can be saved by giving thrombolytic therapy. Aspirin. So aspirin is available, immediately available aspirin. And then you plan how to get you diagnose it with aspirin. And other drugs must be given, but thrombolysis is vascular analyzation is a key. Comments?
I think Dr. Sumit has already highlighted the importance of early use of thrombolytic agents. And
Sir, let me introduce Dr. PC. Sir, 1 minute.
Also has
Thank you, sir. I want to introduce Dr. PC Negi sir has already done this project in Simla district, and then whole HP I think he is covering. So his experience regarding that, he is taking a lecture also on that. And please go ahead, sir.
So, as Professor Nidhi has highlighted the importance of adjunctive anti-platelet agents, the thrombus, although it definitely a red thrombus, thrombus, where the thrombolytic therapy is the role. But equally important is the use of antiplatelets. So we have to use the lower antiplatelets, which is a different mechanism of action. Two antiplatelet agents which we have to use in the STEMI patients with loading doses, especially people who are less than 75 years. Of course, these would protocol would be provided to the sport centers in the field, and along with that, you need to give the IV enoxaparin, low and currently, along with the connected links. During our yesterday's visit, we have visited some of these the hospitals, district level hospitals, interacted with many medical officers, and their concerns was that suppose something happens to the patient after thrombolytic therapy, then there's going to be a medical legal issues or some you invite trouble. So that was a major concern. So I would say that in that context, it's very important to inform the patients about the potential benefits and the potential risks. So you have to weigh the risk and benefit. Not thrombolizing is going to do more harm than giving the thrombolytic therapy with the small definite risk of fatal bleeding also. Sometimes you do come across once upon a time patients with intracerebral bleed, which is a big complication, right? So if you have informed the patient, taken a consent from the patient's relative, I'm sure it is going to avoid unwanted, the follow-up the problems which you have genuine concerns for that. So I think what we have seen in our state, in a district where we implemented this project, there was only one patient I would recall that who that the hemorrhage, the cerebral bleed occurred while he was after shifting to the up center, not immediately there in the sports center. And secondly, you need to have a monitoring facilities in the sports center. And we have seen that some of the divisional district hospitals, PSC, they have a defibrillator. So defibrillator, you can use it for monitoring purposes also. Because sometimes during acute stage, some people may develop ventricular fibrillation, which is a fatal if you not identify and timely defibrillate. So I think we lost 2-3 patients in our district because we did not have any monitoring facilities. So it is not to say that thrombolytic therapy will increase the risk of arrhythmia. Of course, I would believe that timely reperfusion therapy increases the risk of arrhythmia. But still, in spite of thrombolysis, we may come across sometimes patients developing fetal ventricular arrhythmias, where if you have a facility for monitoring and defibrillation, you can save lives. So I would definitely go with the Dr. Swamik's presentation that we need to work together. In considering the situations in every district practically, without any system of care in place, these patients are underdiagnosed, undetected, and inappropriately treated, and they end up with the complication, heart failure, and long-term morbidity and mortality, I think, which is basically preventable. Whatever help you can do is during the acute phase. Once the myocardium is damaged, there is no way of rejuvenating that myocardium. We do not have any regenerative medicine which has progressed to the stage where we can replace the dead myocardium and restore the ventricular function. So, as of today, the modality of treatment is to achieve the rapid reperfusion of the closed blood vessel, restore the blood supply to the myocardium, and prevent further myocardial damage. That's the way we can help these patients. We would like to have your comments, basically your concerns, what you think would be the real challenge in implementing this complex therapy in the respective hospital. Any comments, questions?
Usually the approach that comes at periphery is okay. Tomorrow, not today, we can't do it today. Sometimes later, we will ask. Why it is not helping the patient? All the patient to life saving होने की improve क्योंकि अगर हम compromise कर लिए 100 मरीजों को हमारे जीवन में extra opportunity को opportunity करें. दूसरा, by sending you tomorrow or day after tomorrow or whenever and doing an angioplasty, you are not going to get the muscle back the way you were seeing. So if it has to be done, it has to be done within certain time frame of MI, not third day or fourth day or fifth. Then it will not be.
Morning, everyone. First, let me know how many nurses are there in this hall. Oh, a good number of. Good number. How many doctors? MBBS doctors? How many specialists? I think the CMOs are also. It's wonderful to have all of you over here. As shown in the presentation, there are two options to save the heart. We can go for PCI or we can go for common care. So having heard the cardiologist, not being a cardiologist, having heard them, the American Heart Association guidelines says that if a patient is within a reach of 120 minutes from a hospital with PCI cardiac, then he should immediately be shifted to that hospital. I think that was a catch. That was something which scared us for the community therapy. We thought that's a gold standard. We have to do only PCIs. We did not realize that in our country, the remote areas will never get that kind of capital facility. We will not be able to transfer them within a period of 120 minutes to the hospital. We are not using air ambulances. And I don't think that is feasible in the near future also. Similarly, even in our urban areas, I'm in Delhi right now, staying in Delhi right now. To reach my office, which is 24 kilometers from my house, it takes me around 1 hour 30 minutes. So how does a patient recognize the symptoms late? Our registries are telling us that they are reaching beyond 120 minutes. Most are reaching after 3 or 4 hours, or even a day once they start having the symptoms. So how do we do that? If I look at the data also, then there are 30 lakh studies which occur every year in the country. Out of that, 3.8 lakh only are into PCI. 10 lakh technologies, which is around 30%. And if you look at primary PCI, we are not talking of PCI around 71 on the fourth year or something. We don't even know what is the benefit of it, or whether they are actually harmful. Only 52,416 primary PCIs done in the country out of the 30 lakh patients who suffer from that. So this clearly tells us that the most important thing which we can do to save our patients is we need to thrombolyze. We do understand the fear of thrombolysis was there when streptokinase was the only drug which could be used over there. But with the new generation anticoagulants, I don't think we have that kind of fear now.
Say.
So that's the reason for going for the hub and spoke model. Here, we plan to increase the thrombolysis rates in our centers. And we do feel it's just like I was really thinking, what are the life? It's like giving more or less to the diarrhea patient. It's almost the same when you are just sending your ECG to a penny ECG time. The consultant is the one who is telling you that what you have to do. If you are administering the common medication, it's a bolus injection. There are minimal side effects, as has been known by Dr. Yedi and Dr. Yedi. So I think this is achievable. We do understand your concern. We visited district hospitals, we visited CSC, there are issues. But then we have to sit down together to resolve those issues rather than running away from them. It's unethical not to give to compromise the patient when he's coming to you and you know that this is happening. So thank you very much. I think we can discuss some of the things or concerns. That's much more important. The workshops are meant to discuss the concerns rather than we talking about it. You have to get benefit for our patients.
Good morning, ma'am. Really very nice PPT. One my concern, PMO चंद्रबाबू. तो अभी तक जितना हमने देखा, अभी तक जो presentation हुआ, what I feel कि if possible आपके end से 2-3 pages का एक synopsis हमें मिल जाए. When to start thrombolysis, when not to start thrombolysis. क्या दवा देनी है, कैसे देनी है, ये प्रोटोकॉल मिल जाए सो दैट कि हमारे जो रिमोट एरियाज में एमबीबीएस डॉक्टर्स हैं, यंग जनरेशन के, उनको थोड़ा नॉलेज है बट दे डोंट हैव कॉन्फिडेंस कि दिस पेन इज एमआई और नाउ आई मस्ट स्टार्ट थ्रोम्बोलिसिस राइट नाउ, या कंट्राइंडिकेशन है तो नहीं करना है, इमीडिएटली हमें इसको शिफ्ट करना है. तो ये अगर थोड़ी सी सलाह अगर हमें मिल जाती है तो हम एक ट्रेनिंग सेशन अपने डिस्ट्रिक्ट लेवल पे ऑर्गेनाइज करते हैं उन डॉक्टर्स के लिए और स्टाफ नर्सेस के लिए. तो बैचेस बना के उनको ट्रेन करते हैं तो दे विल गेन अ मच मोर कॉन्फिडेंस दैट समबडी हैज ट्रेन्ड मी, और उस ट्रेनिंग के बेसिस पे हमने थ्रोम्बोलिसिस शुरू किया या कॉन्ट्राइंडिकेशन था तो नहीं किया. तो एक आपके इनसे अगर प्लीज अगर पॉसिबल हो. थैंक यू.
बहुत ही important issue है. This has been in our mind. Dr. Dharmendra is working with she can share with you. So that's one thing. Second thing was that we also realized 8 districts, 7 states. States are now coming up. States अभी हमें कह रही है कि इसको expand करिए. जैसे हिमाचल में obviously हमें 3 साल करती है. उससे इतना confidence बढ़ जाता है. करने तो कई और भी districts में अपने आप से start करवा दी. इसी तरह से आंध्रा के तो आंध्रा वाले भी कह रहे हैं, पंजाब वाले भी कह रहे हैं, इसके भी. So what we are now doing, I will be honest with you, that one is the protocols which they will be given, but one is something which will come out from ICMR. So tomorrow again we are meeting with our experts, the people who have actually worked on it, Dr. Devi and Thomas and other Krishnan from names. We will be sitting and defining what has to be done. The steps and guide, small guide, 4 pages for each step. So we will do that.
We are having today.
Fine. We can invite.
Videos are there in the session. We will show you and share you, and all the participants will get everything. Don't worry. I will share everything. Each and everything. SOP is there with a PDF form. You can read it nicely. It's already prepared. We'll share it. And videos we will show you everything. ECG taking, DFib using, injection preparation for nurses, everybody. ECG, how to take to the technicians, and for MOs to take the decisions, what are the indications and contraindications, everything is there. That is the purpose of this program. Very nice.
Very nice.
उधर मैडम को है एक और मैडम है रखिए.
Good morning.
अभी मैंने चेक किया इसमें किस नाम से.
Actually, so thank you very much for the excellent presentation. Just to repeat myself,
I work with University of Manitoba, India Health Action Trust. So, and what we find is the peripheries that most of the nurses are there, and there is a human resource crunch. The most important thing is within to act between the two golden hours is risk stratification. We are not able to decide, and the ECG findings they are not able to interpret. Usually, ECG is not empowered, and ECG is like a essential or even try sometimes for especially because there are multiple reasons. Even for STEMI, there are multiple reasons. So just to control and give special training to our nurses and medical officers, I think it is important that they are able to decide what do they require? Because the general data, even the American Association data shows that thrombolysis was given to, some young patients also. So just to avoid that, because thrombolysis is such a great intervention you can have at the peripheries. Because PCI, because of the cost, it was not able to access. But I think that in the EPM, we give the ECG interpretation and the diagnostic capability and the competency to our providers. So if the panel can, help with this stratification, I think that could be great. Thank you.
Very much, ma'am. Same question or? Okay, okay.
I am Dr. R. As a consultant medicine in geriatrics. Immediately after my post-graduation, that was in 1984, I was involved in a project, ICMR project, that was about primary prophylaxis of rheumatic fever, in which this peridor L12 was given any persons having a sore throat. So in that field work, we had that there was a legal issue that peridor L12 was to be given through MPW, who were not authorized to give penicillin injection. So in this case also, the doctors posted in periphery, they are mostly they are MBBS. So if anything goes in consumer forum, then they are entitled to give this comparative therapy to the patients. So what we have to answer? Because I have seen that some working district, this districts, they were not trained as a cardiologist, but they were attended by a cardiac patient, and the patients went into consumer forum that they are not qualified enough to give that treatment. So in this question, what we are going to do?
Answer the question posed by you. We have created a network. We create a network of consultants. For example, if I must be having 7 or 8 to 10 those networks of which I am part of. Dr. Maybe part of 5 or 6 networks from history to me. I keep on putting in other networks too. But definitely those kind of networks have to be created so that the ECG is quickly loaded on the WhatsApp group, and within a small period of time, one of the consultants advises you what has to be done. Is it STEMI or not STEMI? And how do you manage it? Actually, this tally medicine which we are using. So it's not that the doctor is sitting in the MBBS, MBBS doctor sitting in the faculty. He's the one who is existing, and we don't just rely on him. It's a group which is doing, it's a team management kind. Everyone in the group knows what we have. Thrombolysis, ECG, and post. Both of them are posted. If required, the patient is shifted to a tertiary care center. So this is what is done. I think because this is done in a network, the chances of having those medical cases, they are really reduced. We have done around 3,000 patients in this care pathway project. We haven't got anything on that. Dr. Maybe can add more things.
no guideline says serious doctor cannot do it. Giving thrombolysis does not require any script, just simple injection. The main issue is that your diagnosis has to be correct. You have correctly been ruled out the contraindication. If you have done that, then not giving thrombolysis is going to be illegal. Why this patient was not deprived from giving the evidence-based treatment. It is known to decrease the mortality. So I think for confirmation of diagnosis, which is an important issue, we have who is IT technology now, we have the WhatsApp group. There you have a panel of cardiologists in this group. And they are the ones who are going to interpret and guide the doctor sitting in the periphery. This is a STEMI patients, go through those checklists. Those checklists are basically symptom patients, the patient-based, response is correct. So same protocol is going to be whether you have ruled out those people. More important thing is to counsel with it. This is a drug which is a time sensitive. Staying using this drug, you are going to damage your heart more. You are likely to end up with a. So if you do not get this drug injection here and waste 2 hours to shoot the patient and the injection, I'm sure I think by and large most of the cases people will do understand. And because of the support of the experts in the two element consultation system, the doctors out there have reasonable confidence. I think this answers your query, Dr. If you answer the query.
The question related with the consumer forum or other legal issues. Because I don't understand the who will be the responsible, who will take the responsibility if anything goes wrong. Because whether our WhatsApp groups and whatever we will communicate with each other with the help of the telecommunication, is it permissible in courts? $20 question is this: whether court will accept this key, all the consultation on the telemedicine and WhatsApp group is good enough for the treatment of a patient of MI.
So you have basically national guidelines on the telemedicine. And in that telemedicine guidelines, the WhatsApp is one of the accepted form of communication of the clinical data of the patients. Patients health record. So tele-consultation through using WhatsApp is an accepted mode of consultation. When advice is being given by the expert, health system is implementing this project. Obviously, the state government is also responsible. And you have mechanisms in this system through the service scope model where we ensure the safety of the patients by ensuring the diagnosis of STEMI is 100%, and it is basically based on the ECG, not by the symptom. Anybody with chest pain with typical ECG, then and now you will normalize, not based on the symptom this patient is presenting. So there is an objective evidence to make a diagnosis of STEMI. Based on that, expert basically guides to normalize. So it is basically government initiated project, and it is going to be upstate to the whole of state. So let me share with you in my state. Last 3 years we have been implementing this project. We have normalized almost 600 patients, and we have not come across any medical issue. And as I said, 2-3 patients died suddenly because of the known complications of acute MI, not because of thrombolysis. It is basically the known complications of MI perceived can lead to sudden cardiac. Those patients could have been saved if we had facilities for monitoring and defibrillation in these health systems. So this is what you need to ensure as a health administrator in your district hospital, where you are going to implement this program. You must have the defibrillator, and each defibrillator has a system of monitoring. You need to ensure some healthcare provider during traumatization is at least for half an hour or so should be there in the rooms where you intend somebody.
Just to add to what Dr. Devi has said, when Dr. Devi says 600 patients traumatized, 70% of them have been traumatized in our CMC. It's a huge number just with that. Then in other centers too, we have done around 3,000, and it's again a good number, 60%. We have not yet come across an issue. And WhatsApp group, that is something which we try to build up an app. But app versus WhatsApp group, somehow the doctors are trying to partner. Easy to use a WhatsApp group. You can even go for a command center, that's your choice. You can even go for some private clinics, that's again your choice. We have given a very simple model that this can be done. That's one thing. Your concerns, you're very right. When we were doing I traveled another project, a motorcycle, a nurse driven motorcycle ambulance. We use that to provide cognitive therapy for the patients who slept in there. When we started the project, people much more questions were there. Because we were doing the research project. In a research project, you are too conscious for each and everything. So we were worried so much that something will happen in the periphery. If a death occurs at home and the two nurses are there, you can understand that there can be anything which can go wrong. So we even asked them to push an emergency button connected to the police system, PCR system, so that if something happens, we can be called quickly and these will can be saved. But nothing happened. It was not during the 4 or 5 days of that project also. Though the complexes rates were not great, but even then the patient, they were going, the teams were going through those steps, doing the ECG, sending it back to the consultant. Our experience with 3 projects now, STEMI this project, motorcycle ambulance driven, a third one in STEMI, Tamil Nadu project, which gave the data hub and spoke model and did a pharmacokinesis. I think we haven't encountered anything of that. We are doing it together. The health system is with us. So when it becomes the more important is the STEMI guidelines, the national guidelines, we are going to be published. I don't know whether they have been released or not. It was going to be released. We contain everything. We talk about competencies and the CHC. These are the national guidelines. Where it's the national guidelines of the I don't think you will have an issue with the medical records. However, you are going to get a different issue which not maybe as part of that. If you don't normalize, you can be patient and take report for not doing the treatment at time. It's the opposite.
Hospital must be a provision for compensation. If there is we expect that nothing will happen, but if something happens, there must be provision. As in case of the sterilization procedures, there is a provision that if patient dies during this sterilization procedure, government will pay for compensation. So in this case also, I think this should be kept in mind that there should be a provision for compensation if anything happens.
This injection is basically voluntary. You need to take consent on the patient. You cannot give without consent. There is no question of the compensation. Any patient who goes to the hospital, not everybody survives. Many patients die because of the disease per se, not because of the treatment which they are giving. So if you start giving compensation with every medical emergency, they are not run. They are there, they have come on their own for medical treatment. And this kind of treatment invariably is initiated after the current death. Not basically for any compensation.
Sir, in sterilization program, I have worked as CMO, Chandravari also. There in sterilization procedure also we take consent, everything. But if anything happens, then compensation is given.
Compensation is almost for the negligence. So negligence has to be proven. Without negligence,
You cannot ensure 100%. I think we are aware that it's like even there is negligence, we have to test without negligence.
There's a lot of confusion. Sterilization and you're dealing with everything. STEMI is for an acute emergency patient who would have died otherwise. So they're two different. You cannot compare them.
One more question I'd like to ask. This which is very serious concern, especially in provincial services. I am also from the provincial services, especially for the doctors, that we have shortage of infrastructure, manpower, and unmanageable patient load, which is very serious concern from the district hospital as well as in CSC and PSC. The problem is that how do we resolve this? First, we need to resolve this. Then, because the project is an overall fabulous project and everybody, I think, is appreciating this project. So, how do we resolve these problems? This is the basic concern that infrastructure shortage we have. We have shortage of manpower and the overall unmanageable patient overload है हमारे hospitals और ACCC के. Then how do we resolve it?
I agree with you. Stand back and think how big a problem STEMI is. I mean, if you all agree, STEMI needs to be addressed, we need to find solution within whatever the infrastructure we have got right now. Our country has been struggling with health infrastructure forever, but we have managed to conquer many of our diseases with the existing infrastructure. So now, myocardial infarction is the number one cause of death. 30% of our deaths happen due to this, and which is very, very important. And many of us know, and we need to address this issue using within our infrastructure. We know PCI facilities are not enough. We need to provide thrombolysis. We need to provide within our health system. This question should come answer solution come from the health system side. You guys tell us how we can resolve this within your infrastructure.
Ma'am, actually, the point is that ICMR is a very big team. If this question is raised by ICMR, that will be okay, fine. But how do we expect from the doctors that, yeah, doctors several times they raise their points, but the point is that once a higher authority raises this question, then definitely the state government and central government will listen this thing. Otherwise, that can be go randomly.
So,
We can think of task shifting too.
डेफिनेटली प्रोग्राम हमारा बहुत अच्छा है और सब कुछ अच्छा कर सकते हैं और काफी ज्यादा लाइफ सेव कर सकते हैं, बिल्कुल ध्रुव सकते हैं। लेकिन आईसीएमआर शायद इस चीज को नहीं जानता है। भारत की पब्लिक ये मानती है कि कोई स्वाभाविक मौत से नहीं मरता है। भारत की पब्लिक ये मानती है कि यहाँ पर जो भी डेथ होती है वो गलत इंजेक्शन देने से या डॉक्टर की लापरवाही से मौतें होती है। हम लोग इसे डेली फेस करते हैं पब्लिक में। तो इसका क्या समाधान होगा? सपोज अगर हमने इंजेक्शन दिया और उसके बाद उस पेशेंट की डेथ अगर हो गई, देन हु विल यूज द रिस्पांसिबिलिटी, और कौन हमारे अस्पताल को प्रोटेक्ट करने आ रहा उस वक्त? क्योंकि गांव का आदमी जो है अपनी ढंग से मैनेज करता है और आए दिन हम लोग इसको देखते हैं, क्योंकि ये पब्लिक में कॉन्सेप्ट है कि अगर वो अस्पताल ना आया होता तो डेफिनेटली बच जाता, डॉक्टर की गलती से या स्टाफ नर्स के गलत इंजेक्शन लगाने से ही मरता है। हम लोग इसे डेली फेस करते हैं।
I completely agree and I कहना चाहिए कि मैं आप जो पॉइंट रेज कर रहे हैं उसको मैं सेकंड करता हूँ, मैं सपोर्ट कर रहा हूँ। So that is what we are thinking also. Public awareness program must precede this. क्योंकि जल्दी में काम हो रहा है, आईसीएमआर पब्लिक अवेयरनेस कर रही है, लेकिन होना ये चाहिए आइडियल that the public is receptive to the yes, this initiative is there, this is a chest pain, मुझे नहीं लग रहा है कि हाँ जो दर्द मेरा है ये एमआई वाला ही दर्द है, इसमें एक बताया गया है कि एक दवाई वहां मिलती है और जल्दी से चल के ले ले। आई थिंक वो लेवल जब आएगा तब ये प्रोग्राम सक्सीड करेगा। आईसीएमआर क्या कोशिश कर रहा है कि अगर हम इस बीच में इसको एक हमारे पास इतना टाइम नहीं कि हम 2 साल पब्लिक अवेयरनेस करें। अभी पब्लिक अवेयरनेस हम दो हमारे दो कर रहे हैं जिंदगी बीत रही, तो बहुत बड़ी बात है कि हमें वहां जाके इंजेक्शन लेना है, तो साथ साथ कर रहे हैं। आपका पॉइंट बहुत वैलिड है। हर जगह हर स्टेज पे इवन इन मेडिकल कॉलेजेस वी आर सीइंग दिस प्रॉब्लम, बट वी हैव टू फेस दिस। आई थिंक वी कैन गो टू द नेक्स्ट।
बहुत बढ़िया क्वेश्चंस रेज किए हैं हमारे सारे स्टेट हेल्थ सर्विसेज से जो लोग आए हैं, उन्होंने अपने अपने कंसर्न बताए हैं रिगार्डिंग देयर एप्रीहेंशन रिगार्डिंग दिस मैनेजिंग द डेडलीस्ट डिसीज इन द earth which is there now. We have conquered, I think, all the infectious diseases. Now non-communicable diseases is the concern of the hour. And from NCD experts are there, and all ICMR experts from division of NCD only. So this is really a deadliest disease, and we have the owners and we gathered here to discuss about these concerns. So very good questions raised, and the public awareness, I think, is the most important thing. If public comes that मुझे वो injection चाहिए, वो ECG चाहिए, वो chest pain है, मुझे ECG चाहिए, मेरा ECG कर लीजिए डॉक्टर साहब, ठीक है, मेरे को इंजेक्शन लगवाना है, वो इंजेक्शन लगा दीजिए डॉक्टर साहब, शायद बच जाऊं, मरने वाला हूं। ये अवेयरनेस यदि आ जाती है तो हमारा काम बहुत आसान है, जो क्वेश्चंस और कंसर्न है वो खत्म हो जाते हैं। जैसे ही पता है कि मेरा सिर फटा है और मैं मरने वाला हूँ, ये पता है उसको कि ये मरने वाला है, शायद बचा ले न्यूरो सर्जन, है ना, कहीं से कुछ रोक दे ब्लीडिंग। सेम थिंग इज हैपनिंग, ये थक्का बन रहा है, वो थक्का कहीं से खुल जाए, ये पता चल जाए पब्लिक को, ये सिचुएशन खत्म हो जाएगी। वही वही चीज इसमें हर लेक्चर के अंदर है, वो सारा एम्फेसिस इसके अंदर है, पहले लेक्चर से आखिर तक। प्लीज वी विल गो अहेड, टाइम कंस्ट्रेंट्स आर देयर। आई विल इनवाइट विदाउट डिले डॉक्टर मीनाक्षी शर्मा, our scientist G from division of NCD ICMR Delhi. So we welcome. She will give us regarding this project, which is a STEMI ACT project, wonderful project. All of you are appreciating it and came here all the way. And Dr. Meenakshi Sharma, please.
प्रेजेंटेशन में अच्छा जो बातें बोलनी थी तो पहले मुझे लगता है कि काफी सारी चीजें तो हमने पहले ही डिस्कस कर ली है, और अगर आप चाहते तो मैं प्रोजेक्ट के बारे में बता देती हूँ कि कुछ इश्यूज हैं। जैसे आपने कहा कि हम लोग पहले क्यों, कम्युनिटी अवेयरनेस इज अ वेरी गुड स्टेप, बट वी मस्ट रिमेम्बर एनसीडीज में हमारी कैपेसिटी नहीं है। अभी एनसीडीज को डील करने के लिए हमारी अपनी हेल्थ सिस्टम पहले कैपेसिटी तो बना ले। आप आज कैपेसिटी बनाए बिना कम्युनिटी अवेयरनेस कर देते हैं, आपके पेशेंट्स लाइन अप हो जाते हैं, पेशेंट्स के तब भी तो आपके ऊपर मेरे मेडिको लीगल कर सकते हैं कि क्यों, मैं तो क्या था, आपने तो कहा था मिलता है वहां पे, जल्दी सिम्टम मैंने रिकॉग्नाइज कर लिए, तब क्या करेंगे? सो द फर्स्ट इंपॉर्टेंट थिंग इज टू बिल्ड अप द हेल्थ सिस्टम एंड देन गो फॉर कम्युनिटी अवेयरनेस एक्टिविटीज। तुम्हारे हेल्थ सिस्टम में कुछ चीजें जो फॉर एग्जाम्पल इन द लास्ट 70 years we focused on maternal health. We had many issues. Look at our indicators. Our indicators are showing that maternal deaths are less now. The infant deaths below 5 deaths are less now. Infections have reduced. If you look at the GBT report, we have transitioned from infectious. कोविड ना आता तो शायद आप बिल्कुल ही ना सोचते, इन्फेक्शियस से नॉन इन्फेक्शियस में हम चले गए। 60% of our deaths are now due to non-infectious chronic diseases. And as Dr. Rupa said, 30% of these deaths, these are due to myocardial infarction, cardiovascular disease, and stroke. So we have to do something about that. The hesitation in the health system is also understandable, because this is something new which we are going to. कुछ भी नया होता है तो दिमाग में आता तो है, और फिर हमारे पेशेंट्स का भी कुछ इस टाइम में जो पहले था 25-30 साल पहले पेशेंट्स मारते नहीं थे हमें, अब वो भी शुरू हो गया है तो हमें उसको भी डील करना पड़ेगा। अब पेशेंट जो है सोचता है कि ये तो ठीक करके ही बाहर भेजेंगे। So community awareness, when we come to community awareness, I believe that we have to make them recognize the symptoms, but also it will be very important to tell them that this is a very, very sick patient. ये बहुत बीमार पेशेंट है, ये कोई आम बीमारी नहीं है. इवन कैंसर का पेशेंट को भी टाइम लगता है. हार्ट अटैक का तो मुझे याद है कि जब मैंने आईसीएमआर में आके हम लोगों ने सोचा कि इनकी स्ट्रोक के लिए, हार्ट अटैक के लिए रजिस्ट्रीज बनाए, तो हमें समझ नहीं आ रही थी रजिस्ट्री कैसे बनाए, क्योंकि इतना एक्यूट इवेंट्स है. देन हमें आहिस्ते आहिस्ते पता चला इवन जो आज भी कनाडा की पॉपुलेशन में स्ट्रोक रजिस्ट्रीज है या हार्ट की रजिस्ट्रीज है, वो 50% पेशेंट्स को ही एनरोल कर पाते. 50% पेशेंट्स की तो इवन हमारी अपनी जो रजिस्ट्री आईसीएमआर की हार्ट अटैक की थी, वी रियलाइज दैट दिस इज अ रजिस्ट्री ऑफ सर्वाइवर्स. क्योंकि इतना लेट आता है पेशेंट, तो ये बच गया तभी आ रहा है ना हमारे पास, जो बचा ही नहीं वो तो आ ही नहीं रहा. Issues ahead, so you have to tell them that this is a very serious condition and we are trying to save. 100 में से 8 या 10 तो deaths होगी ही होगी, even if we do anything. And it's not because we are treating them, it's because of the disease that this is going to happen. But think of it, आज सुबह morning में जब डॉक्टर साहब ने बताया कि 44 years को MI होता है. Think what happens in the families, what happens in the society. जो हमें पहले 5 साल के बच्चे के लिए लगता था, 45 years के आदमी के लिए लगना शुरू हो गया, मैन और वुमेन. So community awareness definitely is going to be a major issue. We have to tell them, we can use our ASHA workers, we can use our ANMs. We have done one project for stroke in Ludhiana, where we used our ANMs and ASHA workers to recognize stroke. Similar can be done for acute coronary events. And that project, we realized that we train and retrain them. And as a result, what happens is that the sensitivity and specificity of screening by the ASHA workers, this increases to 90-95%. I tell you, we got a NHM award for this. This was an innovation in itself. So when you will start doing, there are small things which you will be innovating. And this is an implementation research project. It is not implementation only. You're asking questions, you are trying to solve the problems, and then implement in your hospitals and see whether it works or not. So you will always be discussing all those things. So resource, the second important thing when we will ask you for to do is the resource mapping, cluster mapping. So in the district, we'll give you a pro forma kind of thing to understand what are the opportunities, what are the shortcomings, what are the gaps, and whatever is there in the health infrastructure, is there a little more which can be given? Or we can use the same, just readjust our systems. Especially for STEMI and stroke. If you look at them, then these are multi-specialty teams which are working. This cannot be done by one doctor only. You require nurses, you require a technician over there. So you have to look at that what is the infrastructure over there. Then you have to build up healthcare networks, the specialist networks. That gives a confidence. What we realized in other districts was that as soon as there is a network, as soon as you know that there is somebody who is behind you, it becomes easy for a doctor sitting in the periphery to do the needful. Am I right or not? हाँ? आपको लगेगा पीछे जो बैठे डॉक्टर्स है एमबीबीएस वाले, आपको पीछे अगर सपोर्ट दी जाए, आपको पता है कि डॉक्टर नेगी है, डॉक्टर द्विवेदी है, डॉक्टर धर्मेंद्र उसी ग्रुप में है, और आपको फटाफट कंसल्टेंसी देके, you just have to do it. And after 1 or 2 years, I know that you will be geared up to do it on your own also. You may like to read the ECGs and start doing it. But in the beginning, we are going very slow. आप टाइम लीजिए 2 साल, 4 साल, 5 साल, जब तक आपको लगता है कि हमें कॉन्फिडेंस नहीं. So that networks are very important, and these networks are very responsive too. And these are an online CMEs now. That is what we are calling it now. Because everything what is happening to the patient, this is being put on in the globe. So everyone is learning. the patient had so and so. So now how it should be managed. ECG, you have your own interpretation in mind. Now you look at the interpretation of the consultant. You match them, you learn. The drugs also you learn. Then the ambulance system has also to be geared up. You will need to give training to your ambulance staff too, when you are shifting the patient from the periphery to the hub center. So how do we do that? That training has to be there. We have to ask for the state government to support it. That is why we ask the state government to participate in this project, because this cannot be done as a research project. Researchers अकेले नहीं कर रहे. This is an implementation research project where state government is an equal stakeholder. So this is a pilot project, definitely. This is not something which we are doing for the entire state right now. We will be doing certain things, we will be learning and improving the systems. Every state is unique. What we were able to do in Himachal, we could not do in Andhra Pradesh. We could not do in Punjab. So we had to modify some of the things. So that is where we will work together with you and see how the system works. Then the drug supply. So you people are going to be here. The secretary will be there. Then other people are going to be there of importance. They can always help us in procurement of the drugs. Tenecteplase will have to be there in the EDL. We will be there for a short time. ICMR, this is a research project. लेकिन फाइनली तो आपको ही लेना है ना. तो आप लोग अभी से शुरू कर दोगे तो आसान हो जाएगा. जैसे आप कम्युनिटी अवेयरनेस कह रहे हो, पहले हम कह रहे हैं हेल्थ सिस्टम में टेनेक्टिवनेस तो इंट्रोड्यूस कर दीजिए. आपकी ईसीजी मशीन के लिए कोई टेक्नीशियन तो होने चाहिए. उसकी मेंटेनेंस कैसे होगी, डिफिब्रिलेटर्स कैसे प्रोवाइड किए जाएंगे और उनकी मेंटेनेंस की क्या स्कीम्स हैं. So we have to work on all those things before embarking into the community awareness program. I think the trainings will be provided. We will have trainers. We will train the trainers, and then the trainers will go into the hospitals. Suppose one person or two person from a CHC or district hospital they are trained. They have to train the entire work. This is something which we realize that this is not, you don't require a cardiologist, you don't require a physician only. A simple plain MBBS doctor has to be there. And that person, if he is willing, he can give the training to everyone else. You just do a ECG. Even a sister can be a part of the, nurse can be a part of the team. If they do an ECG and send it back on the group, and you get the consultation, out of the 10 patients which you have sent, for which you send the ECG, एक ECG में आ गया है कि STEMI है, you start the treatment. And for one, I don't think time का इतना मुश्किल होगा. You people have to build those systems. We can do only if you are willing to participate. I hope आप सारे करोगे. मैम तो कह रही है कि करेंगे. So youngsters भी कुछ कहें, बताएं. Is it doable or not? This is doable. This is a very simple model. We are not asking for PCI. That will be done later on. पहले उसका ब्लॉकेज तो खोलिए ना ताकि रिपरफ्यूजन हो जाए. रिपरफ्यूजन आगे उसकी ब्लॉकेज तो खुल जाए, हार्ट को मिलना शुरू हो जाए, अपना ऑक्सीजन वगैरह सब कुछ मिल जाए. So then send the patient to a higher facility. So that's a major goal. And if it happens in our families, we will be thankful for such a system. Thank you so much. Any questions?
Yeah,
Most welcome.
That was a nice concept. जो आपने कहा कि एक हैंड होल्डिंग बाय एक्सपर्ट्स, वो आप हमारे यंग डॉक्टर्स को बहुत बड़ा कॉन्फिडेंस बूस्ट करेगा कि आई एम इन टच विद द एक्सपर्ट, और जो उन्होंने मुझे सजेस्ट किया तो मैं वैसा ही कर रहा हूँ. आई एम नॉट डूइंग समथिंग रॉन्ग. वो एक हैंड होल्डिंग का कंसेप्ट हमारे लिए बहुत ही स्टेमी प्रोग्राम के लिए हेल्पफुल होगा. पहली बात. दूसरी बात की जो आपने कहा 4-5 साल उतना टाइम नहीं लगेगा। जो हमारे एमबीबीएस डॉक्टर्स हैं वो भी 4-6 महीने में 4-6 केसेस को हैंडल कर लेते हैं, तो उनको अच्छा कॉन्फिडेंस हो जाएगा, उनको एक अच्छा एक्सपीरियंस हो जाएगा, तो वो आगे भी प्रोग्राम को कैरी फॉरवर्ड करते रहेंगे। थर्डली की जो आपने कहा कि ट्रेनिंग सेशंस, वो हमारे लिए एक बहुत बड़ा बैकबोन होगा कि टीओटी अगर स्टेट लेवल पे होता है, फिर वहाँ पे डिस्ट्रिक्ट लेवल पे लोग आते हैं, डिस्ट्रिक्ट में हम लोग ट्रेनिंग सेशंस ऑर्गेनाइज करते हैं, जहाँ की वीडियोस रहेंगे और लिटरेचर्स रहेंगे, तो एक बहुत बड़ा एक प्लेटफॉर्म बनेगा ट्रेनिंग सेशंस के लिए, तो इसमें कोई ज़्यादा प्रॉब्लम आएगी नहीं। तो एज ए सीएमओ आई कैन मैनेज द थिंग्स कि टीओटी हो जाए स्टेट में, फिर डिस्ट्रिक्ट पे हो जाए। और जो आपने कहा ड्रग्स की अवेलेबिलिटी, वो हमारे लिए कोई ज़्यादा मेजर इशू होता नहीं है। जो आपके ड्रग्स होंगे वो लॉन्ग एक्सपायरी ड्रग्स होंगे, तो हम लोग इंडियन लेवल करवा लेंगे। लॉन्ग एक्सपायरी है तो छोटे छोटे अमाउंट में ही
हाँ जी हाँ जी।
तो स्टार्ट विद, तो वो जो थ्रोम्बोलिटिक ड्रग्स हैं या सपोर्टिव ड्रग्स हैं, वो स्मॉल क्वांटिटी में टू स्टार्ट विद हम अपने पास रख लेंगे। अगर ये लगेगा कि आप अच्छे खासे पेशेंट, क्योंकि अगर ये प्रोग्राम अच्छा चलता है तो इनपुट्स आएंगे, जब एक बार पब्लिक अवेयरनेस होगी, लोगों को कॉन्फिडेंस होगा कि ये ट्रीटमेंट हो रहा है, तो फिर ड्रग कंजम्पशन जैसे जैसे आगे बढ़ेगा तो हम लोग उस क्वांटिटी को रेज करेंगे। अदरवाइज स्टार्टिंग फेज में छोटे अमाउंट से हम लोग वो ड्रग्स अवेलेबिलिटी करा सकते हैं। एंड फाइनली जो आपने कहा मैम कि जो ईसीजी मशीन्स है, डिफिब्रिलेटर्स हैं, तो वो ज़्यादा बड़ा इशू हमारे लिए नहीं होगा, क्योंकि एक लाइफ सेव करने के लिए ये कोई बड़ा मेजर इशू नहीं होता है। तो उनकी अवेलेबिलिटी, उनका मेंटेनेंस, और जो उसके जो यूजेस हैं कि हाउ टू यूज दिस मशीन, हाउ टू रीड दिस मशीन, ईसीजी कैसे स्टडी करते हैं, वो सारा कुछ हम लोग एज ए सीएमओ वी कैन जॉली वेल मैनेज द थिंग्स जब ट्रेनिंग सेशंस हमारे हो जाएंगे, और आपके हैंड होल्डिंग से मैं बहुत सपोर्ट, तो आई एम लुकिंग फॉरवर्ड वेरी enthusiastically. It's a nice program. Thank you much.
Good to hear a positive comment. Very good. सिर्फ कोशिश तो करके देखते हैं ना, जो इश्यूज आएंगे तो वो तो उनको रिजॉल्व करेंगे। हाँ, और मुझे बिल्कुल सर मेरे कहने सबके पास एक्सपीरियंस है जिसमें 1 सीएचसी में नहीं किया था, तो ये we are used to making them now. बिल्कुल बिल्कुल आएंगे आएंगे आएंगे। हाँ,
We start with a few CSCs, then to go to PSCs, और अच्छा अगर परफॉर्मेंस होगा, नेटवर्क बढ़िया होगा, ट्रेनिंग अच्छी होगी, तो एडिशनल पीएससी पे जो हमारे एमबीबीएस डॉक्टर्स हैं वो भी, इनको भी अच्छा लगेगा कि वो डॉक्टर साहब वो कर ले रहे हैं तो हम भी कर सकते हैं। तो ये बहुत बढ़िया हमें अच्छा प्रोग्राम लग रहा है। आई एम वेरी थैंकफुल टू ICMR कि नया। थैंक यू मैम।
प्रिविलेज तो हमारा है कि आप सारे साथ में जुड़ोगे।
So, meanwhile, we would like to inform you that our chief guest, Mr. Parth Kafi Sen Sarma, he is the Honorable Principal Secretary Medical Health Department. He is here with us, so a round of applause for him. And along with that, our guest of honor, Dr. Vasant Kumar, and He is Executive Director, TSU Medical Health, and his team is here. So a lot of applause for them also. They are trying to, these people are trying to, the same project that Varanasi is leading, that should be there in whole UP. So we would like, again, loud applause for him and his team. So, and Dr. Sandeep Chaudhary, he is also here. He is our CMO Varanasi. Everybody knows him. He doesn't need introduction. And because of his immense efforts, always available to us for any need for this project and anything. So again, round of applause for Varanasi. And without delay, this program should go on because we are already pretty late. So I will invite next speaker, Professor S.K. Dwivedi sir. He is my teacher, he is my mentor, and I'm thankful that he is here as ICMR expert today. And he is Professor Head KGM Lucknow. He doesn't need introduction. He is Varanasi guy. Please welcome him with a round of applause. And he's talking on approach to chest pain and diagnosis MI. So this is very important lecture, and with a teacher like him, nobody can teach. So please ask whatever question you want to ask regarding the apprehension of your apprehension before the patient's apprehension. You can ask anything, and he's the master. Will answer your questions. So, chest pain, acute chest pain patient. I have already taken baseline data of 100 patients last 3 months, December, January, February, and we found that the ECG I got in our group, the MOs has sent, done the efforts to send from our spoke centers. The lacking part is that I have to ask that whatever the time, that window period, we call it window period, we call it time to first medical contact. That I have to ask. It should not be there. You have to recognize which is the most severe episode of pain. If the patient is having a stuttering in part, means it's going to happen. He may have little pain before 1 to 2 days before more pain. But most severe pain with perspiration. I am presenting one case today. Our faculty had MI at 6 a.m. and he is thrombolized at 8 a.m. Very interesting case. I will present somewhere whenever time permit. So most severe pain is the time where we have to count the zero. From there, the patient who came to first medical contact. That time is very important. Who is the medical person? If it is MBBS, it is his duty to recognize, do the ECG, get the ECG done, and recognize the MI if it is there. It is MI pain. You have to recognize what is MI pain. Sir is going to tell that. And if it is MI pain, suspected ACS pain, we can call it acute coronary syndrome. Then we have to be on toes that this patient to get the ECG done immediately, get the consultation done, teleconsultation done, decide regarding the MI is there or not, and then take the decision for thrombolysis. Checklist for thrombolysis we will provide. It's already shown in the first lecture. So, sir, please. Now slide is set. Thank you.
So, good morning, everyone. So I welcome everyone, analyst here, Principal Secretary Health, Mr. Vasant Kumar, my teacher. When I see my friends here sitting as Chief Medical Officers, I'm also seeing some students. I mean students of medicine who are although have their degree, but they still want to learn. और मैं यहाँ पे nurses को भी देख रहा हूँ जो यहाँ बहुत ही basic चीजें सीखने आई हैं. You are welcome all in this project of ICMR. So the aim is how to recognize that this chest pain is a serious one, and these are the list of causes. इतनी सारी वजहों से आपको chest pain हो सकता है. In fact, जितने structure इस जगह हैं, उन सबसे chest pain हो सकता है. From the rib cage to muscle to esophagus, gastrointestinal cause, lungs के cause, they all can cause chest pain. But if you see here, the most serious or life-threatening are these coronary artery disease, which may manifest as ST elevation MI, जिसके बारे में हम बात कर रहे हैं, या non-ST elevation MI, unstable angina, या स्टेबल एंजाइना. ये 4 कैटेगरीज में आपके पास पेशेंट मैनिफेस्ट करेंगे कॉर्निया आर्टरी डिजीज. वो ये चारों चेस्ट पेन से प्रेजेंट करेंगे. So there you have to differentiate the most sinister, which is going to kill you immediately within 24 hours or maybe earlier. So now, whenever you are assessing a pain, ये हमें बताया गया है that you go follow certain guidelines, and this is a mnemonic Socrates, name of a philosopher. Mnemonic SOCR, and S is for site, onset, character, area, association, symptoms, time duration. And we are talking about a chest pain. So when I would be here, so a chest pain in the area of chest, neck, arm can be a chest pain. But there are certain hard things which you can elicit in a patient, and you can say, yes, this is a chest pain, or you can say, no, this is not a chest pain. For example, chest pain related to coronary artery disease will be limited below the jaw and above the umbilicus. So if a pain is originating beyond these, let us say it starts here and then it is not cardiac. It has to be limited or be initiated in this area from the neck to epigastrium. If it is not initiated from there, it is unlikely. And it is not a point pain. If a person comes to you, यहाँ दर्द हो रहा है, आप पूछिए एक पॉइंट, पूछिए कहाँ दर्द हो रहा है. अगर वो एक पॉइंट पे बता दे रहा है ना, very unlikely. Person will say here. Ask him. A point pain is highly unlikely. Onset. A patient will not forget the onset of a chest pain. Episode of chest pain. Onset means ये दर्द कब से शुरू हुआ. वो नहीं सोचेगा कि याद नहीं आ रहा कब से शुरू हुआ ये दर्द. He will remember the onset for this duration of time. So if he forgets, classically what happens is दर्द हो रहा है सर 3-4 दिन से. अच्छा, the second question that you ask is, do you tend to forget your chest pain when you are busy? If the patient is able to forget his pain when he is working, this is not cardiac. Then character. We'll talk about this. Can be heaviness, crushing, pressure, burning, many things can it be, but highly unlikely as a piercing pain or a stabbing pain or a lancinating. No, they are not cardiac because those are pointing, pinpoint pains, pricks. No, they are not. They are not cardiac. Then radiation. If the pain is going to, let's say legs, no, it's not cardiac. Patient occasionally it goes here. No. So radiation will also be in a classical area under the arm, chest here, maybe epigastrium, maybe to the back, maybe to the shoulder, but not everywhere in the body. Then time duration is important. Patient comes, कुछ second के लिए दर्द, never cardiac. A cardiac pain has to be at least for a minute. When I am saying it can never, there is no must in medicine. Never means almost never. So it is almost never less than a minute. It has to be for some time. Similarly, if a pain is going on for days together, 5 दिन से दर्द, no, it's not cardiac. It's not cardiac. Cardiac means I'm talking about coronary artery disease. Exacerbation and relieving factors, probably they are the most important aspects. It is highly unlikely if it is associated with increase with arm movement or neck movement or lying down or taking breath. No. There are precipitating factors will be exertion, or mental stress, and relieving factor may be rest. But moving joints, if it is increasing, it is not cardiac. And then severity is disturbing. Generally, it is disturbing. Generally. One more thing is that patient may come to you, and that is very important, has been brought off late in the guidelines. Patient comes to you, sir, कभी यहाँ होता है दर्द, कभी यहाँ दर्द होता है, कभी no, they are not cardiac. A patient is entitled for a typical pain if he has a cardiac pain. That means he cannot have two or three kinds of pain. One is happening here, other is happening here, other is happening. No, this is not cardiac. So a person is entitled to have one kind of pain as a cardiac pain. And this is, we have seen that this is a classical kind which is persistent, crushing, going to neck, left shoulder blade, may go to the back of, and radiates classically here. If it is radiating on the outer aspect. So these are simple things which probably will be helpful for the nurses who are probably the first respondent. आप लोगों से सबसे पहले मरीज मिलता है, probably उनके लिए important है. This is the same thing. On this side, if the symptoms are here, if you are finding something in history here, high likelihood. If you are finding something here, very low likelihood. So a sharp, flitting, shifting, positional pain is non-cardiac, not related to coronary disease. And a central pressure, squeezing, gripping pain, heaviness, tightness, they are likely to be cardiac. And this is a gradation here. So this is a classical position of a patient when he comes as a chest pain. See, he's holding an area of chest, left hand. This has been described in textbook. Chest pain, sweating, anxious look, holding chest. And this sometimes the signs may be some other ones other than chest pain. They can be lightheadedness, jaw pain, discomfort or pain, I'm sure we discussed. Shortness of breath. He may present with acute onset or recent onset of breathlessness and then sweating. They all can be manifestations, particularly in extremes of age, or patients are having associated illnesses like diabetes or renal dysfunction. These patients tend to have an atypical type of presentation. Now, a word about sweating here. It is a sweating biorhythm, no. The sweating in heart attack has to be very severe. Sweating yahan hui, no, it's not that. It is anxiety. Sweating in heart attack, patient will not forget. Often they say, "Sir, itna sweating hui ki kapda nahi chhod sakte the." That is the kind of sweating that a patient will. So all sweatings are not the same. They are similar in sex, both sexes, except nausea or some unusual tiredness is prominent in female. We are talking about symptoms when it is not presenting as classical chest pain. And in elderly, half of the times, elderly means more than 75, half of the times they are chest pain classical is missing. They present as classically, not, in fact, I can't say classically because they present with fatigue or lightheadedness or breathlessness. सांस फूल रही है, थोड़ी देर में चल रहे हैं सांस फूल रही है या थोड़ा काम करते हैं बहुत पसीना आने लगा. These are the symptoms which can be there at the extremes of age. So they may be presentations of the chest pain. So this, on the basis of history, if a patient is presenting, you are lucky to have a patient who is presenting with chest pain, then 95%, more than 95% times, you will be able to diagnose that yes, this pain is because of or related to heart attack. That is for sure. Now, what happens actually, we know that ये ऊपर की healthy artery दिख रही है, इसमें पहले फैट या डिपोजिशन, कोलेस्ट्रॉल डिपोजिशन शुरू होता है, उसके बाद ये ऑब्स्ट्रक्ट कर देता है. And since heart is a working muscle, these are the arteries. If arteries are obstructing, it will cry for more blood. Now, if the obstruction is fixed means that it doesn't change. Then whenever at rest you may not be having a pain, but when you exert, you start having a cry of the heart. No, I'm not getting enough. That is what is angina. So if it is limited only to that, then it is all stable angina. But what happens is, sometimes, as Dr. Negi had said, कभी कभी ये जो narrowing है that ruptures and then there is a clot formation, thrombus formation, which may proceed and block the artery. Then the pain will come at rest, it will block the artery, and then you will start having continuous kind of pain. That is can be labeled as acute coronary syndrome, or let's say myocardial infarction. Infarction with nothing, infarction means death, myocardium means heart. So MI means death of some area of muscle. So we can broadly classify chest pain related to heart as stable angina. That means whenever he walks, he has a pain. At rest, he doesn't have a pain. Or acute coronary syndrome. That means something new has happened where chest pain is occurring at rest. It is lasting for more than 20 minutes, never for days, and then not relieved by rest or drugs. Then you have to be reason for to be worried. Why? Because stable angina is not killing you in a daytime or in a week's time. It's a stable disease. But when these things are there, when you are sitting in the OPD at village and you see that these are the situations, you have to be worried about it. So once a patient comes in outdoors, this can be that is how we can approach this. चेस्ट पेन करके पेशेंट आया, आपने अपनी हिस्ट्री लियो, कहा कि नहीं ये हार्ट से रिलेटेड नहीं है because of the history pointers, or you can say that this is a stable kind of a heart disease which is not going to cause immediate risk. This is one possibility. First possibility is not cardiac, or second possibility it is cardiac but stable. Or else you can say that this is acute coronary syndrome by history. You have made a diagnosis of acute coronary syndrome by history. Now do the ECG. Then you look for only two things. Go for ST segments. My medical friends may be knowing. Go for ST segments. If there is ST segment elevation or not, and if it is ST segment elevation, that is the business we are connected here. That there you have to proceed straight away and be talking later on thrombolysis or whatever. When it is not ST segment elevation, then you would like to see whether there is a myocardial damage or not. What it means? It means that if there is a ST segment elevation, that is very clear indication two things. One is the artery is blocked. You don't need any further test and you act. And second thing, it is dangerous. Artery is blocked and it is dangerous. When ST segment is not changed, then you have to find out whether he has had a heart attack that is permanent damage or not. And that can be decided by troponin. Troponin is a enzyme which is released by myocardial death, irrespective of the cause. We'll come to that. It is only telling you the. So when you say about ST acute coronary syndrome, it is not a stable coronary artery disease. It is acute coronary syndrome. Then it can be ST elevation or non-ST elevation. Both are MIs diagnosed by enzyme elevations. And unstable angina, there is no enzyme elevation. That means there is no myocardial damage. Troponins are a gold standard to make a diagnosis of myocardium. If you don't have elevation, if you don't document elevation of troponin, then you cannot say it is MI. However, there is a rider in which I have already said. Once you find the ST segment elevation in ECG, there you need not wait for troponin reports. You go ahead and thrombolyze because in all likelihood, this is going to be a heart attack. And madam was talking regarding some patients where unnecessarily some patients are given unnecessarily. If some patient is given a therapy, that means you are not missing. That means you are not missing those patients. If you there are certain patients, all patients, if they turn out to be MI, that means you are missing patients out there in population. But if you are finding some normals in ST elevation, that means your approach is more likely to be inclusive of all patients in population. And that is what happens in any kind of disease. So for troponin, you will not wait for troponins in ST elevation MI. It is only in patient when there is no ST elevation MI, would you like to differentiate whether there has been myocardial damage or not? So if troponin is normal, it is unstable angina. If it is raised, non-ST elevation or ST elevation. And we are worried about this myocardial infarction thing. Now, changes in the MI, we have covered about how to diagnose by history. Now we are coming to for the diagnosis with ECG. With ECG, MI can be non-ST elevation or ST elevation. Why? Because ECG changes, MI can involve all aspects of ECG. It can present with ST segment depression, it can present with elevation, it can involve only T waves. What is the hallmark is enzyme elevation. So remember that ECG may be normal also. So if a patient comes with classical chest pain, which you think is cardiac, and ECG is normal, doesn't mean send him home, get an enzyme down. Now changes in STT, in ischemia and infarction are so varied that one cannot go only for ECG and one cannot go only for chest pain. So it's a combination of these two. ECG has to be interpreted in the background of the clinical history. And this is how you know that my medical colleagues would be knowing these are various kinds of ST segment depression, and this one is the most dangerous where it is downsloping. You can see here in lead V5 and V6 marked downslope ST segment depression. Now, this non-ST elevation in MI is again important. There can be simply T inversions, particularly in chest lead V1, V2, V3, that can tell you infarction if it is associated with enzyme rise. But what you are bothered about is this. This is showing a classical ST segment elevation in V2 and V3. Chest pain is there. This kind of ECG is there. Then you go for thrombolysis. Now, this is a hallmark of total, not only occlusion, but total thrombotic occlusion of the artery, which is amenable to a thrombolytic agent. Now, when to diagnose that is MI, there has been certain criteria. This simplification. ST elevation in two contiguous leads. Contiguous leads, I think you understand, lead 1 and AVL, V1 to V4, lead 2, 3 AVF. Then in V2, V3, it has to be more than 0.2 in men, more than 1.5 in women. These have been recent guidelines, 2008. In all the leads, it is 0.1 millivolt, that is 1 millimeter. 0.1 millivolt will be 8 millimeter. And then you can choose the location also. Then stages of ST segment elevation, MI. In earlier stages, there may be only tall D waves, no ST segment. There you may miss, and there may be marked overlap present. For example, see here, this is 10 minutes ECG of a patient. See, only T waves are tall. I think might be difficult for nurses to understand, but my medical colleagues would know. See the peaked tall T waves. See what happens. ST segment is elevated here. T is still upright, but there is no Q. This may occur from minutes to a couple of hours. When the infarct sets in, then you start having Q waves. So where should you think that the patient has to be receiving streptokinase or thrombolytic? Probably at this point, but you were not able to diagnose. But if you repeat the ECG, you will certainly diagnose. So a single ECG in a patient who is not having classical presentation who is having a typical presentation, but ECG is normal, it is not enough to rule it out. You will miss some patients. This is what happens in few hours. Q has come, then T becomes deeply inverted, and then ST segment becomes isoelectric. So this tells you something else also. That if you see that ST has settled, T is inverted, they're likely to be a old MI. And this time chest pain is not that acute MI pain, but 5 days back pain was MI when he had that episode. You may not thrombolize. So this is how the ECG has to be. Repeat ECGs are important if the present ECG is not diagnostic. So this is simple approach. ECG, chest pain, history, you made a diagnosis of cardiac pain. ECG, ST elevation MI, and this is the limb that you want. Coming to troponins, troponins is the next phase, which may not, which is one has to understand. They're not the part of this phase, but you must know troponins. Troponins or LDH or CKMB are the enzymes which are released, but troponin now has become the gold standard. So don't go or don't ask for any other test. It starts elevating. Here is the upper limit of normal, and this is the days after. You can see it starts rising in the early hours, and a classical rise or fall. It is not the same level, but the classical rise and fall are what are required for diagnosis of myocardial damage. One thing is that if a patient has had chest pain, is showing ECG changes, and at 10 hours, you're not sure. You're not sure whether he is classical pain or not. If troponin at 10 or 12 hours is normal, it is highly unlikely to be an infarction. This can still be an angina, but there has not been any myocardial damage. So when do you say that it is infarction? Either the patient has classical ST segment elevation with symptom, then enzyme is not required. But if it is not there, I'm talking about diagnosis of myocardial infarction rather than diagnosis of ST elevation MI. So for diagnosis of any kind of myocardial infarction, rise and fall of troponin T values with at least one of the following: symptoms of myocardial ischemia, new ischemic ECG changes, development of pathological Q waves, imaging evidences, which probably is not available everywhere, and identification of thrombus by intravascular ultrasound. These last two may not be important, but upper three are any of these criteria present with enzyme rise tells you that it is infarction. However, there has to be a classical rise and fall. Why? Because there it only tells you the damage. Now that damage of myocardium can be because of heart failure also can be present. In renal failure, the excretion is delayed. In septicemia, there may be myocardial damage. In any hypotension, there may be myocardial damage. So myocarditis can have a myocardial damage. So if there is a persistent or non-changing troponin T, it is not cardiac. It is not related to myocardial ischemia. There is often a huge problem with everywhere in ICU. Troponin is done, troponin is elevated, reference to the doctor. No, it's not that. Look at the background. If it is background other than cardiac, then troponin is not to be given importance, because troponin doesn't say that I am because of heart attack. Troponin tells I am coming from heart, but I am not because of heart attack. That you have to decide. So there are various causes, even in severe arrhythmias, it can happen, coronary artery spasm, after bypass surgery, PTC, shock, all things can happen. So to conclude, in patients of chest pain, a careful history, ruling out certain things will invariably lead you to a diagnosis of coronary artery disease as a cause when the chest pain is a presenting feature. And then in a suspected cardiac pain, ECG may identify a subset of patients who may be immediately benefited by thrombolysis. How? When you recognize the ST segment elevation, which for me firstly is because of the thrombus formation. And this may identify a high risk group which can be benefited to save his life. Thank you very much for your attention. I'm sorry I think I went a bit longer, but the purpose was to stress on how to recognize by history. Any questions relating to this?
Thank you, sir, for enlightening us. Yeah. There are questions for sir, so please stay.
Yes. Yes.
Especially from the back side.
And I would have expected questions not from the chief medical officer, but from my medical officers there. Either the things are absolutely clear to you, or you have absolutely nothing is clear to you. There are no questions.
Questions from the nurses, please. Yeah, the
See,
medical officers.
आप पूछना चाह रहे थे कुछ?
I have a question.
अगर ऐसी एलिवेशन एमआई नहीं है सर, तो प्रॉपर्टी कितने समय बाद कराना चाहिए?
आपने कहा
अपना इंट्रोडक्शन प्लीज फर्स्ट इंट्रोड्यूस योरसेल्फ एवरीबॉडी
सर मैं सर डॉक्टर मनीष यादव फिजिशियन सर लेडी। तो सर ऐसी एलिवेशन एमआई नहीं है, और हम ये कितने समय बाद हमें लगा ये एसीएस का पेशेंट या एनएसटीएमआई में, तो
डॉक्टर मनीष
कितने समय बाद कराना चाहिए? जब हम कहते हैं कि प्रॉपर्टी करा लेते हैं, हम वीडियो आता है तो आप MI नहीं, और कितने समय तक पॉजिटिव आता है और कितने समय बाद
Correct. Correct. Dr. Manish, so troponin will start rising immediately, but it will come in the detectable range beyond 2 hours. Now, if it is because of non-ST elevation MI, it will have an increasing trend. So guideline तो अब ये कहती है कि 2 घंटे पे कराइए, 3 घंटे पे, 4 घंटे पे करा लीजिए. बढ़ता हुआ ट्रेंड आ गया तो बनाइए. या आपका सवाल है कि कब तक हम I hope you understand. Increasing trend. First value can be as early as 2 hours, not earlier than that. Then repeat one if it is normal. अगर यही 2 घंटे पे ही classically elevated है और background है तो भी बन जाएगा. लेकिन 12 घंटे के अंदर तक अगर नेगेटिव है आपका, अपर लिमिट नॉर्मल नहीं आया, तो आप कह सकते हैं कि नॉन एस्टी एलिवेशन MI नहीं है. ट्रोपोनिन जब बढ़ेगा तो इट कैन रिमेन रिजन फॉर 7 to 10 days. But what will happen after 2-3 days? It will start falling. So 7th day will be more, 10th day will be lesser. So that's a classical fall trend.
पेशेंट है चेस्ट पेन का है, गांव से MI का वो 2 दिन से चेस्ट पेन हो रहा है, हमने देखा ICD कराया,
ट्रोपोनिन अगर नॉर्मल है तो MI नहीं हुआ.
तो हम 2 घंटे मतलब 2 दिन पहले पेन हो रहा था, तो
2 दिन पहले वाला पेन अगर हुआ है MI वाला, आज कराएंगे तो पॉजिटिव मिलेगा. 12 घंटे के बाद नेगेटिव मिल रहा है 7 दिन तक, तो वो नहीं है.
आप 7 डेज तक करा सकते हैं, तो 8वें दिन के बाद तो नेगेटिव वाले से मतलब नहीं कि उसके MI नहीं.
सही, करेक्ट.
Because sir, I have already worked in cardiac sector earlier. So what causes of false troponin hypothesis? What causes of false troponin hypothesis?
So now,
because several times it comes in false night during my clinical practice, I've seen that many times troponin night comes false positive.
let me tell you. So troponin has a sensitivity of 98-99%. That means it will pick all myocardial damages, and it is 90-99% specific. That means it will not be falsely positive. So what we call as false positive is because of simple understanding that any cause which may have some myocardial damage will raise the troponins. A patient of pneumonitis may have troponin rise. A patient of hypotension because of any reason can have. Those are level. That was a long list. Arrhythmia, let's say if there is supraventricular arrhythmia, I've seen angiograms being done for classic supraventricular arrhythmia at my own center because my colleague is not convinced. Bradycard, so many things. So those are labeled as false elevations. For troponin T, now there is a, once a compound is released, it has to be excreted also. Troponin T is released by renal. So if renal dysfunction is there, it will continue to be elevated, not with troponin I.
तो सर एक क्वेश्चन है सर, प्रोटीन आई है तो क्वांटिटेटिव या क्वालिटेटिव कौन सा बेस्ट होगा अगर करना चाहते हैं?
When we talk of qualitative, what does qualitative mean? क्वालिटेटिव का मतलब समझिए. क्वालिटेटिव का मतलब होता है कि एक सर्टेन लेवल के ऊपर है वो. That is a qualitative. So if the positivity is 0.015, अगर वो एक पॉजिटिविटी है 0.1, तो 0.1 के ऊपर एक आपकी लाइन आ जाएगी. तो लाइन होना ये बताता है कि आपकी वैल्यू 0.1 से ऊपर है. लेकिन आप अगर क्वालिटेटिव करेंगे तो आपको ये तो पता लग जाएगा कि 0.1 से ऊपर है, कितना ऊपर है नहीं पता लगेगा. लेकिन ये एडवांटेज क्या है, बेड साइड होगा, खट से होगा ये. लेकिन 0.1 से 0.015 वाले मिस करेंगे, ये होगा क्वांटिटेटिव. तो क्वांटिटी टेल्स यू अबाउट द एक्सटेंट ऑफ इंफार्क्शन. हायर द क्वांटिटी, बिगर इज द इंफार्क्ट. एंड एडवांटेज ये है. और क्वालिटेटिव का एडवांटेज ये है कि रैपिड बेड साइड 5 minutes.
I want to add one point more in this, that in this program, this is not mandatory.
Definitely.
We are going to thrombolyze STEMI patients on the basis of PCG only. Only and only PCG in background of typical chest pain of MI.
Yes. That is the importance.
That
you
message
don't,
should not
ST
confuse.
segment elevation tells you that you have to thrombolyze. It is totally occluded artery. That is the, but what will you do to the patients who are not coming with ST elevation? You will manage them.
Yeah, so in that case, troponin can be done when we have time. When ST elevations are typical, not there, we are waiting for the ECG changes
No.
to come. We are repeating the ECG 1 hourly 2-3 times. When in meanwhile, if the facility is available, allows, then we can go for the troponins. And troponins are not 100% of MI only. They have long list, 1-page list where troponin can be reached. So you don't go for that only.
Not at all.
But
Not
it
at
is
all.
one of the criteria in diagnosis of MI in definition. One of the criteria, but 2 criteria are fulfilled out of 3, that ECG and chest
Sir,
pain,
my question.
then we can go for.
Sir, my question is, sir, ST segment elevation contour is also important. We are in remote area and we are just seeing ST segment elevation. So contour is also important. Which type of contour, whether it is concave or convex, ST segment elevation.
So don't go by that. Just remember that at least 2 contiguous leads
So
and it is elevated.
important, sir.
Huh?
Contour is not important. Which type of
Contour is dependent upon time. You have seen that it may be concave when you are picking it up in early hours. It will be convex when you will be going beyond few hours. But ST segment elevation will remain ST segment elevation. You may repeat a ECG to see evolution of changes, but don't base your diagnosis of ST elevation MI on the basis of contour.
So firstly, it is concave, then it will be convex.
Yes. But don't go by that. You just limit yourself to ST segment
Sir, I
elevation.
want to add that it is dynamic change. It's dynamic change. If the LVH is causing ST elevation, typical of that strain pattern, then that will not be dynamic. Dynamic is very important in this. If this change is going in serial ECGs, if you are confused, in the background of chest pain, typical chest pain, just 2 things are yaad karna. Typical chest pain, sir has described, sir has emphasized, sir has given the one graph in which the typical chest pain on left side, the lot of features were there. All this slide I will share. Your numbers are there. You can go through. Don't worry. So typical chest pain with ECG changes, ST elevation, which is dynamic. If you are confused, you can repeat the ECG half an hour, 1 hour. And we are there in this project. We are there 24/7. Our team is there. We are thankful to our co-PIs. Dr. Somik was here in the morning, and we all are there on live. And ICMR experts, Dr. Dwivedi sir and Negi sir has consented that we can add them also if they are available. So whosoever is available, and our numbers are there, and my number is there. Anytime you can call me. My number is on 24/7, 365 days. My patient are calling, and I am attending. Nobody can tell that I have not answered a single. I called back also whenever I am. So यदि मेरा फोन थोड़ी देर के लिए ऑफ होता है तो मुझे बुखार है, तो कि पता नहीं कौन बन रहा होगा, कौन कॉल कर रहा होगा. So I am there as a principal investigator for Varanasi, and for this project, which is going in Varanasi with my spokes and CMO sir, all other people, I am thankful that you people came all the way from different parts of UP, and it's all efforts of our CMO sir and the team. So now, without delay, we are already left out of time. I will invite PC Negi sir. He is Professor PC Negi from Professor Head Department of Cardiology, IGMC Simla. He is icon in this whole project, and he has given the example. That project was initially started 3 years back, and he was able to initiate it because he was already working on the similar model previously before starting of this project. So he started and already completed this. His experience are very helpful for us. So please listen carefully how he had implemented it successfully without FN, but without any medical legal issues, without anything. So forget about apprehension, remove that apprehension from your mind, and please listen to his experience, how we can go ahead with this. It's a simple mathematical thing. Chest pain with ECG by ST elevation, which is dynamic. Forget about everything. Chest pain should be typical within window period where we can formalize. So we are there for discussion and give you hand holding initially, and then और मैं ये प्रोग्राम में करता रहूंगा. every quarterly we will be there and gathering together, and everybody is welcome again. So and the other people who left on duties, so we will welcome them again, and we will re-emphasize. We will again and again get together and do the same thing. Online we are already welcome. Anytime we can connect and have meetings. CMO sir is always available. वो तुरंत मीटिंग सेट कर देते हैं और हम लोग डिस्कस भी कर लेते हैं. So it's very good thing. Please sir. Slides are set. So welcome Dr. PC Reddy sir, his experiences.
Thank you, Professor Dhirendra Jain. Good morning to all of you. I am going to share our experience of implementing the 7-spoke model of STEMI care in state of Himachal Pradesh in the district Shimla. Has already been emphasized that acute coronary syndrome is one of the commonest cause of mortality globally, even in the developing countries. And you have also now understood that ACS, acute coronary syndrome, has two forms, mostly STEMI and non-STEMI. What we are basically talking about today is STEMI primarily because it is basically a result of complete occlusion of the coronary arteries because of atherothrombosis. And thrombus forms an important cause for underlying sudden cessation of the blood flow, and where the need for lysing this thrombus, the clot, and restoration of the coronary flow becomes an important to decrease the mortality as well as the long-term complications. So if you see the pattern of acute coronary syndrome globally, we find that the STEMI is the commonest form of acute coronary syndrome in low-income countries like ours. While in the Western world, it is the non-STEMI which is more common. So our patients are younger. We have seen mostly these are basically people who smoke. Young people who smoke are at a high risk of STEMI. So therefore, I think it is an important message that not only treating STEMI, we need to think about the prevention of acute coronary syndrome, where smoking forms a very important predisposing factor, preventable predisposing factor for these dreaded conditions. So, morning, I think it has been already highlighted that we have primarily two forms of restoring the blood flow. One is the drug-based, which is the thrombolytic therapy, which we are talking about. Second is the percutaneous coronary intervention, which needs skilled manpower, logistics, where access is limited to only a very small percentage of patients, which is not practically possible to advocate as a program when we are thinking of implementing the STEMI care model in the state. So the third one is a pharmacoinvasive approach where you thrombolize the patient, which is feasible at every setup, restore the perfusion, then do angiography and address the residual obstruction, which is a pharmacoinvasive the approach. And the study shows that the pharmacoinvasive is as good as doing primary PCI. So in our setup, I would think that we should focus on how early we should thrombolize the patient and then shift the patient to the tertiary care center where you have a facility for angiography and angioplasty within 3 to 24 hours, at least in high-risk patients. The guidelines recommend that all patients should be taken for angiography after thrombolysis, which I think probably in our country with a huge population, with limited resources, if you have to optimally utilize your resources, we need to do a risk stratification, identify high-risk patients, and do angiography and angioplasty in these high-risk patients also who are at a high risk of mortality as well as the adults. So, a real question is how we can ensure that the patients are diagnosed early, receive thrombolytic therapy in eligible population, where our 80% of the population lives in the rural areas. And these hospitals where the diagnostic facilities are available, treatment is available, these are mostly situated in the bigger cities as well as the major towns. So traveling also takes time. Patients, generally there is a delay in the patient level, as has been already emphasized, that patients are not aware of symptoms of heart attack. So there is a need for extensive campaign mode, repeated sustainable fashion, sensitization about the symptoms of heart attack in the community using your healthcare networking, like starting from the community side, you have the sub-centers, wellness centers, primary healthcare centers. These centers are probably their services should be leveraged to disseminate this message in the community about the symptoms, as well as importance of reporting hospitals where the diagnostic facilities are available, because we have seen in our state that one of the reasons for delayed report was basically the patient initially took consultation at the small clinics, maybe PSCs, and so the precious time is lost, because each center it takes time to attend to the patient, do ECG. Sometimes ECG may not be available. Some patients are discharged back home thinking these could be because of the gastric, and they receive the IV pantoprazole and patient is taken back home. And we have seen the next day patients coming back again with the same symptoms with more complications. So the crucial time period is basically lost. So therefore, we need to strengthen these peripheral health centers, starting from CSCs, civil hospital. In our state, we call it as a civil hospital. You have a district hospital, you have a subdivisional hospital also, which I learned yesterday, because in our state we have PSC, CSC, civil hospital, and a district hospital. So these centers should be developed as a spoke centers, because these are the centers which are closer to the community. And if community is sensitized, people are likely to visit to these hospitals. And if you have a facility for diagnosis and treatment available, I'm sure people will definitely visit to these hospitals, and you can provide the time-sensitive treatment which has been discussed in the morning early. And then you refer the patients to the tertiary care center where you have a facility for further evaluation. So we have number of registry studies in our country, like we have a CREATE registry, which was done in 50 cities in the country, in a different regions, south, north, east, west, and central India. Huge number of patients. We had Kerala, from the Kerala state. We have a registry from Kerala state to Kerala ACS registry. We also did in our state about 10 years back, integrating all the hospitals where patients are generally treated and basically at least investigated, mostly the district hospital at that point of time. All these registries basically show that there's a lot of time delay from symptoms to reporting hospital. This we call it as a pre-hospital delay, which was in the range of almost 6 hours to almost 13 hours. In our state, it was almost 13 hours because of hilly terrain, longer traveling time, patient level delay. These were the reasons why the thrombolytic therapy, which was used at that point of time, was only 35% in our center, generally varying from 40 to 50% center. So you can see in the whole state, I mean, in country level, the use of reperfusion therapy or thrombolytic therapy or PCI is very, very suboptimal. Only roughly around 40 to 50% patients are getting the treatment, which may be worse in certain states where we do not have any data. So therefore, hub and spoke model of care is the solution to this problem, and in order to optimize the reperfusion therapy. So we basically, I'm going to now share with you our experience of implementing this project, what challenges we got, and whether it has translated into improvement in the survival, and whether it has led to some increase in the thrombolysis rate in our state. So we implemented this in the district Shimla, which has a population of around 80 lakhs. And so in this, basically, what we have done is basically that I'll just briefly give you the background of the model of the hub and spoke model of STEMI here. Basically, as I said, you need to identify the spoke centers, training of these centers, provide the logistic support. In the logistic support, you need to have an ECG machine for diagnosis, and you need to provide the drugs, TNK, and the other drugs which we discussed in the morning, adjunctive drugs like antiplatelets and heparin, etc. You need to have a monitoring facilities, like because small percentage of patients do definitely get problems, serious problems, which needs immediate attention like defibrillation. So ideally, all these spoke center must have a defibrillator, ECG monitor, at least during the acute treatment which we are giving, because sudden cardiac death is more common in the initial part after the acute coronary syndrome. So every spoke center must have a monitoring ECG monitor as well as the defibrillator. Then we should ensure that safe transfer of patients through the ambulance services to the tertiary care center. Because during transfer also, sometimes again you can have a problem related to arrhythmias. Patient can have a sudden cardiac death. You need to have, ideally, in ambulance services, you need to have monitors, and this monitoring signal should be attached to the hub center, so that during the transportation, you are constantly monitoring the patients for any arrhythmias. And the people who provide the emergency ambulance services should be trained to give defibrillation under the supervision of the the experts from the hub center. So, as I said, we have started implementing the hub-and-spoke model in March 2020 till date. Almost in last 3 years, we have thrombolized a substantial proportion of patients. And basically, it was a part of ICMR project. So we had one project coordinator coordinating the implementation of the STEMI, the model in the district. And all our faculty members in the Department of Cardiology, RDM students were as expert members available round the clock for providing the teleconsultation, because many times somebody may be busy. So whosoever is available during the time when we receive the consultation, he is there to provide the interpretation of the ECG as well as the clinical based on clinical details. Sometimes ECG tracing may not be clear, clinical details may not be clear, plus minus cases are there. We ask the patients to repeat the ECG and provide certain additional clinical information through the WhatsApp itself. So based on that, we basically this is how we our model is in terms of assessing ascertaining the cases of STEMI. So this is basically a geographical representation of the distribution of the spoke centers in our district. Each block we have at least one spoke center, be it a CSE or civil hospitals, and this bigger red star is the Medical College Shimla. So this is located in the other corner of the district. You imagine if every patient has to come to the IGMC Shimla for treatment, such a long traveling time, the precious time is lost. So therefore, it is very important that you need to identify the hospitals in the peripheral, at least at the block level, train them so that the traveling time can be decreased and ischemic time can be decreased, and more patients are eligible for thrombolysis, because the benefits of thrombolysis is most when you give early. The guidelines basically recommend that up to 12 hours you should thrombolyze a patient after the onset of chest pain. But in a select group of patients who are continue to have chest pain, even if they have reported 12 hours later, up to 24 hours also you can thrombolyze the patient. So objective of this project was basically if you can strengthen these peripheral hospitals through training, providing logistic support, and 24-hour access to the teleconsultation services, can we increase the thrombolysis rate? Does it translate into decrease in mortality during hospital stay as well as for the 1 year? We, after discharge, giving the initial treatment, and patients are followed sequentially at 1 month, 3 months, 6 months, and 1 year. Now we have data of one year also. How do they do if they are treated in the peripheral hospitals vis-a-vis when they directly reported to the medical college and they are treated in the IMC as in the hub center. So as a part of project, initial 3 months were basically to capture what is the existing practices in the district, means whether the patients of acute coronary syndromes are being diagnosed, detected, how they are being treated. So it's basically from April to July, we collected the baseline data of these spoke centers, and through the WhatsApp group, we have basically at the beginning of the project, we made a WhatsApp group, as I told you, where all the medical officers who are working in these spoke centers were members. The experts, the cardiologists and RDM students were the expert groups in the WhatsApp group. We asked them to report any patient with chest pain, whatever treatment you have given, whatever diagnosis you have given, must share in the group. And patients were then transferred to the IMC. So subsequent follow-up and data collection was done in the IMC, in the medical college. So we have a data of that patient, and we also meantime developed the IC materials. We have developed the ACS manual for the doctors, giving some understanding about the STEMI. It's the how they manifest, what are the complications, how do you diagnose, how do you treat, what has been discussed so far in the morning. It is given in the ACS manual which we have developed for the doctors. So during this time, we also developed this electronic health recording format also, and where the data was basically collected. So pre-intervention phase, as I said, it involves basically detection and the collection of the data of the patients who have been thrombolyzed or not thrombolyzed, then refer the patients, and detailed data was collected in the medical college itself. In the post-intervention, after the 3 months are over, then we started doing the capacity building in terms of training. And we provided the ECG machines to the hospital where they did not have any ECG machines as a part of the project which we had received the funds. We purchased the TNK injections distributed to these spoke centers, and we organized the training program. As was highlighted in the morning, the need for the training program is very, very important for implementation of this kind of STEMI care program. So unfortunately, the COVID started in the May, June of 2020. So initial 1 or 2 batches, we did training for 1 week in the medical college, but subsequently because of COVID, we had to stop this. And 2-3 months later, then we took the online format of training of these medical officers. Then we had a series of weekly lectures covering the different aspects of acute coronary syndrome. And subsequently, we asked the doctors working in these spoke centers to make a presentation of the patient which they had seen week before. And in the whole group, then there used to be discussion as to what they thought initially was patient was having, whether it was STEMI or not, how do they interpret the ECGs. So that way, it basically generated a lot of interest amongst the medical officers also as a part of training. So this is how we basically did the training of these healthcare providers working in these spoke centers. So secondly, side by side, we also initiated the intervention for community sensitization because we realized that the pre-hospital delay was definitely one of the important barriers in optimization of the use of thrombolytic therapy. So we did basically prepare the IC material for the healthcare providers, ASHA workers, and general public in the form of the posters, pamphlets, booklets, and we also took the help of social media. And we have basically our IMC Heart Tech Facebook page we have where we put all these IC related material in our Facebook page. And we also recorded the video clips narrating the symptoms and importance of timely reporting to the hospital, which hospital they should report. And through this video message, we circulated in various WhatsApp groups, trying to reach to the general public as much as possible. We took the help of the electronic media also, through the Doordarshan station of Shimla, All India Radio also. We conducted the press conference, trying to, bring it this in the various local newspapers. We had a series of Zoom meeting with the Panchayati Raj institutions also. We discussed with the Deputy Commissioner of this district, and we are requested the Deputy Commissioner to direct all the block level, the block development officers to cooperate with us in organizing some kind of stakeholders meeting with the Panchayati Raj institution representative, health workers, and other the stakeholders in the block. And one of us personally basically had a lecture and interactive session with these people at each blocks so that general public is made aware about the availability of these services and symptoms of acute coronary syndrome and need for early shift to the hospital. So these were basically the IC material which we had generated, like posters, pamphlets, and booklets. And this is the manual which we have prepared for our medical officers. And so based on this, the model of the basically modus operandi was any patient who reported to these spoke centers, the attending doctors first initially assessed the patient clinically, did the ECG, shared the detail in the WhatsApp group, and received the consultation from the experts. And if it turned out to be STEMI patient, and if had no contraindication, patient was thrombolized. And 1 hour later, repeat ECG was done to see whether it has been successful or not. And irrespective of whether the thrombolytic therapy was successful or not successful, patient was then transferred to the medical college through the ambulance services. So now just to share with the results, initial 3 months, we had captured, and basically these spoke centers had detected 29 patients in the 3 months time. And when we compare the data of subsequent 3 years, from August to 2020 to October almost 2022, 255 patients were enrolled at these spoke centers. If you see the demographic characteristics of these patient population before and after was almost identical, same holds true for the cardiovascular risk factors. Now, the most important thing to see is that basically symptoms of thrombolysis rate was significantly higher in pre-intervention period compared to the post-intervention period, which was median delay of 542 minutes, and post-intervention it decreased to 230. So this decrease was primarily because of the community education and education of the healthcare provider at the system level. So the system level delays also decreased. And you see the thrombolysis rate before intervention was just 27% patients were receiving thrombolytic therapy, which increased to almost 65% after the intervention. So this hub and spoke model of care is definitely feasible, and it helps in improving the thrombolysis rate and decreases the ischemic period. And if you see the outcomes, this was basically the comparing the data of patients who were enrolled in the spoke center vis-a-vis with the hub center. People who came directly to medical college, almost 50% patients. So 50% patients were treated in the peripheral hospitals, and remaining 50% patients were treated in the hub center. And if you see again the time delay from the symptoms of thrombolysis was median delay was 230 in the spoke center, which was significantly higher in the hub center. So this model definitely decreases the time lapsed from the symptoms to the delivery of the thrombolytic therapy. And if you see the thrombolysis rate also was higher in patients who were treated in the spoke centers compared to the hub centers. This shows you basically the trends of mortality. The blue basically means mortality rate seen in patients who were treated in spoke center compared to red bar, which basically shows the mortality rate in the patients who were treated in the hub center, which was significantly low, almost 50% reduction in mortality. This is definite. This basically shows the value of translational research. What you know, if you are able to implement, this definitely does translates into improvement in the outcome. So during this course, we had encountered certain challenges. One was the non-availability of the TNK in the initial part of the project. And few centers showed hesitation in starting the thrombolytic therapy. As was morning, it was expressed that many doctors may not be confident in, patients themselves may not feel confident in getting the thrombolytic therapy in these spoke centers. So we had to talk personally with the relatives of the patients, explaining to them that if you receive this treatment at this point of time, you are likely to be benefited more compared to if you wait and come to the IGMC and lose 2-3 hours of travel, then your heart is going to damage further, and maybe a complication may arise. So with this kind of video calling, with directly talking to the patients by the experts, it helped in pursuing the patients to receive the thrombolytic therapy. So non-availability of technician was also one of the problems in the emergency hours. So it was basically resorted by training all the available healthcare providers, be it the nursing staff, the doctor itself, maybe pharmacist. So this we have been able to manage. We have never come across any incidents where a patient came in the odd hour and ECG was not done because of the lack of the technician. So that problem has been sorted out. So except for one, the spoke center where the medical officers, they were not very confident in starting the thrombolytic therapy. We called the nodal officer to the hub center, and he worked, hands-on experience was given for 1 week. And when he saw how the TNK is being implemented, what are the potential complications, when he's witnessed himself that it definitely helps in relieving the pain, improving ECG changes. So people were then encouraged and feel confident in starting the thrombolytic therapy, and it was started subsequently. So all our spoke centers now, medical officers, these are basically MBBS medical officers, are confident in initiating giving the thrombolytic therapy, but under the guidance of the experts. So they still require the teleconsultation support system for diagnosis. They cannot make diagnosis on their own, take a decision. So this is basically provided by ensuring access to teleconsultation services 24/7. To summarize, I would say hub and spoke model of STEMI care is feasible model. It is effective in reducing the ischemic time, improves thrombolysis rate, and reduces the mortality by almost 50%. So therefore, I would encourage, I think I'm happy to see Secretary Health is there. It basically speaks volumes that how the state government is committed to initiate this hub and spoke model. And definitely it is implementable. You need basic minimum logistics. And I would request that all these spoke centers which are mapped must be provided with the drugs, diagnostics, and monitoring facilities, and ensure the safe transfer of patients through the ambulance services. And I'm sure it is doable. and it definitely does help in decreasing the mortality. Thank you very much for your time. As a part of project, actually, it was basically envisaged in the beginning that is a protocol that we need to at least establish, document what are the prevailing practices in treating patients with STEMI. So it was decided that initial 3 months or first 100 consecutive patients, we will record the data and see what percentage of patients were diagnosed as STEMI and what percentage of patients are already being thrombolized or not. So after having visited a couple of centers yesterday, I realized that practically it is not being done even in the divisional district hospitals where you have all the facilities. Compared to UP, I would say Himachal, we do not have that kind of facility in space. So it is doable. So what we can do is basically do a kind of a survey study. In preceding 3 months, how many patients of chest pain you have seen? How many STEMI you have diagnosed? Did you thrombolize the patient? So this is basically baseline status. You need not wait for 3 months for to collect the data as to what is the practice pattern. So you can straight away start.
थ्रोम्बोलिसिस तो जीरो होगा, पर आपके ईसीजी भी करते हैं, आपकी ईसीजी फैसिलिटी
Truly,
है।
truly what you said is true, and it's a word of motivation from you all. We are in the initial phase, and definitely we have to impact our public setup to understand what is chest pain and where to report and turn up on a proper time. We are initiating this, we are working on this, and definitely in the next phase we will do.
हमने ना पहले भी पहले हम थोड़ा सा हेल्थ सिस्टम we want to do the it will be great if we were visiting all your district hospitals.
Chalo.
Other district hospitals are still not doing that. Certain things for dialysis. One or two of CSCs will be on the district hospital like that, but otherwise we have to.
Definitely, we will gear up.
Emergency is a 24 घंटे There are manpower issues. There are infrastructure, other issues, small issues. But I think using the team-based approach, we will be able to do something around that.
We'll go with that. The point is that we
पर टीम में से जैसे हमने कहा कि मेडिकल डॉक्टर्स नहीं है इमरजेंसी में, तो अब उसके लिए कुछ तो करना पड़ेगा. There have to be people who are there 24/7. But if the staff is not there, how do we resolve that issue? Then we were thinking that we can try this project at least nurses जो है वो ECG करते हैं, ECG करके इसको के नाम है. And once तो हमारा सोचना रहता है कि अगर 10 भेजी है तो हो सकता है 2 में सेमिनार में सेमिनार है, उसको शेयर करना मेडिकल ऑफिसर्स के लिए इजी होगा. We wanted opinion from medical officers too, rather instead of putting everything in the medical officers basket, we are dividing. It's a last shifting kind of approach. तो दूसरा इशू आया कि मेडिकल लीगल केसेस तो नहीं होगा. काफी यहाँ से क्वेश्चन आए, तो हमें लगता है कि जब ये नेटवर्क बनाते हैं तो नेटवर्क की पूरा कंसल्टेंट चलेगी. Definitely, for example, we have the Andhra network in which the consultants from the hub hospital as well as the MD doctors, the residents open their part of that network. Plus, some of this ladies there in that network. We can have national experts. We can give incentives to them, small incentives to them. We can have boosters. तो अनेक चीजें से उससे मेडिकल डिपेंडेंट का इश्यू नहीं आता. रात हमने कहा कि अगर तुम नहीं देते तो
Anything else
If you want to rise to the second.
But I'm very hopeful considering the enthusiasm which I have seen yesterday amongst the doctors and health administrators. They are really willing to implement this STEMI care. I think which is very much required considering the volume of number of patients getting affected with the heart attack. Even young patients are getting affected. And unfortunately, as of today, they are not getting the treatment the way it should be received because a large proportion of patients are in the rural background, rural areas. So unfortunately, our healthcare system in these areas are not geared enough to make a diagnosis, treat on their own. So these teleconsultation services can definitely be a boon. And the feasibility of which we have demonstrated at least in our center, and it is being implemented in 8 centers in the country, where Varanasi is one of the centers where they are also going to see what are the challenges which you have come across, how effective it is going to be. Efficacy, I think there is no question if you are able to normalize early, and that requires a lot of public education and taking care of the concerns of the doctors regarding the medical legal needs. Because I do not know because it varies from state to state. Because suppose there's a definitely known complications. The treatment also in a very small percentage of patients can lead to bleeding complications, and therefore, if patient, it's very likely that they can have problems. But these are anticipated to be in a very small percentage of patients, but do definitely do that.
So फियर आप निकाल दीजिए. इस पूरे के पूरे प्रोग्राम का पर्पस यही है, जो फियर टू थ्रोम्बोलाइज है वो यहाँ से निकल जाए. जब आप इस चैम्बर से बाहर निकले तो यू आर रेडी फॉर थ्रोम्बोलाइसिस. यही पर्पस है इस होल सारे एफर्ट. So round of applause to
Thank you very much.
Dr.
Thank you.
He shared his experience with his example for whole completion of this project at that place. The same project he has conducted, and we found it's very useful that we can go with the same example. It's a similar scenario, and same thing is being followed in the Tamil Nadu. Why we cannot do that? UP क्यों पीछे है? हम सबसे आगे रहेंगे. वाराणसी is giving example. Yes, please.
And then the patient leaves. Because, for example, I visited CHC Badlapur, ma'am. So I was a patient. I said, okay, let's see how you're dealing with telemedicine. And I became a patient and I consulted. I waited for half an hour. I finished my rounds after 1 hour. Even by 1 hour, I could not get the doctor online. So from Apollo, we don't get good response also, ma'am. So I request you to just look into this matter.
Yeah, very good. That.
That's why I said you need a large pool of experts. So that at least somebody would be available in the group to address it. So I think the physicians in the UP, maybe district-wise at the state level, all the cardiologists of the UP, I think they can be part of this WhatsApp group. And I'm sure if a large group is there, the time delay in responding to your request would be minimal.
इसीलिए ना अपने उसके ग्रुप में जो रिसेंटली किया, we introduced some specialists from outside the state too.
So they are in a way your auditors that what is happening in the group. So if there are certain those kind of things which I have made, which are definitely avoidable as well as unavoidable kind of things. तो उसको highlight करके उसको ठीक करने की कोशिश की जाती है. So we have been able to do that in Tripati. Same thing, even the last 1 month, Punjab and Kerala issues. So we try to rectify that. But there has to be someone. So that is something which the secretary has to consider. Some nodal person. अभी तो हम लोग कर देते हैं कर जाते हैं कोई required नहीं.
Step by step, I think we can go forward. Because first we have to train.
Let's do one project.
Yes,
and एक साल के बाद हम लोग we can always upscale it to time. And then the state government we do those kind of things.
So the training part and the awareness in the rural areas, ma'am. Urban areas में तो लोग चले जाते हैं treatment के लिए. But the rural people and all staff nurses we have to be trained. Out of the
Right.
ECG readings also not right.
We made very small video audios actually.
Right.
But maybe नहीं बनाया था. It's a half a minute audio. It's a very effective. If you can give these kind of message in the
This, I think it is state and sponsored, the audio message in the All India radio. It can reach a wide regarding the symptoms. So, because in our project, we have a small budget, so we could say this only for maybe for 28 days, because it costs the second cost. So if you have, I mean, at the state level, if you are thinking of scaling into the whole state, this is one media where you can have a wide coverage. We can play that audio. The apprehension that is based here amongst the medical officers. I think twofold. One is the apprehension that if petty plays, something happens.
So this is in Punjabi actually.
So this phase we will go once we are ready with the equipments and supply of equipment. So we will going for tender for that, for this project for Varanasi. So similar things will happen in sequence. So at other places. So we will procure the things, then only we will go for advertisement. We have ECG. We have ECG. Sir has initiated, and CMO sir personally has visited. His team is personally Dr. Atul, Dr. Shiv Sakti personally visited at various spoke centers. जो धूल पड़ रही थी वो सब निकाला गया, सबके ECG खुद के कराए गए. So this was the initiative by his own efforts. Heads up to our CMO sir. He took so much interest in this project. Please give a loud applause for him. And the ECG is being done now. So our team visited and appreciated the one place he told that CSC Cholapur. We visited few places. So out of that, Dr. Manikant is there. I need his views also regarding this project and any concerns about of MOs. So, Dr. Manikant.
If the issue comes about the cost, here the medical fraternity is trained. Streptokinase has issues with its introduction, or let's say with the when we give streptokinase, it has some issues, and the medical fraternity here recalls those problems with streptokinase and probably is okay. What happens if? There will be two answers. Either he's convinced that nothing will happen, or else he is trained here on this incoming new years. So I would strongly recommend that state government should, instead of streptokinase, state government should make this as a fallback thrombotic agent in its state. Because we at government center, we are not receiving this. We are still receiving streptokinase, and from there they will learn. The experience runs from the center to the periphery. And if they come to know that it's so simple, I think that will be very important. One more step.
The celebrity is that is what it is costly, but that is what we want.
Because it's much more easy to administer. And then I think the DPS office will not have any issue. It's streptococci is there definitely only. And when the state government does it, you can always talk to the companies. I think the rates we got for 26,000 per hour kind of thing. But it is cost effective. You are saving lives. But 26,000 isn't better for your life.
So, if one life saved with this much of amount, I think it's cost effective. Dr. Manikant will take your call later on. Please sit in 1 minute. Yeah. Because we have to go for an hour. Yeah.
पेरिफेरी के जैसे हॉस्पिटल में हम लोग हैं वहाँ पब्लिक अवेयरनेस होना और कम्युनिटी अवेयरनेस होना ये सबसे मेजर इशू पॉइंट है। बहुत से पेशेंट ऐसे होते हैं जो चेस्ट पेन को लेकर बिल्कुल भी सीरियस नहीं होते हैं, वो एकदम लाइटली लेते हैं और वो हॉस्पिटल तभी आते हैं जब वो एकदम सीरियस हो जाते हैं। वो क्वैक को दिखाते रहते हैं, इधर उधर से सलाह लेते रहते हैं और हल्का फुल्का कोई भी ट्रीटमेंट लेके उनको लगता है कि मैं ठीक हो गया हूँ और जब वो सीरियस होते हैं तब आते हैं। तो हमें सबसे पहले उनके मन में ये जो विचारधारा है कि चेस्ट पेन हार्ट से रिलेटेड नहीं होता है, केवल गैस की वजह से हो सकता है, ये सब इस कॉन्सेप्ट को पहले हटाना होता है और उनकी काउंसलिंग करके उनको बताना होता है कि ये चेस्ट पेन आपका हार्ट से रिलेटेड भी हो सकता है, कृपया आप ईसीजी कराएं। बहुत से पेशेंट ऐसे होते हैं जो इस जांच के बारे में तक नहीं जानते कि ये भी कोई जांच होती है, क्योंकि वो गाँव के माहौल से उनको नहीं पता होता है या वो सोचते हैं कि ये जांच कहाँ होगी, कैसे होगी, कितना खर्चा आएगा। ये तो उनके मन में कई तरह के डर रहते हैं जिसकी वजह से वो बीमारी को किसी से शेयर भी नहीं करते हैं। जब उनकी काउंसलिंग की जाती है, उनकी हिस्ट्री की जाती है, तो वो बताते हैं कि हाँ ऐसा एपिसोड हमें पहले भी हुआ खड़ा हुआ, आज मैं आया हूँ, मुझे पता चला है कि यहाँ पे ईसीजी होता है, किसी ने मुझे बताया है, तब उनका प्रॉपर ट्रीटमेंट शुरू होता है। मैंने खुद कई ऐसे मरीज देखे हैं जिनका मैंने ईसीजी कराया, वो जब फील्ड में जाते हैं तो बताते हैं कि आप उस हॉस्पिटल जाओ, वहाँ पे ईसीजी होता है, कोई खर्चा नहीं लगता है। इसकी वजह से बहुत से मरीज मेरे पास आए और वो खुद आते ही कहते हैं कि मैं पूछा भाई क्या दिक्कत आपको है, वो कहते सर हमको ईसीजी कराना है। ये सुन के मुझे बहुत खुशी होती है कि वो मरीज खुद से बोलता है कि सर मुझे ईसीजी कराना है। मैंने कहा कि क्या दिक्कत होती है आपको, तो वो कहते हैं सर मुझे सीने में दर्द होता था, हमारे गाँव के एक लोग थे उन्होंने ऐसा कराया, हमने उनको बीएचयू भेजा भी था, वो बेचारे बहुत गरीब घर से थे, उनके पास ऐसा पैसा नहीं था वो खर्चा वहन कर सकते। उन्होंने मुझको बताया कि आप हॉस्पिटल जाइए, डॉक्टर मिलेंगे वहाँ पे और ईसीजी होता है। तो ऐसे डॉक्टर या ऐसे मेडिकल स्टाफ हमारी ये ड्यूटी बनती है कि हम पब्लिक के अंदर जो मिसकॉन्सेप्ट धारणाएं बैठी हुई हैं कि जैसे कुछ मरीज होते हैं उनको हम कहेंगे कि अरे ये तो घर पर पेन हो सकता है, ईसीजी करा लीजिए। उनका जवाब होता है अरे सर हमारे घर में बाहर किसी कोई बीमारी नहीं हुई, हमको कहाँ से हो जाएगी। ये भी उनकी धारणाएं होती हैं। तो इस धारणाओं को भी हमको बदलना होगा। ये धारणाएं जब बदलेंगी और हमको एक कॉन्फिडेंस डेवलप करना होगा कि सरकारी अस्पताल पे आपकी सारी सुविधाएं उपलब्ध हैं, सारी सुविधाएं आपके उपलब्ध हैं, आप आइए 24 और ईसीजी होता है सारी।
Thank you, Dr. Malika.
It's important. We are not saying community education is not important. What we can do is, then all of you can decide that in the next few months we have a peer system in place.
Yes.
All the things in place. Let's start with the awareness activity.
Okay.
उनका भी होता है, जैसे हमने पंजाब में स्टार्ट किया था, ICMR जब स्टार्ट किया तो हमने बिना दवाई के स्टार्ट कर दिया। हुआ क्या, जो रजिस्ट्रेशन हुई है काफी नंबर हुए, 30,000 3 months in lockdown.
So we will prepare first ourselves, then we will invite the guest. Thank you very much, Dr. Meenakshi. Now we will conclude the morning sessions here, and we are ready for the inaugural. And I would like to welcome all. It's very hearty morning to everyone joining us today in the oldest living and holy city of Varanasi. And it gives me immense pleasure to welcome you all this conference, which will prove to be fruitful and informative for all the members participating in it. I will be your host for this conference, and it is my pleasure to welcome you all for the conference. I'm grateful to all the speakers who have joined us today to share their knowledge and experience with us. I am Professor Dr. Dharmen Jain, Department of Cardiology, Varanasi. I am Principal Investigator for this project from ICMR, and extremely overwhelmed to have this opportunity to address you all at this life-saving project of STEMI led by ICMR together. and the team at Varanasi. So MI is one of the most important cause of mortality and morbidity among adult population. Timely diagnosis and timely management of this disease can save many lives, and we are together here to save those lives. In this project, we have tried to build an infrastructure of trained staff along with equipped centers, which is linked with a hub center of BHU to reduce the time to thrombolysis to minimum. Only two targets are there: reduce the time to thrombolysis to minimum, maybe half than the before, and the number of thrombolysis should be raised to double. This is the target for this project. Before beginning, I would like to thank all the dignitaries joining us in this endeavor. We are all grateful that you all have taken out time from your busy schedules to come here and make this program a success. I would especially like to invite our chief guest, Parthathi Sen Sarma, Principal Secretary, and patron, our Rector, Professor V.K. Shukla sir, to join us on the dais, and Professor Saurabh Singh, he is a principal, he is a professor in charge for this trauma center. I would like to thank for giving us space here. And Dr. Meenakshi Sharma, she is scientist from scientist team from ICMR division of NCD, and Professor S.K. Dwivedi sir, he is professor in head cardiology from KGM Lucknow. He is from ICMR expert, and Professor P.C. Negi sir from IMS Simla to join us on the dais for this inaugural. And our CMO sir, Dr. Sandeep Chaudhary sir, please join us. And Dr. Basant sir, TSU head medical health, please join us on the dais. And we are going to start with the Kulgit. Sir, Sandeep sir, Basant sir, please join us on the dais. Please, 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 please. Sir. And Rupa ma'am, please join us. The dais. Let's just hear. And Dr. Alok, he is president from our Heart India Charitable Trust. He has given time from his busy schedule. I would like to thank him and join on the dais. He is very dynamic cardiologist in the city and trained from KGMU, and his mentor is here, so he has opportunity to share the dais with his mentor, S.K. Dwivedi sir. So it's really. I would like to thank him. He has given this conduction. He has given the association for the conduction of this program from his Heart India Charitable Trust. He is conducting very good Heart India conclave annually, and all of you are already attending that since many years. And he is publishing one journal, Heart India Journal. So it's a indexed journal from MCA, and he is running it regularly. So, so with that, I would like to tell Dr. Payal and our team, Mr. Virender, so to welcome our guests. And we will simultaneously would like to start the program with the Kulgeet. So for that, I have one announcement that please do not clap on this. This is not allowed. So please do not clap after Kulgeet of BHU. So this way,
राजधानी ये तीनों लोग तेरा निवास सब ज्ञान धन और सच बसी तेरा तट पर ये विश्व सर्वों का रचे हैं ये सर्वसृष्टि की राजधानी अतीब सुंदर ये राजधानी
अपरंपार है।
So with that, Kulgeet, now we will going to proceed for lamp lighting and then for our founder, Madan Mohan Malveji, so garlanding his bus. Please, all the dignitaries on dais, join us for lamp lighting.
Sir, before this, I want to welcome you also, sir.
जी सर। So, with the interpretation, I would like to from the invited dignitaries on dais, some words of wisdom requested from our professor, first from our professor Dr. Saurabh Singh. He is the professor in charge for this trauma center and professor in orthopedic department in IMS BHU.
Namaskar to everybody here. It's great to see an initiative by ICMR and the Cardiology Department of BHU that we have trying to do something more for our cardiac patients, and hope this this model is based on Tamil Nadu government. And Professor Jain, I just caution him that there is a difference between Tamil Nadu government work culture and the existing work culture of UP government, or rather this specific zone. And second, it will be by doing thrombolysis, we are creating more patient for our reference. So at the same time, when we are creating more patient for referrals, our center should also be equipped to handle those increased number of cases. Otherwise, it will be plethora of the patient in the hub, and then again the problem of non-management, less beds, and dissatisfactions. So I request everybody here to think this forthcoming problem after 1 year, when we will have all setups, all the patient will have it properly thrombolized. When they came to the BHU or any KGMC or whatever in the centers, we should be thoroughly equipped. With the same caution and my hopes, I thank everybody here. Thank you.
Thanks, Saurabh. Right concern. But दिल्ली कहीं से पीछे नहीं होगा, भावनाएं सबकी जोर से जुड़ी हुई हैं, मैंने देखा है इनके अंदर इतना जोश भरा हुआ है, सारे जो मेडिकल ऑफिसर्स हैं स्कोप में, they will do everything wrong. Actually. So concerns are very relevant. And now I will ask Dr. Alok Singh. He is President of Heart India Charitable Trust, and he is a renowned cardiologist from Varanasi. And Dr. Alok, yes.
Thank you, Dr. Dharmen Jain and ICMR for taking this initiative. First of all, I would like to say, first try to engage with the patient, because all patient coming with the chest pain may not be the ST elevation MI. Around out of 100, only 25% of the chest pain patients are actually cardiac origin. So first try to engage with the patients, and there are certain basic things which can be done everywhere. To know what is the exact mortality of the MI, even if you don't treat MI, 70% of the patient will survive, although they will have the morbidity. And you simply catch them and put in ICU and monitor them. And simple this will improve the mortality by 15%. It has been seen when the formation of CCU came into the picture, then the 70% mortality, 70% survival increased to the 85%. And then simply by giving Disprin, clopidogrel and atorvastatin 1480 mg further gives the benefit. And even if you don't thrombolize the patient, your 90% patient will survive. The purpose of thrombolysis is to improve the acute mortality and to reduce the morbidity, because muscles once it will be damaged, patient will have heart failure lifelong. So first try to engage the patient, do ECG, give immediate Disprin, clopidogrel 300 mg, do ECG. If it is a ST elevation, patient is within chest pain within 12 hours. If you can thrombolize, you feel comfortable, you are having tenective players, give bolus and refer to the higher center. If you don't feel comfortable, you don't have that setup, please give Disprin, please give atorvastatin, please give 300 mg clopidogrel and send patient तुरंत BHU चले जाइए. अगर गरीब है जहां भी आना चाहे जाकर के तुरंत इंजेक्शन लगना जरूरी है. और ये भी बताना जरूरी है कि इंजेक्शन समय के बाद नहीं लगेगा. तो चेस्ट पेन से पैनिक ही नहीं हो जाना कि चेस्ट पेन है तो ST elevation MI ही होगा. First try to engage with the patient and give immediately these simple medicines, because this is also wonder. The benefit which we derive from the Disprin, clopidogrel, atorvastatin is also very important. So at least we should start from the basic. Try to engage with the patient, do ECGs, and do basic things which can be given even at the home. So that's all about my message. And one another point for the CMO sir, there should be one specification. This is a ECG room where patient can go directly for the ECG. That is very important.
We have done already. It's already the banner is done, and we identify the place where to ECG will be done. We already have done that. We will show you. Thank you, Dr. Alok, for your kind words of wisdom. Really, he has highlighted the relevant points. And then I would like to invite Professor S.K. Dwivedi sir for words of wisdom from an expert. He is mentor for many of the cardiologists of UP. So please.
मंच पर बैठे हुए मुख्य अतिथि महोदय और अन्य अतिथिगण, मेरे दोस्तों, मित्रों, स्टाफ नर्सेस, ICMR का जो इनिशिएटिव है, ये इनिशिएटिव को इस तरह से देखिए कि हम आगे आने वाले दशक में क्या कर रहे होंगे, अपने आप को कहाँ पाएंगे. लिमिटेशंस हैं, हर प्रदेश के सामने अलग अलग इंफ्रास्ट्रक्चर्स हैं, लेकिन अगर किसी एक प्रदेश में हो सकता है तो यहाँ भी हो सकता है. शुरू करते हैं, देखते हैं कहाँ पहुंच रहे हैं, निकालते हैं कौन कौन सी कमियां आ रही हैं. हम भी इसी देश का हिस्सा है, हो जाएगा.
Thanks for the words of wisdom. This is the word of encouragement, I would like to say, and that will give us the power in under us, which is जो काम मेरे ख्याल से रामायण में भी हुआ था, जब हनुमान जी को जरूरत थी, तो वो वही चीज जगाने की जरूरत है. और this was the sentence, I think, for that will boost us and our motto. Thanks, Dr. S.K. sir. I would like to invite Professor P.C. Negi sir. He is a professor from professor and head department of cardiology from IGMC Simla, and he has already done already discussed and presented his experiences. Please, words of wisdom for us.
Thank you, Professor Raminder. As I've already talked about, I think nothing much to say except to say that this model is definitely feasible and doable, and it will definitely help many patients. So it basically requires the commitment of all the stakeholders, and together I think we will definitely succeed in achieving our mission of how best we can help the general public and decrease the morbidity which they have to go through lifelong by timely intervention. So I think my best wishes to state of UP. I'm sure you will be successful. Thank you.
Thanks, Negi sir, for kind words of wisdom. Now, without delay, I'd like to have Dr. Meenakshi Sharma. She is a senior scientist, Division of NCD from ICMR. Words of wisdom.
सुबह से words of wisdom ही है। Thank you everyone for the opportunity. Thank you sir. वाराणसी आके जो मुझे याद आया तो ये याद आया कि बुद्धम शरणम गच्छामि, धर्मम शरणम गच्छामि, संघम शरणम गच्छामि। तो 3 वर्ड्स इसमें इंपॉर्टेंट है, बुद्धम, धर्मम और संघम। तो बुद्धम इज द नॉलेज. Do we have the knowledge to treat STEMI? Yes, we have. Are we on the right path? Dharmam. Yes, we are on the right path. What we require is Sangam, the community building. And I think you are all there. Thank you so much.
Thank you, ma'am, for kind words. Now, I would like to invite our director, sir, Professor D.K. Shukla, sir. He has taken time from his busy schedule. I would like to thank him. And he is always available for us, for IMS BHU. This is blessing that he is there as a rector, Pro VC, Full Guru. Please, sir.
Thank you, Professor Jain. It gives me immense pleasure to extend warm welcome to all the dignitaries on the dais, invited guests, delegates, ladies and gentlemen. At the outset, I'd like to congratulate Professor Jain and Professor Dr. Sandeep Chaudhary because it is their initiative and which was not possible to come to this stage unless Sri Parthasarathy Sen Sharma ji would have supported this wholeheartedly. And we were just talking, that why this. He said, why Varanasi? Because they initiated it, and he said, if it is being done, it should be expanded beyond Varanasi also. And why it is important? If you see, look at the figures, global figures. If you see, about, if I am not wrong, it is about 500 million cases around the globe. People are suffering from cardiovascular diseases, and if you look at the cost involved in the treatment is about maybe 800 billion, and it is projected that by 2035 the cost of treatment for cardiovascular disorders will be to the tune of more than 1 trillion. So that is the magnitude of the problem, and that is why it is important to organize the STEMI MI. Why? Because this is the group where you can really salvage the patients, and I think the report which he gave it to me, the ICMR report, the early reports are very promising. The group where the STEMI practice was not involved, the outcome was not good. But contrary to that, in the study group, the outcome was very good. So that speaks about the success of this program, and I'm sure with this outcome of this Varanasi region study, Sri Sharma ji will make sure that it is expanded to the rest of the state and maybe the model for the rest of the country and the globe. With these few words, once again, I will congratulate Dr. Jain and his team and Dr. Chaudhary and Sharma ji for hosting this and supporting this. And I wish that the delegates who have assembled here, they will be benefited and will contribute in the success of this program. Thank you. Jai.
Thank you, sir, for kind words and giving us time from his busy schedule. Thank you again for D.K. Shukla sir. A round of applause for him. And then I would like to invite our chief guest, Parthasarathy Sen Sharma, our Principal Secretary, Medical Health of UP Government. I am thankful for him. He has given time, came all the way from Lucknow, and many of us accompanying with him
So, please, sir.
Dignitaries on the dais and my fellow officers, CMOs from various districts, medical officers and nurses from the various community health centers. First of all, I thank Dr. Jain and Sandeep for taking the initiative for this project. It was in the last visit when I came to Varanasi in the World TB Day, I came to know through conversations that such a project was being implemented by BHU as a hub, IMS BHU as a hub, under the ICMR guidelines of STEMI of 2022. That was when I first came to know of this project, and was the first time I went through these guidelines. And that is when it was conceptualized that after 31st March, let us have a workshop in BHU in which we can call the CMOs of the neighboring districts. So today, I am happy to see CMO Chandoli, CMO Azamgarh, CMO Mau, CMO Bhadoi, CMO of all the districts who are nearby here to BHU. I'm also happy, at that time only, we also thought that why only BHU? KGMU is our natural partner. So I'm very happy to know that Professor Devedi came all the way from Lucknow, and we have CMO Lucknow Manoj is here, CMO Sitapur is here, and CMO Raebareli is here, who can be the natural partners for KGMU, just like the other districts are natural partners for BHU. As I think I'm the only one in this entire hall who is not a medical practitioner. You, all of you are either doctors or nurses, so I know the least about this subject. What I do understand is that if somebody has taken an initiative, then it is our duty to see whether it can be taken to the fruitful conclusion. I have with me Director Medical Care from the DG of UP, who will be the nodal person as far as from the state is concerned. As I see it, that the project has 4 or 5 parts. One is the identification of those CHCs and mapping of the CHCs with the tertiary sector. Not only CHCs, in our cases, it will be probably the district hospitals also. So for example, BHU will be mapped with around 40-50 CHCs come district hospitals. That is very easy to do. That can be done. And similarly, KGMU can be mapped to some 30-40 CHCs and district hospitals who can be the spoke, and the tertiary sector becomes the hub. The second point is to have the equipment gap fulfilled. As far as I am concerned, the equipment will be largely to ECG and defibrillator. If that is true, then these devices are not so costly. The CMOs of the concerned district can do an inventory check in the districts, whether what equipment is missing, and if that equipment which is missing, your indent should come to Director Medical Care. It is not a huge amount. It can easily be given to the districts, and the districts can themselves purchase because it is less than 2 lakh rupees. So you need not go through the centralized medical corporation procurement. The third is the drug. I cannot even pronounce the names. One is starts with S and the other starts with T. So streptokinase is the traditional thing, and the other one that Madam was trying to say. Yeah, streptokinase is not an EDL. It is for the doctors to decide whether they need to change the EDL or not. Money should not be a problem. So it is the Director General Health and Director Medical Care who should look into this, whether this drug needs to be changed or not. I have no opinion on the matter. But once the drug is identified, the CMOs of the districts have a 20% local purchase limit. this requirement will be much less right now because it will be based on your requirement, and this things will start picking up. Then only you'll require in large numbers. So the money for purchasing the medicine should not be an issue. The third, which is the most important point, in my opinion, the fourth is the most important point, in my opinion, is the HR capacity and their mental attitude to do the thing. So the training of the MOs and the nurses in the CSCs, as well as in the district hospital emergency department, in this method on a SOP and an ACS manual, which Shimla has already done that. So it should not be too much of a reinventing of wheel. So that manual is already there. How to have the training of the MOs and the staff nurses in a scheduled timetable manner with the concerned medical college, so that you do not end up having all the CHCs empty. You can spare some at one point of time, have the batches who can be then trained in the medical college, the hub medical college, on that predefined manual and the SOP. And then a lot of hand holding and mentoring is probably required, because one training may not take out all the hesitation. Having said that, I must also say that I know personally of CHCs in UP who are already doing this without any mentoring and without anything. They do it. I yesterday met a doctor, I can say Sayana, in Bulandshahr or Ghaziabad. Bulandshahr. The MO there is doing this, and he is referring the patients to the medical college, Meerut Medical College, without any ICMR project and without anything. So it is possible to be done if you have the will. People, and he is an anesthetist, but he is doing this, referring the patients to the Meerut Medical College and saving lives. He has already saved lives. So I think it is possible, and in the collective wisdom of this room here, we have all the CMOs here, and we have the medical officers, we have the nurses, and we have BHU and KGMU here. My only purpose of coming here is to show that we are committed to the project, and the equipment and drugs will not be an issue. Now it is up to the medical doctors of BHU, doctors of KGMU, and my team of doctors to come forward with a way. I have with me Executive Director of TSU, Dr. Vasant Kumar. You all know, I think most of the people know here, who will be giving us technical support for this project. And I think we should be able to take it forward in a reasonable time frame. Once we have the supply side going, then the demand side of the IEC should take place. We should not do the IEC before we have done the supply side. So once we have the drugs, the equipment, the HR in place, then we should go to the community and tell people that you can come to the CHCs and get your life saved through this method. So these are my initial words, and I think most of you would do a good job. I go forward with enthusiasm and yet skepticism, which Trauma Center Dr. Saurabh pointed out. The wisdom is always to go forward with enthusiasm mixed with skepticism. So I take it your point is well taken, but I think we should go forward, and we will see the challenges how to tackle. Thank you.
Thank you, Dr. Pal, sir, for words of wisdom. I think the leader like him is there with us, so he can lead us to the destiny where we want to go. And in his guidance and whole UP state health services, will try to go with the motto out of this hall in the evening, that we can do, no fears. So with that, the logistics, state health services definitely will take care. And I think CMO sir is preparing, and TSU head sir, Vasan sir is here. He is having one thorough presentation regarding this. So I'm thankful to him. He came all the way from there. And I think we have 2 more lectures, or we can go with the lunch. So I invite all of you the lunch, I want to clarify that lunch is there outside. If you feel that the space is less, it's not on paper, it's not allowed, but we can use it carefully. It is all. And the dignitaries on dais can join lunch on this hall at the entry point. We are arranging it within 5 minutes. So please, without delay, we can go for the lunch. Thank you very much. Dignitaries on dais, please go in the entry hall, and remaining people can go directly here.
Welcome, madam.
It was on a pen drive.
Yeah, it's the other one.
अभी पेन ड्राइव से हाँ डॉक्टर वसंत
यही है क्या देखता हूँ
नहीं ये नहीं है
ये ट्रेनिंग प्रोग्राम
नहीं
टाइम से
नहीं नहीं
हेलो वसंत सर हाय हाउ आर यू लॉन्ग टाइम यार इसमें देखिए मैं भी देख रहा हूँ नाम किसका है देख रहा हूँ नहीं तो मैं दोबारा कर ले
पेन ड्राइविंग पर अभी कर रहे हैं नहीं पेन ड्राइव
है एंड्रॉइड नहीं यार व्हाट्सएप इसमें काम करेगा व्हाट्सएप
so then I can send it to you. तो नंबर एक बार तो जैसे व्हाट्सएप करना
आप अपना खोल सकते हैं अच्छा ठीक है हाँ खोलते हैं फिर
मैं आई विल डू इट
Can you wait for a moment? देर के लिए आप वेट कर लेंगे ऑन के लिए कहाँ बटन
इधर से न्यू टर्न होने के लिए ये बंद हो गया
इट्स लाइट आएगा
हाँ
ये बंद है
अभी स्टार्ट है और
चेक चेक चेक
बोलिए हाँ
चेक ग्रीन
ये स्टार्ट है स्टार्ट अब बोलिए तो
चेक
ओके
बत्ती कर लेते
ठीक ठीक
think we are back. So as our guest from Lucknow, the chief guest, he has to leave. He has his own schedule. So before that, I would like to invite them back on the dais. We will have some photo session and then lectures. Dr. Basan will have a lecture on the feasibility of this protocol all over UP, how we can go ahead. And CMO sir will share his experience with this current project. So after that, we will continue. So I would like to invite our dignitaries who were on dais back to the dais so that we will have some photo session and then we will start the session. So that is also the part that will give us memories. Please, sir, come back. Okay, Pastor, our TSU head, Saurabh sir, Dr. Sandeep sir, and our ICMR team, they are just outside coming to the dais. Meanwhile, I would like to give some honor to our dignitaries on dais, Dr. Payal, with the Dr. Payal is so it's a Tulsi plant and yeah, just you can explain the file.
जी सभी चीजें डिफरेंट डिस्ट्रिक्ट इसलिए आया मैडम आ गई क्या हायर डिस्ट्रिक्ट तो आई वॉशरूम नहीं वॉशरूम नहीं बुला लगा लाइट्स are on मालूम सब बदलाव रखा है वो सर ने चेक कर लिया तो उसका भी
Yeah, so please, Madam Rupa is there, right? So please join the dais. Dr. Payal, please. Honorable Dr. Rupa. Dr. Meenakshi, please join us on the dais. So, yeah. So the CMOs from other districts can come back for a photo session. Please, CMO sirs from other districts, please join us backside so that photo. We just trying to arrange it at a small place, dignitaries.
You can see it. Yes. Wow.
Sir, बैठे
Hello. Sir, photos please.
Remaining people, please come. बस 2 मिनट.
And how much you can accommodate, we have a program and we start the session. बस आगे पीछे जैसे adjust कर लें. It's a great moment for us to have a peaceful meeting over here. Please. जल्दी आना please.
Alka. Alka also please join us. The stage. Alka, please join us.
Demo Sitapura ma'am, Shady ma'am.
Please, everybody join us. Please come to the stage. Anywhere can adjust. Please come. Please stay back. I need a combined photo for whole hall. It will be a great memory. Please stay back.
Yeah, that will be a good thing, sir. That is good thing.
We suggested that can be like this. Please come back. Come to the nearby. Can come to stage also.
SP Singh sir, आप इधर आ जाइए. Sir, sir, please. Sir, just एक फोटो ले लेना. Sir, photos लो.
Thank you all.
So I would like to invite Dr. Basan, our TSU head, medical health, UP government, to the dais, and we will continue with the sessions. So very good sessions are there. We will share the experiences after Dr. Vasant sir's message and Dr. Our CMO sir's message. Then we have to share the experiences from our current baseline data. Dr. Payal will tell, and the protocol. I will explain how we can go ahead with this. We all know with the morning lectures, we all know that what is MI and how we can diagnose and how we can treat. But actually what to do with this project, I will explain in very minute details so that the actual implementation can be done in our district, because we have done only baseline data. Now the actual thrombolytic phase will start, and before that, I need all of you should know what to do when the patient comes. So before that, how we can do it in the remaining UP, just like Tamil Nadu. Dr. Basant is there. He is TSU head, but luckily he is MD medicine, so he understands the things much better. So he is combined of administration along with the medical field. So we are blessed with his presence here, and he will explain how we can go ahead with the same Varanasi replica or same TN replica in whole UP in a phased manner, in a logistic how we will arrange the logistics, and then how we can implement it with the help of the Varanasi people who are trained in, who will be trained by that time. They are ready for the other places, so they can help us. The Varanasi people, all of you can help him to implement it in the remaining part of it. Dr. Basant, please.
Thank you, Dr. Sir. I hope I can. सभी को नमस्कार. मेरा नाम डॉक्टर वसंत है. मैं तमिलनाडु से हूँ, जो सुबह से बात कर रहा था. मुझे इतना बहुत अच्छा मालूम नहीं है, तो कोई भी मैं बात करता हूँ, कुछ गलती है तो माफ कर लीजिए. आज मेरा हम क्यों इस तरह डिस्कस कर रहे हैं, कितना इम्पोर्टेंस क्यों है. प्रोफेसर सेक्रेटरी साहब आए हैं, आप सब लोग हैं, बड़े बड़े डॉक्टर्स हैं, CMOs हैं. अभी यहाँ सब लोग क्यों आए हैं? बिकॉज मैं कार्डियोलॉजिस्ट के साथ तो लड़ाई नहीं करने वाला हूँ. सॉरी, लो मैं ओके. हम क्यों यहाँ बैठे हैं? इतने सुबह से 5 घंटे वहां से लखनऊ से यहाँ आए, दोबारा जाना, इतना बहुत बहुत काम है, बहुत मीटिंग्स होते हैं. हम यहाँ क्यों इतनी इंपॉर्टेंस करके बैठे हैं? सब लोग मालूम है नॉन कम्युनिकेबल डिजीज, आप लोग मालूम है CHO है. नॉन कम्युनिकेबल डिजीज मतलब क्या है? कैंसर है, हार्ट प्रॉब्लम है, किडनी प्रॉब्लम है, ये सब कुछ को हम क्या बोलते हैं? नॉन कम्युनिकेबल डिजीज बोलते हैं. इसमें से आज हम बात कर रहे हैं कार्डियोवास्कुलर डिजीज. जो द्विवेदी साहब बात कर रहे थे, मेरा जो टीचर का याद आया था, मेडिकल कॉलेज में जो पढ़ता था. यू रियली मिस अ गुड टीचर. कितने अच्छे से उन्होंने समझाया था बहुत कॉम्प्लेक्स टॉपिक को. तो हार्ट डिजीज में बहुत अलग अलग तरह से हार्ट डिजीज है. ऐसा नहीं है सबको हार्ट अटैक एक ही हार्ट डिजीज है. हार्ट अटैक है जो ऊपर लिखते हैं इस्कीमिक हार्ट डिजीज है, रूमेटिक हार्ट डिजीज है. आप लोग पता नहीं आज देख रहे होंगे, बहुत ज्यादा नहीं है, बट जब छोटा बच्चा होता है इनको जो टॉन्सिल बोलते हैं ना, बार बार टॉन्सिल आ जाता है, उसको हार्ट में अटैक होते हैं, उसको रूमेटिक हार्ट डिजीज बोलते हैं. आजकल नहीं है बिकॉज एंटीबायोटिक इतना खूब सारा हम इस्तेमाल कर रहे हैं. वैसे हार्ट में इतने प्रॉब्लम्स है. हम जो आज बात कर रहे हैं सिर्फ इस्कीमिक हार्ट डिजीज के बारे में बात कर रहे हैं. तो इस्कीमिक हार्ट डिजीज में जैसे द्विवेदी से बताया था, स्टेबल कोरोनरी सिंड्रोम, मतलब आपका ब्लॉक है बट ये ब्लॉक स्टेबल है. इसका मतलब आप थोड़ा मोड़ा काम कर सकते हैं. वो जब अचानक ब्रेक हो जाता है उस समय आपको इतना दर्द होते हैं. हाथ जो हाथी या एलिफेंट आपके ऊपर बैठा है उतना दर्द होते हैं. जो एलिफेंट सिटिंग ऑन योर चेस्ट बोलते हैं, हाथी आपके चेस्ट के ऊपर बैठे हैं, इतना दबाव होते हैं. ये हम बात कर रहे हैं एक्यूट कोरोनरी सिंड्रोम. आज जो बात कर रहे हैं एक्यूट कोरोनरी सिंड्रोम, इसमें अलग अलग नॉन स्टेमी है, स्टेमी है. क्यों स्टेमी? स्टेमी इसलिए बात कर रहे हैं, लगभग 40% जो इस्कीमिक हार्ट डिजीज है वो स्टेमी है. ये स्टेमी को आराम से हम जैसे अच्छे से बायो कार्डियोलॉजी तक नहीं पढ़ाई किया है, हम नर्स हैं, हम इसको डायग्नोज कर सकते हैं। क्यों डायग्नोसिस इसलिए कर सकते हैं, हम बात कर सकते हैं। डॉक्टर हो नर्स हो, पहले चीज तो हिस्ट्री टेकिंग है। हम हिस्ट्री टेकिंग इतने अच्छे से समझाया था, यहाँ दर्द है तो हार्ट नहीं है, इसके नीचे दर्द है तो हार्ट नहीं है, उन्हें अलग अलग तरीके से समझाया था। तो एक है हिस्ट्री टेकिंग, हम भी भूल जाते हैं, हम सोचते हैं सीधा ट्रोपोनिन टी करो, ट्रोपोनिन टी सीधा करें तो वो अच्छा डॉक्टर नहीं है, अच्छा नर्स नहीं है। पहले आप हिस्ट्री ले लो, उसके बाद ईसीजी ले लो, दो में ही आपको हो गया तो तीसरे वाला करने का जरूरत नहीं है। इसलिए हम सीएचसी लेवल पे, पीएचसी लेवल पे कर सकते हैं। हाँ, आज और कुछ लोग बोल रहे थे या हम करके कुछ हो गया तो क्या करें, कुछ हो गया तो भी प्रॉब्लम नहीं है। क्यों, मैं बताऊंगा। ये जो ग्लोबल लेवल पूरा दुनिया में ब्लू कलर है, नॉन कम्युनिकेबल डिजीज है। जैसे मैंने बोला था, ब्लू कलर में जितने भी डब्बे 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 हैं वो नॉन कम्युनिकेबल डिजीज है। जो ऑरेंज कलर में है वो कम्युनिकेबल डिजीज है, जैसे कोविड है, टीबी है, जो भी कम्युनिकेबल डिजीज है वो ऑरेंज कलर में। ग्रीन कलर में है वो इंजरीज है, इंजरीज हो सकते हैं, रोड ट्रैफिक एक्सीडेंट है या सेल्फ इन्फ्लिक्टेड, जो आप कुछ इंजरीज ग्रीन कलर में होते हैं। पूरा दुनिया में जितना भी बीमारी है, इसको कितना अफेक्ट करते हैं उसको मेजर करते हैं। ये पूरा दुनिया में 16% डेथ होते हैं वो इस्कीमिक हार्ट डिजीज, जो हार्ट में जो प्रॉब्लम होते हैं ब्लड के वजह से, वो इस्कीमिक हार्ट डिजीज बोलते हैं। 9.1 मिलियन मतलब 1 मिलियन 1 लाख 10 लाख है। 9 मिलियन मतलब 90 लाख लोग मर जाते हैं दुनिया में इस्कीमिक हार्ट डिजीज की वजह से। पिछले 20 इयर्स 30 इयर्स में दुनिया में इससे 0.36% बढ़ रहा है, बॉक्स का साइज बढ़ रहा है। इस बीमारी की वजह से बहुत ज्यादा लोग मर रहे हैं, मतलब बॉक्स का साइज बढ़ते जाएगा। ये ग्लोबल है, पूरा दुनिया को करते हैं। वहां देखेंगे तो 75% लोग नॉन कम्युनिकेबल डिजीज से मरते हैं। इंडिया में भी 16% लोग मरते हैं, 1.5 मिलियन 15 लाख लोग मरते हैं बिकॉज ऑफ इस्कीमिक हार्ट डिजीज, और वो भी ब्लू कलर में है। यहाँ 65%, ग्लोबली 75% है नॉन कम्युनिकेबल डिजीज, यहाँ इंडिया में 65% है नॉन कम्युनिकेबल डिजीज। बट प्रॉब्लम दूसरा है, हमारा इस बॉक्स का साइज बढ़ रहा है, हर साल इस बॉक्स का साइज 1.4% बढ़ रहा है। इसका मतलब है बहुत ज्यादा लोगों को कार्डियक डिजीज हो रहे हैं। क्यों हो रहे हैं? शिमला से जो डॉक्टर साहब आए थे उन्होंने बताया था हमारे लोग स्मोकिंग कर रहे हैं, हमारे लोग एक्सरसाइज नहीं कर रहे हैं, हमारे लोग ऑयली फूड ये वगैरह खा रहे हैं, तो इसकी वजह से इस बॉक्स का साइज बढ़ रहा है। उन्होंने बोला ट्रीटमेंट तो करना है बट प्रिवेंशन भी लेना है। बट ये करेंगे तो क्या हो रही है, ये किस बीमारी के वजह से ज्यादा डेथ होते हैं इंडिया में? ये जो इस्कीमिक हार्ट डिजीज है 1990 में फोर्थ रीजन था, आज का दिन फर्स्ट नंबर 1 रीजन है। इंडिया में सबसे ज्यादा लोग मर रहे हैं वो इस्कीमिक हार्ट डिजीज के वजह से मर रहे हैं। ये तो इंडिया का स्टोरी है। इंडिया का स्टोरी में दो चीज होते हैं जब भी बीमारी होते हैं। मान लीजिए मुझे किडनी का प्रॉब्लम आ गया, किडनी के प्रॉब्लम का वजह से मैं 5 साल पहले मर सकता हूँ, लेकिन 5 साल भी मैं पूरा हेल्थी नहीं रहूंगा, थोड़ा कम हेल्थ में रहूंगा। मॉर्टेलिटी एक है, मॉर्बिडिटी एक है। मॉर्टेलिटी मतलब कितने जल्दी मर जाते हैं, मॉर्बिडिटी मतलब मैं पूरा हेल्थ में नहीं हूँ, मैं दौड़ नहीं सकता हूँ, मेरा अपना काम नहीं कर सकता हूँ, जब भी वॉक करके मैं बात करता हूँ ये नहीं कर सकता हूँ, उसको मॉर्बिडिटी बोलते हैं। इन दोनों को मिला के कंपेयर करेंगे तो डेली एक है, ऊपर लिखा है डेली सबसे ज्यादा पूरा दुनिया में हार्ट अटैक की वजह से। डेली कहाँ ज्यादा है? इंडिया में ज्यादा है, लाल रंग का है। इसलिए क्यों ज्यादा है? हमारा तो हार्ट अटैक कम है, लेकिन जो हार्ट अटैक हो रही है उसका ट्रीटमेंट नहीं कर रहे। जैसे उन्होंने बोला मॉर्बिडिटी ज्यादा हो रही है, यंगर एज का अफेक्ट हो रही है, इसलिए सबसे ज्यादा प्रॉब्लम है इंडिया में। ये तो ठीक है, इंडिया का स्टोरी ठीक है। यूपी का क्या है? सबसे ज्यादा इंडिया में यूपी में मैंने बोला था 16 लाख डेथ हो रही है, उसमें 2 लाख डेथ एनुअली। 13% ऑफ इंडिया बर्डन उत्तर प्रदेश में आ रही है और 50 लाख दिल्ली है। सो मैं इसके नेक्स्ट स्लाइड दिखाऊंगा एक्चुअली कितने परसेंटेज कंट्रीब्यूट हो रही है। जैसे वहां मैंने बताया था यहाँ 10.7% ऑफ डेथ थी है, लेकिन 2 लाख है, 2 लाख लोग हर साल मर रहे हैं। उत्तर प्रदेश में एक साल में 60 लाख बर्थ होते हैं, 60 लाख मतलब 6 मिलियन, 60 लाख नया बच्चे पैदा होते हैं, 16 लाख लोग मरते हैं, उसमें से 2 लाख लोग एक्चुअली इस इस्कीमिक हार्ट डिजीज की वजह से मर रहे हैं। और चेंज है इंडिया से भी ज्यादा, इस बॉक्स का साइज बढ़ने वाला है, 1.6% इस साइज बढ़ रहा है, हर साल 1.6% बढ़ रहा है। और यहाँ भी जो कॉस्ट ऑफ डेथ है, पहले इस्कीमिक हार्ट डिजीज 6th स्थान में था 1990 में, अभी ऊपर होके होके वो 2nd स्थान में आ गया। पहले तो हमारा एयर पोल्यूशन है, क्रॉनिक ऑब्स्ट्रक्टिव पल्मोनरी डिजीज की वजह से सबसे ज्यादा लोग मर रहे हैं। ये जो है 15%, हर साल 15% बढ़ रहा है पूरा दुनिया में। यूपी का मैंने अलग किया है रेट में, हर साल एनुअल रेट ऑफ चेंज 15% बढ़ रहा है। मैं क्या बोलना चाहता हूँ, ये जो हम सोच रहे हैं ज्यादा इश्यू नहीं है यूपी का कंपेयर टू सदर्न स्टेट्स, वेस्टर्न कंट्रीज, ऐसे नहीं है। यूपी का ट्रीटमेंट नहीं होने के वजह से बहुत लोगों को मॉर्बिडिटी भी हो रही है, मोर्टालिटी भी हो रही है। ये इंडिया का लेटेस्ट स्टैटिस्टिक्स है, एसआरएस डेटा 2-3 दिन पहले आया है। यहाँ भी देखेंगे तो ये जो लेफ्ट साइड में है पूरा स्टेट, जो पहले अपने बीमारू स्टेट बोलते थे, बिहार, मध्य प्रदेश, राजस्थान, उत्तर प्रदेश, उसको अभी ईएजी स्टेट्स बोलते हैं असम के साथ। वहां भी सबसे ज्यादा लोग क्यों डेथ हुआ, वो कार्डियोवास्कुलर डिजीज की वजह से हुआ। यहाँ अर्बन रूरल, लोग रूरल में हैं, एक सुबह कुछ लोग बोल रहे थे रूरल लोग सब पता नहीं है, वो लोग इधर उधर जाते हैं। मुझे ऐसा नहीं लग रहा है कि अर्बन लोग में भी डिफरेंट है। मुझे जब भी बीमारी होते हैं मैं डॉक्टर के साथ जाना नहीं चाहता हूँ, मैं भी इधर उधर घूमता हूँ, इधर उधर करता हूँ, उसके बाद ही जाता। ऐसा नहीं है बाद के मैं डॉक्टर के पास जाता हूँ। वी ऑल थिंक वी विल नॉट गेट इट, ऑल ऑफ अस थिंक वी विल नॉट गेट हार्ट अटैक। सो ये जो प्रॉब्लम है ये रूरल में भी है, अर्बन में भी है। एज ग्रुप वाइज क्या है, बहुत 30 साल से 69 ईयर्स। मेन प्रॉब्लम क्या है इंडिया में, ये जो बीमारी हो रही है यंगर लोगों को अफेक्ट कर रहे हैं। और ये वाला तो दिखाया था डिले, लोग कितने लेट आ रहे हैं, बहुत स्टडीज हुआ है जिसमें कितने लोग लेट आ रहे हैं, बहुत लेट आ रहे हैं ट्रीटमेंट के लिए। ये सबसे इंपॉर्टेंट है। ये 40 साल से कम लोग, 25% ऑफ द पीपल इन इंडिया आर गेटिंग कार्डियक डिजीज, जिसकी उम्र 40 साल से कम है। एक्चुअली 55 इयर्स लेंगे तो 50% है। ये वेस्टर्न कंट्री से बहुत अलग है। वेस्टर्न कंट्रीज में इतने अधिक प्रतिशत कम उम्र लोगों को नहीं आते हैं। सबसे ज्यादा लोग बूढ़े होते हैं, एल्डरली होते हैं। इन्होंने एक्चुअली द्विवेदी सर यूज द वर्ड 75, एल्डरली 75। आपने जो भी लिटरेचर पढ़ते हैं, अंग्रेजी वाले जो भी लिटरेचर पढ़ते हैं, उसमें ये जो कार्डियक बीमारी होते हैं 65-70 के ऊपर ही आते हैं। लेकिन इंडिया में लगे तो 50% लोगों को ये बीमारी 55 ईयर्स के पहले आ जा रहे हैं। तो बेसिकली मैं क्या बोल रहा हूँ, हर साल इंडिया में इंसिडेंट, एक तो इंसिडेंस है, दूसरा प्रिवलेंस है। मतलब क्या है, एक आज बीमारी आ गया, मैं 10 साल तक रह रहा हूँ, तो मेरा प्रिवलेंस क्या हुआ, हर साल जितने भी लोगों को 10 साल तक ऐड होते जाएगा, इसको बोलते हैं प्रिवलेंस। पूरा कितना बीमारी है और एक साल में कितना आ रहा है। एक साल में जो आने वाला है 400 से 500 हो गया पर लाख। पर लाख पॉपुलेशन से 500 लोगों को हार्ट अटैक आ रहा है इंडिया में। ये आप लोग देखा होगा क्या क्या ट्रीटमेंट है। ट्रीटमेंट तो एक स्टेंट लगाओ, या आप ये जो थ्रोम्बोलिसिस दवाई दे दो, दवाई देने के बाद किसका जरूरत है उसको स्टेंट लगाओ। सो सब लोगों को स्टेंट नहीं लगा सकते। क्यों नहीं लगा सकते? स्टेंट लगाने के लिए कार्डियोलॉजिस्ट चाहिए। इस रूम में शायद 2 लोग होंगे जिन्होंने लगा सकते हैं स्टेंट, बाकी किसी को भी स्टेंट लगाना आता नहीं है। बट जिसको जरूरत है बहुत ज्यादा है, इसलिए दूसरा चीज करना चाहते हैं, वो जो दवाई देना है वो दवाई दे सकते हैं। उस दवाई देने के बाद आपका 24 आवर्स अधिक टाइम मिल जाते हैं, जिसका जरूरत है सिर्फ उनको ले जाना है कार्डियक सेंटर को। जो ये तो बोलते हैं कितना जल्दी ले आना है मसल, बेसिकली आपका टाइम इज मसल, सो आवर एम इज कितने जल्दी जल्दी उसको लेके आना है अस्पताल को। तो क्यों डिले होते हैं? एक तो आप लोग बोला था पेशेंट डिले, ये जो अपना सुबह सुबह से बोल रहे थे सर किसी का अवेयरनेस नहीं है, लोग ठीक से नहीं आते हैं, उनको बाकी चीज गैस्ट्रिक प्रॉब्लम ऐसे चले जाते हैं घर। ये तो डेफिनेटली पेशेंट डिले है, बट वो इम्पोर्टेंट नहीं, इतना नहीं है। देखिए इससे एकदम ज्यादा डिलेज है। वो क्यों है? 10 मिनट के अंदर जो भी चेस्ट पेन पे आ रहे हैं, मैं पीएचसी में हूँ, सीएचसी में हूँ, मेरे पास एक पेशेंट आ रहा है जिन्होंने डॉक्टर साहब बताया था मेरे पास चेस्ट पेन है, हिस्ट्री टेकिंग और जो ईसीजी है 2/3 10 मिनट में कंप्लीट करना है। जो पेशेंट आपके अस्पताल के अंदर आने के बाद 10 मिनट के अंदर हिस्ट्री लेना है और ईसीजी लेना है, इसको मेन प्रॉब्लम है। नेक्स्ट उसके बाद स्टार्ट करना है वो जो ट्रीटमेंट हम बता रहे हैं, जो दवाई देना है। ये जो सिस्टम इंटरवेंशन है इसका डिले बहुत ज्यादा है। एक्चुअल यहाँ नहीं है, एक्चुअल डिले वो पेशेंट हमारा दरवाजे में आने के बाद जो ट्रीटमेंट इनिशिएट करने के लिए बहुत डिलेज है। जैसे मैंने बोला था, अच्छा ICMR इस प्रोजेक्ट कर रहे हैं, बट ये ऑलरेडी अर्थ स्केल में हो रही है। जैसे मैं तमिलनाडु में बोला था, वहां 18 अस्पताल से कैथ लैब पूरा स्टेट का, किसी को भी हार्ट अटैक प्रॉब्लम आ रहा है तो पीएचसी जाते हैं। इफ मेरे पेरेंट्स हैं अभी, आई एम कॉन्फिडेंट बिकॉज उनको कोई चेस्ट का पेन आएगा तो पीएचसी जाएगा। उस पीएचसी में ईसीजी मशीन होगा, कोई डॉक्टर उसको ईसीजी नर्स लेगी, वो व्हाट्सएप ग्रुप में डालेंगे, कार्डियोलॉजिस्ट बताएगा हाँ इनका एसटी एलिवेशन एमआई है, वहीं का वहीं वो तुरंत उसको रिपरफ्यूज कर लेगा, उसके बाद एम्बुलेंस में ले जाएगा। वो कॉन्फिडेंस है मेरा मेरा इसमें 100% कॉन्फिडेंस है, मेरा पेरेंट्स को मिलेगा। उस तरह से कैसे हमारा पेरेंट्स को कैसे उस कॉन्फिडेंस हम दे सकते हैं? हमारा पब्लिक सिस्टम जो कल्चरल एस्पेक्ट बताया था, दिस इज द ओनली कल्चरल एस्पेक्ट आई सी। People in UP work much harder. I'm telling after 5 years working in UP, but the difference in the culture versus मेरा parents को ये हो सकते हैं, it can happen to my parents। तो मेरा PHC और CHC भी ये सुविधा होना चाहिए और वहाँ काम होना चाहिए। जो बंदा वहाँ है ECG लेना है, वहाँ नर्स जो है वो ECG लेके डॉक्टर से पूछना है और दवाई देना है। I am confident it will happen in Tamil Nadu। वो कल्चर हम कैसे लेके आ सकते हैं? बिकॉज आप लोगों का पेरेंट्स कभी आ सकते हैं, ऐसा नहीं है सिर्फ मेरा पेरेंट्स आएगा कार्डियक डिजीज, है ना, किसी को भी आ सकते हैं। ये वाला जो सिस्टम है पूरा अर्थ स्केल चल रही है। सो आवर एम इज व्हाइल BHU इज द पायनियर, और जो BHU पहले से स्टार्ट कर लिया और वो बहुत डिस्ट्रिक्ट्स इसके साथ ऑलरेडी जोड़ा है, साइमल्टेनियसली कैन वी डू इट इन at least 9 more मेडिकल कॉलेजेस। अभी यूपी में 19 मेडिकल कॉलेजेस में कैथ लैब है, 19 मेडिकल कॉलेजेस में कैथ लैब है, जिसमें आई थिंक 5-6 प्राइवेट है, बाकी सब सरकारी मेडिकल कॉलेजेस है। ऑलरेडी हमारे पास हब है, अभी जो हम एक्टिवेट करना है वो स्कोप है। मैंने बोला था पब्लिक सेक्टर में 13 है, बाकी प्राइवेट सेक्टर में है। हमारे पास रूरल पॉपुलेशन 18 करोड़ है। 18 करोड़ लोगों को इफ वी कांट ट्रीट इट इन 13 पब्लिक सेक्टर, ये कभी नहीं होने वाला है। विद इन 1 आवर सब लोग आ जाएंगे, उनको हम स्टेंट करेंगे, वो नहीं होगा। सो 2 घंटे के अंदर हम करना है तो हमारा CHC इवन PHC लेकर हम इसको जो परफ्यूजन थेरेपी बोलते हैं, जो दवाई देते हैं, इंजेक्शन देते हैं, उसको स्टार्ट करके देन जिसको जरूरत है उसको हमको लेके जाना है। हम क्या बता रहे हैं, पहले तो किसी को आया दर्द, वो हमारा पास स्पोक अस्पताल आया। जो स्पोक अस्पताल है वो बेसिकली स्पोक अस्पताल है, वो CHC है। वो CHC में जो डॉक्टर है वो नर्स है, उन्होंने ECG लिया और व्हाट्सएप में उन्होंने डाला, व्हाट्सएप में पूछा, स्पेशलिस्ट वहां तुरंत बताया था हाँ आपके पास ST एलिवेशन MI है, उसको उन्होंने थ्रोम्बोलाइज किया। वो जो दवाई बोल रहे थे TPA उसको दिया, जब दे दिया उसके बाद उनको टाइम मिल रही है, एम्बुलेंस में लेके हब हॉस्पिटल जा रहे हैं। हब हॉस्पिटल में कार्डियोलॉजिस्ट है, पेशेंट ठीक हो गया, डिस्चार्ज हो गया। दूसरा है जो अपने दवाई दिया, देखो इस दवाई में 99% को कुछ नहीं होगा, बट 1% लोगों को काम नहीं करेगा, वो तो हर दवाई में है। एनीथिंग आप वैक्सीनेशन दे रहे हैं उसको भी तो एफिशिएंसी 100% नहीं है, कोई भी दवाई का एफिशिएंसी 100% नहीं है। ऐसा ही है तो बहुत अच्छा रहेगा, इसमें भी इतना ही है दैट 100% लोगों को दे रहे तो 95% 96% लोगों को तो उतनी काम करेगा, 4% लोगों को काम नहीं करेगा। जिसको काम नहीं कर रहा फेल्ड थ्रोम्बोलाइसिस बोलते हैं, ईसीजी एलिवेटेड ही रहेगा। जैसे इन्होंने बोला था एसटी एलिवेशन हो गया, अब थ्रोम्बोलाइज किया एसटी एलिवेशन कम हो जाएगा। अब 1 घंटे 2 घंटे के बाद भी देख रहे हैं एसटी एलिवेशन ही है, पेशेंट बोल रहे हैं मुझे दर्द हो रहा है, कम नहीं हुआ, उसको एम्बुलेंस में दोबारा ट्रांसफर करना है। तीसरा है जिस पेशेंट बगल में ही है, एचएमयू के बगल में रहते हैं, बीएचयू के बगल में रहते हैं, वो तो डायरेक्टली कैन कम टू दी टर्शियरी केयर सेंटर। यही है हमारा ओवरऑल जो हमारा मॉडल है, एज सिंपल एज दिस। इसलिए बहुत कॉम्प्लेक्स कुछ नहीं है। जिस पर्सन को कार्डियक पेन हो रहा है, चेस्ट पेन हो रहा है, वो सीएचसी को आ रहे हैं, सीएचसी में आप लोग बैठे हैं, ईसीजी लेना है, चेस्ट गलत बोल दिया, हिस्ट्री लेना है, ईसीजी लेना है, ईसीजी को व्हाट्सएप ग्रुप में डालना है, स्पेशलिस्ट आपको बताएगा हाँ इसको इसकी एलिवेशन एमआई है या दोबारा ईसीजी करो। वो पेशेंट से डायरेक्टली बात करेगा, बोलेगा हाँ इंजेक्शन दे दो, इंजेक्शन दे दिया, एम्बुलेंस में बिठा के उनको भेजना है, एम्बुलेंस का जो बंदा है उनको भी ट्रेनिंग, दैट्स द ओनली थिंग वी वांट टू डू। इतने कॉम्प्लेक्स हम नहीं बता रहे, ये भी करना वो भी करना, ये बहुत कर चुके हैं। जो तमिलनाडु में वी आर टेलिंग 10,000 20,000 30,000 उस लेवल पे होते हैं हम, वी आर टॉकिंग अबाउट 1 2 3 ईयर, इट इज पॉसिबल वेरी इजीली। नाउ हमारा नेक्स्ट स्टेप क्या है? एक तो है हब्स एंड करस्पॉन्डिंग स्पोर्ट्स, हमने कुछ आइडेंटिफाई किया है टेंटेटिवली, मैं नेक्स्ट स्लाइड में दिखाऊंगा किस किस डिस्ट्रिक्ट किस किस मेडिकल कॉलेज के साथ हम जोड़ सकते हैं। फिर उसके बाद गैप असेसमेंट करना है, यहाँ ऑलरेडी उन्होंने एस प्रोजेक्ट में कर लिया। एक चेकलिस्ट है, सीएचसी में ईसीजी मशीन है, जो डिफिब्रिलेटर है, उसके अलावा भी 1 2 3 जो भी एक प्रॉपर चेकलिस्ट है, उस चेकलिस्ट के साथ चेक करना है हब्स का भी स्पोक्स का भी। उसके बाद ट्रेनिंग कैपेसिटी बिल्डिंग है, बहुत इंपॉर्टेंट है इसमें ट्रेनिंग। ट्रेनिंग पैकेज हम हिमाचल से ले सकते हैं, तमिलनाडु से ले सकते हैं, हम खुद डेवलप कर सकते हैं कार्डियोलॉजी के साथ। डॉक्टर का क्या ट्रेनिंग होना चाहिए, नर्स का ट्रेनिंग क्या होना चाहिए, ग्रुप डी स्टाफ का क्या ट्रेनिंग होना चाहिए, एम्बुलेंस ड्राइवर का क्या ट्रेनिंग होना चाहिए, एम्बुलेंस पैरामेडिक का क्या ट्रेनिंग होना चाहिए, सबको अलग अलग ट्रेनिंग कराना है। उसके बाद जो थ्रोम्बोलाइज करना है, जिसका जरूरत पड़ेगा उसको हम यहाँ भेज देंगे, हम जो मेन अस्पताल है। तो हमारे पास आरआरटीसी एक नेटवर्क है, मेडिकल कॉलेजेस सीएचसी तक जाके, डिस्ट्रिक्ट हॉस्पिटल तक जाके, जो एफआरयूज बोलते हैं, सिसेरियन सेशन जहां होते हैं, उनको हैंड होल्डिंग करते हैं। जैसे यहाँ बड़े बड़े जो डॉक्टर्स हैं जिसका स्टूडेंट्स है, आज उमा सिंह मैडम बोल रही थी यहाँ जितने भी डॉक्टर्स हैं वो सारे मेरा स्टूडेंट्स हैं, वैसे वो लोग खुद जाके उनको मेंटरिंग करते हैं। वैसे इसमें भी जो भी मेडिकल कॉलेजेस हैं उनका एरिया में जो भी सीएचसी है वहां जाके उसी मॉडल पे हम एंट्री कर सकते हैं। ये जो कितने लोग ऑलरेडी पीएमजे में कवर्ड है, लगभग हमारा 8 करोड़ फैमिलीज ऑलरेडी कवर्ड है, 34% लोग तो कवर्ड हैं। इतने पीएमजे में रेट्स भी है, पीएमजे में इसके लिए जो भी बीमारी आ जाते हैं उनको पे करने के लिए पीएमजे में रेट्स भी है। ये हमारा मेन 9 मेडिकल कॉलेजेस हमने सोचा था जो लेफ्ट साइड में है, और जो बीच में है हमने सोचा था इस डिस्ट्रिक्ट उसको हमने मैप किया है। जनरली उसी डिस्ट्रिक्ट, इसके और एक्स्ट्रा डिस्ट्रिक्ट भी मैप कर सकते हैं, ऐसा नहीं है सिर्फ उसी डिस्ट्रिक्ट का लेना है। और वहां इतना डिस्ट्रिक्ट हॉस्पिटल है, स्पेशल हॉस्पिटल है, सीएचसी है, हमने वो भी नंबर दिया है। ये जो टेंटेटिव है, इस डिस्ट्रिक्ट को इस मेन अस्पताल के साथ हम लिंक कर सकते हैं, सीएमओ उसी तरह से हमने बुलाया है। इसको मैप किया हमने, यूपी में कहाँ कहाँ ये आएगा, ये डिस्ट्रिक्ट किस किस को कवर कर रहे हैं। अल्टीमेटली बस इतना ही बोल रहे हैं, हम इस दवा प्रॉपर हिस्ट्री टेकिंग ईसीजी करके हम ये जो थ्रोम्बोलाइसिस करेंगे तो आपका एक टाइम विंडो बढ़ जाएगा, जिस टाइम विंडो से आपका हब हॉस्पिटल तक लेके जा सकते हैं उनको। यूटिलाइजेशन ऑफ कैथ लैब ऑप्टिमल, हमने जो कैथ लैब यहाँ है उसमें ऑलरेडी मान लीजिए एक दिन में उन्होंने 24 केसेस कर सकते हैं, हर घंटे एक केस कर सकते हैं, 12 केस कर रहे होंगे तो 12 और केसेस कर सकते हैं। बट वो 12 केसेस ऐसे होना चाहिए जिसके एक्चुअल जरूरत है, जिसको स्टेंटिंग का जरूरत है, वो भी हम कर सकते हैं। मेरे हिसाब से यूपी जैसा स्टेट जहाँ ट्रांसपोर्टेशन बहुत मुश्किल नहीं है, फ्लैट टेरेन है और बहुत रूरल एरिया है और कुछ अस्पताल ही कैप्चर कर सकते हैं, ये वाला मॉडल बहुत सूट करेगा। लास्ट स्लाइड है, लेट्स डू इट, वी कैन सेव लाइव्स। ओके, इसमें एक्चुअली अगर एक्सेस बढ़ जाएगा, why is it that my parents I am confident that they will get care, लेकिन आप लोगों का कितना कॉन्फिडेंस है आप लोगों का पेरेंट्स का केयर मिलेगा? How many of you are confident that your parents will get? Okay, good, lucky, 1 2. So in your village they will get a care मिल जाएगा, good. Why can't all our parents get? They all deserve, am I right? And second, and minimize treatment delays, optimal resource utilization. बाकी चीज को नहीं करेंगे तो हार्ट के लिए बड़े बड़े लोग ऐसे बोला है, हार्ट इज सच एन इम्पोर्टेंट थिंग। ओके, बहुत ख्याल देते हैं, लेट्स ट्राई टू सेव एज मेनी लाइव्स एज पॉसिबल। थैंक यू।
So I think most of the questions and concerns from our audiences been answered by Dr. Basant sir regarding medical legal issues which may come up. But he has answered that it's a logical to go ahead with this project and it will definitely going to save lives. We are saving more lives than losing it by thrombolizing in a appropriate patient. So that motto should be there in the mind. And I would like to invite our CMO sir, most dynamic person in this Varanasi district who is taking this project so ahead. I'm thankful to him. He has given the time from his busy schedule. And he invited so many CMOs of the district and CMS of the various hospitals and MO in charges, all of you and the medical officers and nursing staff, nursing officers, and from many people from different parts of the state health services. So it is his all his efforts that you people are here and listening to this training program, which is very important for this project to go ahead. So Seva sir will take ahead with the fear of ECG. He is very fond of this part of the STEMI, that ECG should be there. Everybody should learn that how we can diagnose this STEMI with the help of ECG. Then he wants that each and every person, it's not a rocket science. It says words that it's not a rocket science. ECG can be done by all the people available in the emergency. Each and every person should have a basic of CPR, which Dr. Shiv Shakti is doing, I think, in various parts of the Varanasi and surroundings in various places. He has having his dynamic nature that he is there in the newspapers with news that now this part of the area of the Varanasi now confident of doing CPR. So every person in the community should know the basics of CPR. Similarly, every person in the emergency should know the ECG how to do. So sir is highlighting us the ECG mistiming.
Thank you, Dr. Jain. It's very tough post lunch to just listen to lecture and always मैं भी post lunch में सोया हूँ, but वसंत सर के beautiful lecture से सभी जागे थे. It's a nice approach, sir. I'm blessed that our principal secretary sir is away and my CMOs from district are aware, and my whole team is aware, and faculties from ICMR and BHUs are aware. And I do have among you one of our listeners, my student also. He's right now physician at Rai Bareli. He's sitting over there. Now, best part was that Dr. Dwivedi has very rightly said कि पहले क्या करना है? History, history, history. And the second part is very rightly ECG, none other things. If you take a history, without any history, we cannot go any disease, and that we are lacking. We have to go only for history, history and history. We'll have a lot of confusions and lot of things there. But एक history लेना एक सबसे ज़्यादा ज़रूरी है.
मेरा ये पूरा लेक्चर उन लोगों के लिए नहीं है जो पोस्ट ग्रेजुएट मेडिसिन के और डॉक्टरेट इन मेडिसिन है. आई ट्राई टू सिंप्लीफाई फॉर कॉमन पीपल एंड एमबीबीएस. This is a global problem. I'm just very rightly, Dr. Vasant sir has very rightly said. I'm not going to detail with this. Now, this is what is ICMR project. Now, all over what we have discussed, सुबह से बार-बार हम इस चीज में डिस्कस कर रहे हैं. ICMR STEMI project. What is ICMR STEMI? ये एक कोई प्रोजेक्ट है उसमें बस ये है कि we have to take care of only one thing, that is कि we give the services to the patient earliest and increase the thrombolysin rate or decrease the time of period where this person has not received it and increase the, or rather decrease the mortalities. This basic concept is there. So the concept is only that we need not any cardiologist for that. हमें बस थ्रोम्बोलाइसिन की रेट्स बढ़ानी है और हमें इस्चेमिक टाइम को कम करना है. बस दो ही चीजें हमें करना है. उसमें हिस्ट्री टेकिंग एंड ईसीजी दो ही चीजें. गोल्स हमारे सुबह से हमने पढ़ लिया काफी कुछ. कोरोनरी आर्टरी डिजीज क्या है, कैसे होती है, क्या हिस्ट्री क्या है. ये गोल्स हमारा एकदम डिसाइडेड है कि हमको थ्रोम्बोलाइसिन रेट बढ़ानी है और हमें इस्चेमिक टाइम कम करना है. सो वी हैव टू डबल द एग्जिस्टिंग थ्रोम्बोलाइटिंग. जितना हम थ्रोम्बोलाइज करें उसके रेट को जस्ट डबल करें और हम जितना इस्चेमिक पीरियड होता है एक पर्सन जो उसकी ब्लॉक हो गई जब तक उसको कैनालाइज ना हो उस पीरियड को कम करना. दैट इज बेसिकली रिड्यूसिंग द इस्चेमिक टाइम. This was very rightly presented by Vasant sir, and I'm not going to go in detail with this. Now, I'll just मेरा ECG का presentation बहुत simple है और simple हमने पूरी कोशिश की है इस बात को बताने के लिए कि जैसे हम पूरी अच्छी तरह जानते हैं हमारा हार्ट एक कोन होता है. एक बेस है और एपेक्स है. बेस इधर रहता है, एपेक्स इधर के ऊपर होता है. तो भी हमारे हार्ट में एक राइट साइड की मसल है, लेफ्ट साइड है, इंटरवेंट्रिकुलर सेप्टा है और पीछे की पोस्टीरियर. तो हमें पोस्टीरियर वॉल एमआई हो सकता है, राइट साइडेड एमआई हो सकता है, एंटीरियर वॉल एमआई हो सकता है, लैटरल वॉल एमआई हो सकता है. हमें बस जब भी हार्ट अटैक होगा तो ये वेसल्स जिस पोर्शन को सप्लाई कर रही है हमें बस वो लीड को समझना है बस और उसको देख लेना वहां पे क्या चेंजेस है. बहुत सिंपल है. एक एग्जांपल आपके सामने साफ साफ है. एक 60 मेल है and it presented with retrosternal chest pain and EC shows ST segment elevation in inferior lead. जो लीड 2-3 एविया होते हैं inferior lead जो पीछे की तरफ देखती है ये ST segment elevation है और उसी के साथ जो उसकी corresponding लीड होगी उसमें reciprocal changes आएंगे. दूसरा अगर आप देखिए तो उसमें आपको देखिए लीड 2-3 एविया और दूसरा एविया देखिए आपको दोनों में एक में एलिवेशन मिलेगा और दूसरी तरफ corresponding आपको क्या कहते हैं डिप्रेशन मिलेगा. जैसे कि आप 2-3 एवीएफ हमारी जो इंफीरियर साइड को हार्ट को देखती है उसमें आपको एलिवेशन है. उसकी रेसिप्रोकल जो 1 एवीएल एवीआर उसमें आपको डिप्रेशन मिलेगा. तो दिस इज अ बेसिक कांसेप्ट. एक तरफ एलिवेशन है, दूसरी रेसिप्रोकल में आपको डिप्रेशन मिलेगा. बहुत सिंपल है इस ईसीजी को पहचानना और कोशिश करिए बहुत सिंपल है इस चीज को समझने की एसटी सेगमेंट का फैक्टर क्या होता है. अब ये आए जो सुबह क्लासिकली देखिए यहाँ पर आप आराम से तो ये यहाँ पर देखिए ये आपकी आरबीआई ये जो ऊपर होता है यही एसटी सेगमेंट है. जहां आपका एस वेव खत्म होता है उससे टी वेव की शुरुआत से पहले को एसटी सेगमेंट कहते हैं. इसी को पहचानना है और कुछ नहीं करना है, बस इसी को पहचानना. अगर ये बेस लाइन से ऊपर है तो ये एसटी सेगमेंट एलिवेशन है हमारी. अगर बेस लाइन से नीचे भी आएगा तो उसकी रेसिप्रोकल में देखिएगा उसमें एलिवेशन. तो अगर ये सिंपल है कंसेप्ट है कि ST सेगमेंट अगर उठा है तो हार्ट अटैक है। अब ये क्लासिकल हार्ट अटैक उस समय का होता है जब उससे पहले की चीज भी हो चुकी है। बहुत आगे कंफ्यूजन आपके दिमाग में आ सकता कि ये कैसे है। तो सबसे पहले टी वेव में चेंजेस आती हैं, टी वेव की दोनों लिम्ब एक बराबर हो जाती है, फिर पीक हो जाती है, फिर ST सेगमेंट उठता है। अब इस प्रोसेस में शुरुआत में हल्का सा कॉन्केव हो सकता है, बाद में कॉन्वेक्स होता है, स्लांट भी हो सकता है और स्ट्रेट भी हो सकता है। तो यही चीज को देखा है, दिस ST सेगमेंट इज एलिवेटेड, इट इज मोर और लेस कॉन्वेक्स और मोर और लेस स्ट्रेट और मे बी हॉरिजॉन्टल, रेयरली स्लोपिंग डाउन। इस 4 फिगर को आप ध्यान में देखेंगे, यही आपका पूरा ECG है। 4 बार देखेंगे, 5वीं बार से आप खुद ही डायग्नोस करने की कोशिश कर लेंगे कि कितना आसान हमने क्यों नहीं इसको समझा पहले। तो ये बहुत सरलता से आप समझ लें और आपको लीड याद रहे कि इंफीरियर लीड कौन सी, लैटरल लीड कौन सी है, राइट साइड की लीड कौन सी, इतने 3 मोस्ट कॉमन साइट्स हैं। बहुत कॉमन पे जाइए बस, बहुत ज्यादा डिटेल में नहीं, जो कॉमनेस्ट प्रेजेंटेशन उसी में। अब देखिए यहाँ पे नॉर्मल ECG, बहुत ध्यान से देखिए, नॉर्मल ECG पी वेव है, ये PRV सेगमेंट है, ये आपका QRS कॉम्प्लेक्स, यहाँ से S शुरू होगी, ये यही ST सेगमेंट है। बस इसी को देखना है, इसी को समझना है। यहाँ देखिए ये उठा हुआ है, यहाँ देखिए लाइन से नीचे है, यहाँ देखिए आपका टी वेव इन्वर्ट, यही ST सेगमेंट। मेजॉरिटी आपको ये मिलेगा, मेजॉरिटी आपको यही एलिवेशन मिलेगा। एज वेरी राइटली सेड बाय वसंत सर, 40% आपको यही मिलेगा और 40% में आप या मोर और लेस इससे ज्यादा भी, इस चीज को आप पहचान जाए, बस इतना ही ST सेगमेंट है। इतनी पूरी आज की कॉन्फ्रेंस है, इतनी हम लोगों को आपको प्रोपोगेट करना है। आप इसको पहचाने, जैसे ही ECG आपको ऐसा दिखे, आप तुरंत अपने उसकी ECG को डालें इसमें और उसको धीरे धीरे जब बार बार देखेंगे आपको आराम से मिल जाएगा और आप धीरे धीरे ये भी पहचान जाएंगे कि ये अक्यूट MI है कि परसिस्टेंट MI या धीरे से आगे चला या इनके में इस्चेमिक कंडीशंस है। तो कुछ ज्यादा कंफ्यूजन नहीं, बस यही ST सेगमेंट को देखिए, ये ही कंफ्यूजन है। बेसिकली क्या होता है, जब कोरोनरी आर्टरी ब्लॉक कर देती है तो हार्ट के मसल को रीपरफ्यूज नहीं होता है, इस वजह से ये सेगमेंट ऊपर एलिवेट होता है, आपके क्या कहते हैं इसमें आयन चेंजेस की वजह से। बस यही सिंपल आज की पूरी कॉन्फ्रेंस है, आगे की पूरा काम भी यही है, इसी को हमको समझ के आगे बढ़ना है। नाउ इसके ग्रेड्स हैं, आप आगे पढ़ेंगे तो आगे वो ग्रेड्स आपको समझ में आएगा। आपको देखिए ग्रेड 1 है जिसमें आपको सिर्फ आपको टीवे में चेंजेस मिलेंगे, ग्रेड 2 में ST सेगमेंट एलिवेटेड मिलेगा और आपको चेंजेस इन टर्मिनल पोर्शन ऑफ QRS कॉम्प्लेक्स मिलेगा ग्रेड 3 में। और जब हार्ट अटैक हो चुका है तो क्या होगा, कई ऐसे लोग होते हैं जिन्हें हार्ट अटैक हो जाता है, ECG नहीं करा है, बहुत माइनर अटैक होता है कई बार, तो उसमें कैसे होता है वो नेक्स्ट स्लाइड है हमारी। अब आइए देखिए यहाँ ये ST सेगमेंट है आपका, ये आपका ST सेगमेंट है, ये नॉर्मल ECG है, यहाँ देखिए एलिवेटेड हॉरिजॉन्टली है, ये डिप्रेस, ये भी यानी 2 मिलीमीटर से ऊपर अगर एलिवेटेड है सिग्निफिकेंट है, 1 मिलीमीटर से नीचे डिप्रेस है तो भी सिग्निफिकेंट है। तो यहाँ आपको दोनों चेंजेस मिल सकते हैं, इसलिए ये कॉमन है। एंड नॉन ST सेगमेंट चेंजेस बहुत रेयर होता है, बस आपको उसके लिए ज्यादा कंफ्यूज ना होइए। नो सीक्वेंस ऑफ ECG चेंज, अगर आप ST सेगमेंट देख ले, आपकी जिज्ञासा होगी ये सीक्वेंस आया कैसे। अगर आपने इस जिज्ञासा पैदा होगी कि ये सीक्वेंस आया कैसे, बहुत आसानी से आप समझ जाएंगे कि ST सेगमेंट चेंज हुआ कैसे। ये नॉर्मल है, जैसे ही उसको कोरोनरी आर्टरी ने ब्लॉक किया तो तुरंत ये ऊपर उठ जाएगा और देखिए ये लिंक दोनों डिस्पैरिटी आ जाएगी टी वेव में और ये ऊपर उठेगा या कॉन्वेक्स होगा। इसके बाद आपका टी वेव जो ऊपर उठा रिवर्ट होगा, क्यू वेव बनेगी और परमानेंट अगर इसके बाद आपको सरवाइव करे या पुराना ECG तो आपको ये क्यू वेव नेगेटिव वेव आपको मिलेगी। बस पूरा ECG यही है ST सेगमेंट एलिवेशन MI की प्रोसेस में। हमें बस इतना ही जानना है, हमें इसी पे इतना ही वर्क करना है, इसी को समझना है बार बार और ये बहुत सरलता से हम समझ लेंगे और हम जितनी जल्दी इसको समझेंगे हम अपने काम को और आगे बढ़ा लेंगे, इसलिए इतना समझने से आगे कुछ नहीं। अब क्यूवेव के बारे में थोड़ा सा आपको ज्यादा जानने के लिए थोड़ा सा क्यूवेव में आप सॉरी पैथोलॉजिकल क्यूवेव्स है, ये आपके कहाँ मिलती है मोस्ट कॉमनली आपको देखिए लीड एनी क्यूवेव्स इन लीड 2 V2 and V3 more than 0.02 seconds or QRS complex in lead V2 R and V3. They are basically can be seen. अच्छा, क्यू वेव कभी भी 0.03 सेकेंड से ज्यादा हो और उसका डेप्थ ज्यादा आने लगे तो वही पैथोलॉजिकल। कुछ लीड में आपको मिले, वो बाद में हम लोग आपको धीरे धीरे ये आपको दिखाते रहेंगे, धीरे धीरे टीचिंग मॉड्यूल में आपको समझाते रहेंगे, ये सब चीज आप समझेंगे बना कैसे है। यहाँ बस हम एक ग्लिम्स दे रहे हैं आपको, बस सिर्फ एक ग्लिम्स है। ये क्यू वेव होती है, हम आपको क्या बताएंगे बनी कैसे, इस पे आप क्या करना है नेक्स्ट एक्शन। जैसे आप मरीज आपसे जिज्ञासा बस पूछे कि आपने ईसीजी लिया, हुआ क्या इसमें, तो थोड़ा सा आपको ये भी बताया जाएगा कि नॉर्मल क्यू वेव ऐसे होती है, इसी से होती है भाई, आप थोड़ा सा परेशान नहीं होइए, अभी ये नॉर्मल भी हो सकती है। नाउ एक ओनली फॉर्म इलेक्ट्रोग्राफिक एविडेंस ऑफ मायोकार्डियल नेक्रोसिस, तो अगर किसी में क्यू वेव मिलेगी तो इसके मतलब उसका मायोकार्डियम वहां से नेक्रोज हो चुका है, यानी कई छोटे मोटे अटैक हुए उस पर्टिकुलर पोर्शन में नेक्रोज हो। ये पेशेंट्स होते हैं जो सर ने भी साफ साफ बताया कि वो मॉर्बिडिटी के कंडीशन में वो ज्यादा अपने दिन के कार्य नहीं कर पाते, सांस फूलती है और परेशान रहते हैं, नैतिक कार्य नहीं कर पाते। ये नंबर बहुत बढ़ रहा है आजकल हमारे में। तो इफ यू आर अलर्ट, हम ज्यादा जितने अलर्ट होंगे जितने समझेंगे उससे ज्यादा से ज्यादा हम इस चीज को पकड़ पाएंगे। और ये कंडीशन में हमारे मरीजों की पॉपुलेशन में अगर बढ़ती जाएगी तो ये हमारे लिए पब्लिक हेल्थ प्रॉब्लम आएगी। अब एसटी सेगमेंट कैसे चेंज हुआ थोड़ा सा बस आपको ग्लिम्स देंगे, इसके बारे में डिटेल हम लोग बार बार बताएंगे। जैसे क्योंकि जब आप बीसीजी करेंगे तो थोड़ा सा आपसे पूछेगा वो कि साहब हुआ क्या, ये बढ़ा कैसे, आप कहेंगे एसटी सेगमेंट बढ़ा हुआ है और पूछेगा बढ़ा कैसे। तो in fact it was the ST segment elevation diminishes and the T wave becomes inverted. जैसे जैसे इनफाक्ट का टाइम बढ़ेगा T वेव इन्वर्ट होगी और ST सेगमेंट आपका एलिवेट होगा। अगर इंफीरियर वॉल एमआई है it may take two weeks और एंटीरियर वॉल एमआई है तो longer than that can be possible. रेसिप्रोकल चेंजेस आपको मैंने बता ही दिया इसमें। अब रेसिप्रोकल डिप्रेशन आप देखिए कितने आराम से आप इसमें ये डिप्रेसिव टीवी लाइंस ये आपको उसके ऑपोजिट लीड में मिलेगा। तो इससे मत कई बार आप उसी को देखेंगे कैसे तो डिप्रेशन एसटी सेगमेंट एलिवेटेड ही नहीं है। नहीं, अगर आप इंफीरियर वॉलम है तो हो सकता है लैटरल वॉलम में आपको ये चेंजेस मिल रहे हो। तो बेसिक वहां फिर वही बात आई हिस्ट्री देन ईसीजी, दिस इज द ओनली टू थिंग्स। नाउ थोड़ा सा आपको ये भी दिखा दें, ये देखिए एसटी सेगमेंट एस एंड टी, ये अप स्लोप ऊपर की ओर जा रहा है, डाउन स्लोप इसको कहते हैं जब नीचे की ओर जा रहा है, हॉरिजॉन्टल ये पूरी लाइन। तो ये तीन तरह के पैटर्न मिल सकते हैं, इस पैटर्न को आप देखते रहिएगा। अब भाई बात बार बार हम लोग सुबह से बैठे हुए इसी बात को कहने के लिए एसटी सेगमेंट एलिवेटेड, एसटी सेगमेंट एलिवेटेड, और जो एसटी सेगमेंट एलिवेटेड उसको तुरंत पकड़ो इस थ्रोम्बोलाइसिन थेरेपी दो। हमें पूरा ध्यान इस बात में रखना कि एसटी सेगमेंट अकेले एलिवेटेड है तो और भी कंडीशंस हो सकती हैं। इसलिए बहुत अच्छे शब्दों में सुबह द्विवेदी सर ने बताया कि चेस्ट पेन क्या है ये समझना जरूरी, चेस्ट पेन कैसे होता है ये समझना, उससे कोरिलेट करना है। एसटी सेगमेंट और भी बीमारी पड़ती, लेकिन वो क्लासिकल चेस्ट पेन नहीं होगा आपको, इसलिए इसमें देखना ये पोस्ट एमआई भी हो सकता है, एक्यूट पेरिकार्डाइटिस भी हो सकता है, ये और भी मायोकार्डाइटिस में हो सकता है, रेसिप्रोकल या लेफ्ट वेंट्रिकुलर हाइपरट्रॉफी उसमें भी हो सकता है, लेफ्ट बंडल ब्रांच ब्लॉक उसमें भी हो सकता है। तो हर बार एसटी सेगमेंट में आप अगर मिला कोई चीज तो आपको फिर उसी पे जाना कि हिस्ट्री कैसे ले, हिस्ट्री टेकिंग इज वेरी इंपॉर्टेंट। और बहुत बारीकी से हिस्ट्री लेंगे तो आपको आराम से पता चल, जैसे सर ने एकदम साफ कहा कि लगता कोई हाथी का पैर किसी सीने में दबा रखा है, वो आदमी कई बार हाथ पकड़ के ऐसे आता है, कई बार अपने शब्दों को पूरा बोल नहीं पाता है और वो इतना ज्यादा स्वेट करता है वो शकल से दिख जाता है कि ये पेशेंट है, और वो हाथ कई बार ऐसे हटाना नहीं चाहता, वो आपसे बात पूरी कंप्लीट नहीं करना चाहता क्योंकि उसको दर्द इतना ज्यादा है। एंड बीन टेकन दैट कार्डियक पेन सबसे हैवी, सबसे ज्यादा पेन होता है, इवन टेकन दैट कि लेबर पेन से भी ज्यादा पेन कार्डियक होता है। तो कोई भी प्रिडिक्ट नहीं, कोई इसको मतलब बहाना भी मारने की कोशिश करे तो नहीं, आप साफ पकड़ लेंगे क्योंकि वो इतना हैवी पेन होता है कि लेबर पेन से भी ज्यादा दर्द होता है, और उसको पकड़ के वो नीचे झुक के थोड़ी बात करके आपसे बहुत ज्यादा कम अपने सेंटेंस भी नहीं कंप्लीट करता है। तो ये होता है कार्डियक पेन, और इसी को कहते हैं इस्चेमिक पेन, कार्डियक पेन। यही आपको हमें सबको समझना है, इसको जैसे जल्दी जल्दी आपको इनको रोल आउट करना है। यही आपके देखिए हार्ट की मस आप एओर्टा है, आपकी राइट साइड की आर्टरी है, लेफ्ट साइड की दो ब्रांच होती, एंटीरियर डिसेंडिंग और सर्कमफ्लेक्स, बस इतने ही तीन आर्टरी में कोई ब्लॉकेट होगा तभी कुछ होगा, तभी आप हार्ट के लिए आपके पास आएगा। और देखिएगा इसका कैलिबर कैसे जैसे जैसे नीचे जाएगा कम होता जाएगा। तो ये भी बहुत जरूरी है कि कहीं पहले से क्लॉट है तो बाद में डिस्क्लॉज होकर आपकी पेरिफेरी में आ सकता है। और कॉमनेस्ट अगर ये वाली आर्टरी जाती है तो बहुत जल्दी बहुत कॉम्प्लिकेटेड स्टेज आता है, तो इस पर ये ध्यान रखना है। ये एक छोटा सा ग्राफ आपको मैंने दिखाने की कोशिश की है। इसमें नीले वाले जितने देखिए आपके तो लेफ्ट सर्कमफ्लेक्स आर्टरी के ब्लॉकेट के हैं, ये हम आपको ग्राफ दे भी देंगे। ये लेफ्ट सेप्टल एंटीरियर डिसेंडिंग ब्रांच के हैं और हरे वाले हैं देखिए ये राइट साइड की कोरोनरी आर्टरी यानी इंफीरियर। अब कभी कभी आपको लेफ्ट वेंट्रल ब्रांच बाउंस के साथ भी एसटी सेगमेंट एलिवेशन मिलेगा, ये हम आपको आगे इसको आपके ट्रेनिंग मॉड्यूल में बताने की कोशिश करें, आप समझ जाएंगे इसको। तो इस तरह की कंडीशन होती है, उसमें भी आपको एसटी सेगमेंट एलिवेशन, अगर लेफ्ट बंडल ब्रांच ब्लॉक है तब कैसे डायग्नोज करना है कि एमआई है कि नहीं, ये सार्वजनिक ये आपका क्राइटेरिया है। इसमें कॉन्फिडेंट एसटी सेगमेंट एलिवेशन 1 मिलीमीटर होगा तो 5 नंबर मिलेगा, 3 नंबर एंड 2 नंबर। ये बस एक नॉलेज के लिए आपको बता रहे कि ऐसा भी एक कंडीशन आ सकती है। अब क्राइटेरिया यही है, इसमें और ज्यादा आपको बता अभी बस इतनी समझिए कि लेफ्ट बंडल ब्रांच होता है, उसमें मैं हो तो उसमें कैसे डायग्नोस करेंगे। एक छोटा सा मामूली सा क्विज है, अगर आप देखिए तो बहुत आराम से ये क्या पॉसिबल है, ये थोड़ा कोई भी बता सकता है। आप देखिए किस लीड में है, चलिए ये है एंटीरियर वॉल एमआई। आप देखिए ना V1 से लेके उधर पूरे तक, ये आप देखिए ध्यान से देखिए, आपको 2-3 AVF में एसटी सेगमेंट एलिवेटेड है, इंफीरियर वॉल एमआई। इसको भी ध्यान से देखिए आप, 2-3 AVF 1 AVL में इंफीरियर लैटरल वॉल एमआई। ये लास्ट स्लाइड एक्सटेंसिव एंटीरियर वॉल एमआई। एक स्लाइड और है बस आपकी, इसके बाद खत्म। ये लेफ्ट बंडल ब्रांच ब्लॉक के साथ एमआई है। ये सब हम लोग आपको धीरे धीरे हम लोग इसको आप इस ट्रेनिंग मॉडल बताने की कोशिश करें, थोड़ा सीजी पर चलना है, एसटी सेगमेंट क्या है बस उसको पूछना है, यही है। थैंक यू ऑल फॉर पेशेंस।
और एक जो थ्रोम्बस फॉर्मेशन, स्पास्टिक चेंजेस का भी कोई कंट्रीब्यूशन आपने देखा है क्या?
बहुत कॉमन है कोरोनरी स्पाज्म, कई जगह बहुत कॉमन है।
यस
और
वासोस्पाज्म में भी आपको एसटी एलिवेशन मिलेगा, वो ट्रांजिएंट होगा, डायनेमिक होगा, बार बार भी हो सकता है और रिलीव हो जाएगा आपका सिर्फ वासो
हमें थ्रोम्बोसिस नहीं करनी है वहां पे स्पास्टिक कंडीशंस।
डेफिनेटली, बट द क्राइटेरिया जो हम डिस्क्राइब कर रहे हैं यहाँ पर, उसमें आप थ्रोम्बलाइज करते हैं एसटी एलिवेशन और चेस्ट पेन के साथ में, तो कोई उसमें मेडिकल प्रॉब्लम नहीं है, हार्म भी नहीं है पेशेंट को, क्योंकि आप जो डायग्नोसिस के क्राइटेरिया है, आपके पास चेस्ट पेन है और एसटी एलिवेशन है टिपिकल, आप थ्रोम्बलाइज कर रहे हैं पेशेंट को। इफ इट इज इवन इफ इट इज वासोस्पाज्म, देयर जो स्टडीज है उसमें पता है कि usually there is atherosclerosis associated in the vasospastic segments also, and there are also chances that these segments can have MI also. So that has been documented and reports are there that vasospastic segment also can have atherosclerotic segments and they may have MI. So we cannot differentiate on the basis of clinical history and ECG diagnosis. We have to formalize with the definition which is just discussed and described. The vasospastic changes maybe have a recurrent similar presentations in your clinic. Patient thrombolized, gone back home, he may come next day or same day with same pain again. So then you can think of these situations. Very good question. So then he need a vasodilators. That's in the
Yes,
so that we prescribe to such patients when we suspect. But first presentation, people have done the angiograms also. Because for primary PCI, if they are going for thrombolysis, you are thrombolizing them. If they are going for primary PCI, we do the angiogram, we find that that segment is there. So that can be differentiated by if there is no thrombus, we leave it then and there. If the patient is again and again symptomatic, people have done stenting also on that.
इस पॉजिटिव कंडीशंस में सोच सकते हैं और एक फाइनल एक सबमिशन हमारा ठीक है संदीप सर आते तो रोज हम डिस्कस करेंगे आपसे that's past method we were using nitroglycerin vasodilators और हमने बहुत अच्छे रिजल्ट्स पाए हैं सिंपली vasodilators देकर बट इसमें कि आपको हाइपोटेंशन ना हो ये पर्टिकुलरली एज ए सीएमओ चंदौली हम लगातार संदीप सर के कांटेक्ट में इन सब चीजों के लिए रहेंगे एक मेरा फाइनल सबमिशन है सजेशन भी है सर कि हम लोग जो थ्रोम्बोलिसिस की बात कर रहे हैं तो साथ में हम लोग एसटीडी के रोल्स को भी उतना ही हाईलाइट करें
Definitely, that is there.
तो प्रोटोकॉल में है एस्पिरिन
and the clopidogrel or some P2Y12 inhibitor that is there in the protocol and statin. So these loading doses we give. That you will get in many presentations. We are highlighting that. इसकी गाइडलाइंस है प्री सर्जरी प्लांट नॉन कार्डियक सर्जरी के लिए सर गाइडलाइंस है कि कितने दिन पहले कौन सी वाली ड्रग बंद करनी है और उस ड्रग को बंद करने के बाद हम ब्रिज थेरेपी में क्या चीज देंगे अकॉर्डिंग टू द पेशेंट प्रोफाइल सो दैट वी डिसाइड एंड देयर आर गाइडलाइंस फॉर दैट राइट सो दैट वी विल एक्सप्लेन इफ टाइम परमिट्स
Thank you, Dr. Jain, for giving me the opportunity to speak.
Sorry, I got to introduce the speaker. He is Dr. Alok, friend of mine. He is a renowned cardiologist in the city and president of Heart India Charitable Trust, which is endorsing this event. And we are blessed that his presence. He is here with his busy schedule, and he is giving glimpse of acute coronary syndrome, which has 3 parts: unstable angina, STEMI, and non-STEMI. So how we can differentiate between them and how we can approach to that acute coronary syndrome. So when you do the ECG, when it is not typically of ST elevation MI, so you put it in the suspected ACS group. But that ACS suspected is there and how to approach that. Alok, please.
Coronary artery disease have the spectrum from asymptomatic coronary artery disease to acute coronary syndrome. And when we talk about the coronary artery disease, it may be simply spasm. As CMO sir was saying, patient may be having the atherosclerotic plaque, but that plaque is stable. And patient may have the thrombus in coronary artery. What is acute coronary syndrome? Acute coronary syndrome means, for clinical purposes, it is a rest chest pain. It is a rest chest pain for more than 20 minutes. And from pathological perspective, once we are making the diagnosis of acute coronary syndrome, then there is a thrombus in coronary artery. If there is a plaque, if there is an atherosclerotic plaque is there is no thrombus. It means the blockage, which we commonly call as a blockage. Blockage is basically atherosclerotic plaque. That plaque is stable. When because of any stress, it may be physical stress, it may be mental stress, the coating, smooth muscle coating over and above the atherosclerotic plaque get ruptured or get disrupted, then the lipid inside the plaque comes in the contact of the moving blood. Then thrombus formation starts. When this thrombus completely occludes the artery, then it is a ST elevation MI. When thrombus is there, but artery is not completely occluded, some flow is still going on, then it may be unstable angina or non-ST elevation MI. So whenever there is a 20-minute of rest chest pain consistent with the myocardial ischemia is there, then we make the working diagnosis of acute coronary syndrome. First, we have not done the ECG. We are not having the report of troponin I. So any patient सब आधे घंटे से तेज दर्द हो रहा है, तो हमने लिख दिया ACS, acute coronary syndrome. Now we have to stratify whether it is a ST elevation, whether it is a non-ST elevation MI, or it is an unstable angina. Why this differentiation is required? Because or we are talking about thrombolysis. You cannot thrombolize all rest chest pain. You will thrombolize only ST elevation MI. So ECG is must. Whenever you get any chest pain patient, rest chest pain, एक पेशेंट कहता है सर हम चलते हैं तो छाती में दर्द होता है, बैठ जाते हैं तो आराम हो जाता है. That is chronic stable angina. या एओर्टिक स्टेनोसिस में भी ऐसा होता है. दो कंडीशंस कॉमनली होती है जिसमें भी रेस्ट एंजाइना हो सकता है. एंजाइना मींस चलने में दर्द हो, और बैठ जाते हैं तो आराम मिल जाता है. लेकिन when there is a rest chest pain for more than 20 minutes, then you make the working diagnosis of acute coronary syndrome. Then go immediately for the ECG. And if ECG shows ST segment elevation, then this is ST elevation MI. And here you have to thrombolize immediately. And if ECG is not showing ST elevation, then you will label as a non-ST elevation MI or unstable angina. Now the question comes, how we will differentiate unstable angina and non-ST elevation MI? So non-ST elevation MI, non-ST segment elevation myocardial infarction, UM is unstable angina. Then here the comes role of troponin. If there is no ST elevation, there is a persistent chest pain, and you do troponin I, and if troponin I comes positive, then it is a non-ST elevation MI. If troponin I is negative, pain is persisting, then it is an unstable angina. So that's how you differentiate. Chronic stable angina, no rest pain. Rest pain, there are three things can happen. First do ECG, ECG ST elevation MI. ECG is not showing ST elevation. It may be normal, it may be ST depression, it may be T-wave inversion. And if troponin is positive, then non-ST segment elevation. And if it is not positive, then unstable angina. So this differentiation is very important because all thrombolysis is depend upon this differentiation only. Because if you will thrombolize the patient of non-ST segment elevation MI or unstable angina, then mortality can be increased. This is important to understand. So this is one important thing. And now the question comes, when troponin should be done? If you will go by the guidelines, then guidelines say, actually all guidelines come from the America and Europe. जैसे पेशेंट आए तुरंत आप ट्रोपोनिन करा लो. अगर वो निगेटिव आता है तो 1 घंटे बाद करा लो, फिर तीसरा 3 घंटे बाद करा लो. हमारे यहाँ तो अगर आपने करा लिया तो फिर तो पेशेंट कभी आएगा नहीं आपके पास, और प्रैक्टिकली फिजिबल भी नहीं है. तो हम लोग जो प्रैक्टिकली कर चलते हैं कि ECG तुरंत कर लो, और अगर ट्रोपोनिन करना है तो पेन के 3 घंटे बाद कम से कम करो पहला वाला, ताकि उसमें ज्यादा चांस है कि आफ्टर 3 आवर more than 90% cases में troponin positive आ जाएगा. Another important point which I will like to highlight, in 50% of the cases you will get first ECG as a ST elevation MI. ऐसा नहीं है कि आपने पहला वाला किया उसमें ST elevation नहीं आया तो अब आपने उसको जो है एकदम complete non-ST level करके और उसको छोड़ दिया. नहीं, in another 45 to 50% patient will develop ST elevation in next 24 hours. So you have to do repeated ECG changes. Sometimes happens we admit the patient as a non-ST elevation MI, patient develop ST elevation in the night, nobody have attended and patient myocardium is lost. So 13% of non-ST elevation MI develop ST elevation MI during the hospitalization. So that should not happen. Repeated ECG जो आईसीयू में सीसीयू में भर्ती होता है, कई बार पेशेंट के अटेंडेंट भी कंप्लेन करते हैं, कई बार हमारे डॉक्टर कलीग भी कंप्लेन करते हैं कि डॉक्टर साहब लोग बार बार जबरदस्ती का ईसीजी कर रहे हैं, इतना जरूरत तो है नहीं, वी हैव टू डू इफ दैट इज इंपॉर्टेंट. रिपीट ईसीजी इज मस्ट, क्योंकि एसटी एलिवेशन एमआई ओनली 50% केसेस में ही फर्स्ट एनकाउंटर में एसटी एलिवेशन एमआई आएगा. So that is important. So we cannot go with the guidelines. The American guideline, we don't have any our data. So we follow them, but we have अपने हिसाब से उसको हम लोग रीएडजस्ट करते हैं. So ideally now high sensitivity troponin I available है. High sensitivity troponin I, even the minor myocardial injury can detect it. But lot of time the question comes, does all troponin I positive patients have myocardial infarction? No. As CMO sir have told, all ST elevation is not ST elevation MI. There is a long list of causes. If patient is a non-hypertensive, you will have ST elevation in anterior leads. So previous ECG of the patient is very important. Previous history is very important for that kind of. Or troponin. What is troponin? That is very important. Troponin is an indicator of myocardial injury. किसी भी कारण से मायोकार्डियम में डैमेज होगा, एक्सीडेंट हो गया, सेप्टिसीमिया हो गया, pulmonary embolism, any reason which can lead to the myocardial injury, that will lead to the elevation of troponin. सपोज बुखार का पेशेंट है और एटिपिकल चेस्ट डिस्कम्फर्ट बता रहा है, आपने ईसीजी में कोई पुराना उसको एमआई है या हाइपरटेंशन है, ईसीजी में चेंजेस है, आपने ट्रोपोनिन कराया पॉजिटिव है, अब आपने कर दिया उसको जो है हेपेरिन ऊपर सब दे दिया. नहीं, हिस्ट्री इज वेरी इंपॉर्टेंट. फीवर is there, then you should suspect these type of changes can occur because of the myocarditis. Myocarditis can have any sort of ECG changes. ST elevation, it can have ST depression, it can have anything because myocardium is affected. So history is very important. History is very important, because if you will not take proper history, then you will unnecessarily thrombolize the patient, and thrombolysis, if it is not done properly in properly selected patient, then it will be the double-edged sword. So that is important. So you have to see patient in totality, not in the isolation of ECG. And whenever you get ACS patient, chest pain, rest chest pain more than 20 minutes, irrespective of ECG changes, then aspirin, heparin, whatever, if unfractionated heparin is available, you can give. Fondaparinux is available, you can give. Enoxaparin is available, you can give any three of them. And apart from aspirin, you can give another antiplatelet of your choice, like clopidogrel or ticagrelor or prasugrel, any one of each. If you are planning to manage medically, then clopidogrel, and if patient is going for immediate intervention, then prasugrel is the preferred. But for all our scenario, we mostly use the clopidogrel, because we don't know patient will go for intervention or not. So our usual regime is 1 tab Disprin, 300 mg clopidogrel, and atorvastatin 80 mg, sorbitrate 10 mg, ये देना है. और फर्स्ट जो डिस्प्रिन देनी है उसको चुएबल स्प्रिन होनी चाहिए, उसको मुंह में चबाना है उस स्प्रिन को. तो डिस्प्रिन, क्लोपिडोग्रेल ये. और ईसीजी में एसटी एलिवेशन नहीं है, एसटी एलिवेशन है, देन गो फॉर थ्रोम्बोलिसिस. इफ देयर इज नो एसटी एलिवेशन, then you give immediately heparin. Enoxaparin subcutaneous injection mostly we use 1 milligram per kg per weight होता है. अगर 60 किलोग्राम है तो 60 mg सुबह 60 mg शाम देना है. तो ये आपका प्रोटोकॉल हो जाएगा. If you will properly treat non-ST elevation MI or unstable angina, then you will automatically reduce the 15% burden of the ST elevation. Another thing, if there is a ST elevation MI and patient had already passed 12 hours, सबसे तेज जब दर्द हुआ था उससे 12 घंटा बीत चुका है, then thrombolysis will not help. Then again, for all practical purposes, the management remains like the non-ST elevation MI. Then you have to give, suppose any patient came after 24 hours, then there is no role of thrombolysis. Then you have to manage according to non-ST elevation MI and refer to the higher center. And if myocardium is viable on echocardiography, then further angiography and angioplasty will be done. If it is non-viable, then even angioplasty will not help these patients. So that's how you have to manage. Comprehensive management is very important. So complete history, then ECG, then troponin I. All these three you have to take. If you are got previous ECG of the patient, that is very helpful. And whenever you thrombolize the patient, ST elevation MI, always look for the reciprocal changes. If there is inferior wall MI, then there may be ST depression in anterior lead. If there is anterior wall, then reciprocal changes are very important because they donate there is an active MI is going on. And presence of Q wave, earlier it was thought that it occurs late, but now it has been seen it can occur even after 3 to 4 hours. So it is not a good criteria nowadays to say it is an old MI. Now earlier it was. So previous classification was QMI versus non-QMI. So it has been seen even after 3 hours, some patient can develop the Q wave. So that classification has been abandoned. ST elevation and non-ST elevation classification came into the picture. So comprehensive picture is very important. Presence of LVB is very important confounding factor. And in the presence of LVB, diagnosing the anterior wall MI is difficult. But for all practical purposes, when there is a LVB, there is a depression. Usually there is a depression in opposite direction. When there is a concordant means जिधर की तरफ LVB है, उसी की तरफ में ST segment उठा हुआ है. Secondary STT change होगा तो नीचे की तरफ. Then for the all practical purposes, that is a anterior wall MI because Sagarmusa criteria has been 5 points. And if there is a depression, it should be more than 5 mm if it is a reciprocation. So comprehensive assessment of the patient ECG and troponin I is very important. Thrombolizing in appropriate time and appropriate patient is very important. If suppose I am giving some practical examples, patient is having the history of fever, chest pain है जो कि सांस लेने पे बढ़ता है, and ECG में ST segment elevation है. It means you might be dealing with the patient of pericarditis. In pericarditis, you will have a diffuse ST segment elevation. You will not have reciprocal ST segment depression. That is the importance of reciprocal ST segment depression. So talk to the patient. Okay? What is the history and how the pain it is look like? So that is very important. So apart from that, if patient is being sent to the higher center, then depending upon the patient situation, if patient is really very sick, then we send patient for the immediate invasive. I think basic part I have cleared. When these patients require intervention, when this patient have the hemodynamic instability, ongoing chest pain, then these sort of patients need to be subjected early to the immediate intervention. And if they are clinically stable, then elective angiography and angioplasty can be done in non-ST elevation and unstable angina. Wherein ST elevation MI, the criteria for primary PCI and thrombolysis are same. And DAPT in most of the cases in 12 months. And here is a long list of cardiac troponin causes, but I have already told all troponin I positive is not MI. Any type of tachyarrhythmia, atrial fibrillation, ventricular tachycardia, heart failure, any hypotensive emergency, any critical septicemia, burn, myocarditis, Takotsubo syndrome. Takotsubo syndrome is again is a very important entity came into the picture, also known as stress cardiomyopathy. अचानक से कोई बहुत खुशी की न्यूज सुन लिए या बहुत दुख का न्यूज सुन ले, अचानक से हार्ट बैठ गया, that may present as a ST elevation MI. But these sort of patients actually because of the increased catecholamine, इतना ज्यादा एपिनेफ्रिन रिलीज हो गया कि जिसकी वजह से कि मायोकार्डाइटिस हो गई and patient have collapsed. So these subset of patients, here comes the role of echocardiography. Only echocardiographic, good echocardiographer can differentiate, because here you will may have ST segment elevation, you may have troponin elevation, but echocardiography will cleanse the picture. So in echocardiographic picture, regional wall motion abnormalities will not correspond to the particular territory of the artery, coronary artery. Aortic dissection. Aortic dissection is again very important entity, and usually it presents as the inferior wall MI. So here the importance of measuring the pulse in both arms and both limbs comes very important, because if you will thrombolize the aortic dissection, then there is no chance of surviving, the patient is there. So mortality is for sure. So basics, if you are taking the pulse of both upper arm and both lower limb, if there is all good, then chances of dealing with aortic dissection is very high. And the characteristic of pain of aortic dissection is different from the acute coronary syndrome. Acute coronary syndrome, the intensity of pain is a variable. थोड़ा तेज होगा, थोड़ा कम होगा, तेज हुआ फिर कम हुआ, फिर थोड़ा तेज होगा, फिर कम होगा. Aortic dissection का जो पेन होता है, it is a maximum severe at the onset. जब शुरू होगा उसमें सबसे सीवियर होगा. That is the differentiating, and it will be tearing quality. Whereas ACS, it is a compressive quality. जैसे हाथी लगा कि हाथी चढ़ा हुआ है, इस तरह का दर्द जो होगा compressive feeling का होगा. That will be the MI pain, and dissection pain will be tearing at the onset of the pain. जब पेन शुरू हुआ उसी समय सबसे तेज होगा. Whereas acute coronary syndrome pain will have varying intensity. कभी जब कम हुआ, कभी ज्यादा हुआ, कभी कम हुआ, कभी ज्यादा हुआ. That's how it will occur. Mortality of aortic dissection is very, very high. Almost 25% patient die within 24 hours. So even stroke patients, amyloidosis, hemochromatosis, sarcoidosis, any patient, lot of cancer chemotherapies are being given nowadays, can lead to the troponin elevation. So isolated troponin elevation should not be done. Troponin should always be analyzed in the context of the clinical setting. That is very important. So history taking is the core. That is important. If any patient coming with more than 20-minute chest pain, simply if you are confident, give Disprin, clopidogrel, atorvastatin, enoxaparin, sorbitrate 10 mg. Then think of anything. ECG होता रहेगा, ECG कराइए. अगर है तो डायरेक्टिव प्लीज लगा दीजिए. अगर ST एलिवेशन है तो. अगर नहीं फैसिलिटी है आपके पास, नहीं है ECG, कहीं आप गए हैं, आप इतना कर दीजिए. इतना आपने कर दिया तो आपने काफी काम कर दिया उसका. So any test, whether it is ECG or troponin, it must be individualized to the patient, history and clinical condition. And there is a long list of conditions which can cause the acute chest pain. So for 100 chest pain you are encountering in emergency, maximum to maximum only 25% will be the cardiac. This is the data. So your approach, if you really want to get good result, if you want to get out of your thrombolysis, then you have to be your clinical diagnosis must be very good. And there is a very good document by the American Heart Association regarding the approach of chest pain. It is very good. It can be downloaded freely. Even in cardiac, myopericarditis, cardiomyopathy, tachyarrhythmias, acute heart failure, aortic valve stenosis, coronary spasm, cardiac trauma, pulmonary embolism, bronchitis, pneumonia, aortic dissection, GI causes very common, musculoskeletal disorder very common, and even herpes zoster. We usually find in our practice, herpes zoster patient, usually pain comes first and vesicles come later. Sometimes it takes 6 hours, 1 day after the pain. So herpes zoster. So this is very important. So all chest pain is not cardiac. Only 25% is cardiac. So that is important. And even though it is acute coronary syndrome, only 40% are ST elevation MI, where you have to thrombolyze. 60% is the patient where management is very simple. Give disprin, clopidogrel, atorvastatin, heparin, sorbitrate, and refer to the higher center. So overall, until you will have a comprehensive understanding of the chest pain, then you will not feel the comfortable in thrombolizing. So what is the role of ECG? What is the role of troponin? I think a lot of issues have been made clear to all of you. So the recommendation is all vitals measurements should be taken, and bilateral upper limb, lower limb pulse is very important because aortic dissection you might be dealing. ECG guideline, when you are getting the patient, within 10 minutes ECG should be done. And if you are thrombolizing the patient, within 30 minutes of arrival up to your hospital, thrombolysis needs to be given. That should be the spirit. And 1 hour, 3 hour algorithm, I don't find very useful in our setting because we cannot do 3 troponin in our setting. So what I will advise, if patient can afford, after 3 hours or after 6 hours, you order a troponin I. If first ECG does not show ST elevation, then you can repeat 1 ECG after 1 or 2 hours. Otherwise, it's okay. BNP and NT-proBNP are, you can do it, but for all practical purposes, it is not very useful. So these algorithms are very much complicated and they make the simpler things very complicated, but for all practical purposes, which I have told, history, physical examination, ECG and troponin I, 3 is the crux. The difference is, I am summarizing for all of you. If there is a chronic stable angina, then you give simple antiplatelet, statin, beta blocker, and ACE inhibitor. Once there is ACS, acute coronary syndrome, then thrombus comes into the picture. Rest pain matlab thrombus. Then what you add? You add dual antiplatelet, you add 1 more antiplatelet. And because there is a thrombus, then you need drug which can counter the thrombus. Then you add heparin. And if there is a STL segment elevation, means thrombus burden is very high. It is occluding the artery. Means it is a real emergency. If you will not give some agent which can really open the artery, then your myocardium will be damaged. Then here comes to the role of thrombolytic agents are primary PCI. So once you have thrombus, then your intensity of dealing with the thrombus should be high. So if it is ST elevation, then it is a maximum severity of maximum intensity to deal with that situation. In that situation, you go with the thrombolysis or primary PCI. And if it is a non-ST elevation MI or an ST angina, then you go with the dual antiplatelet and heparin only, and intervention later on. So I think that's all which I will like to say. And intervention part is being decided by the cardiologist based on the clinical presentation. If patient comes into the 12 hour, then we do directly primary PCI. And if patient is within 24 hours, again we can go for the primary PCI, or if patient have been already thrombolized, then PCI can be done within 24 hours or up to 48 hours. And if ongoing pain or hemodynamic instability, then anytime if cardiologists feel we can salvage the myocardium or myocardium is salvageable, then can do. So a lot of no and buts, ifs and buts are there. So all patients should get, if blood pressure permits, they should be given beta blockers, ACE inhibitors and MRAs, specifically if the ejection fraction is less than 40%. And concomitant use of proton pump inhibitor have some issues with the dual antiplatelet. So among them rabeprazole is advised. So summarizing is to my talk, history, physical examination, ECG and troponin I, 4 thing is the must. And comprehensive understanding of the chest pain is very important when we are managing these patients. Thank you all for patience.
Thanks, Dr. Alok. I would like to invite Muslims as a panelist on the dais. Dr. Alok, please join. CMO sir, Dr. Sandeep Chaudhary sir, please join as a panelist on the dais. And Dr. Basant sir, please join dais as a panelist of post-lunch session lectures. Please come. Your inputs are very important. So, with that, regarding Dr. Suyash Tripathi is also a panelist. Join the dais. Other panelists, Dr. Dheeraj, Dr. Gautam, Dr. Abhishek Pathak, Dr. Sang, Dr. Ajay Patel, Dr. Manoj Gupta, if anybody is there, please join on the dais. And the message is very clear with Dr. Alok's lecture. ACS is a composite diagnosis. So any chest pain patient with 30-minute chest pain, more than 20-minute chest pain is ACS. And this is the patient which we are targeting. So very important is history. Only history can tell you that this is our target patient and this can be our MI patient. Only history. As he has clearly stratified that if the patient have typical chest pain of MI, which has been described by Dr. Dwivedi sir in the morning, Dr. Alok right now, and we will again answer whenever you ask in every lecture, it is there. So emphasis is only on symptoms followed by the ECG to be done. And if ECG is showing ST elevation with reciprocal changes, it's MI. If ST elevation only, then we have to think that it may be pericarditis, it may be other things. So ST elevation with reciprocal changes with background of chest pain, it's MI. No confusion. Reciprocal changes means leads which are opposite to that wall, they will have ST depressions. That is reciprocal. So we will explain again and again that, don't worry. So next lecture, the complications of STEMI. We are apprehensive. Our patient will die. What will happen? Patient is going to die with what regions? Dr. Suyash Tripathi is here with us, our co-PI of the STEMI SCT project, and we are thankful to him. He came with his busy schedule. He is with us, and he will highlight the complications of STEMI and how we can manage it. So the possible complications which he is describing, we can explain to the patient beforehand that you are going to die with these so many complications possible for with MI which he is having. So disease can be the cause of death with these much complications. So these pictures will be there in your mind. You can explain to the patient you are going to die with this much complications. If we give this injection, you are getting to be saved because of that blockage will be opened and you may get the savior of life. Otherwise, you are going to die because of these much complications. This much percent of chance he will highlight that will be there. You can explain clearly. Then you take the consent and then thrombolize. So consent is very important. Consent is a legal paper where patient is giving you opportunity to treat with the guideline directed therapy. It's not. It can be done by any MBBS person by batchmate at very small place, CSC in MP. I belong to MP. He is thrombolizing since when he joined. After MBBS, immediately he joined that CSC in 97, 98. And he is thrombolizing since he saved many patients. He was the only MBBS available in that city. It's very small city, CSC Mungavli in MP, Guna district, Ashoknagar. When we go from Bina to Kota, you will get. And he is thrombolizing at a CSC without much anything else, just chest pain, ST elevation. He was taking initially on WhatsApp from our colleagues. Many of our batchmates are cardiologists, so we can call anybody and get the help in diagnosis. Now he's not asking. Since many years he's not asking. He's thrombolizing. He's saving many lives at a very small place, giving example that it can be done with confidence. So that confidence will be there when you leave from here, with all the possible complications, with all the possible differential diagnosis in your mind. So by the time Dr. Suez is setting the slides, we are going to discuss very interesting data which we have got with the 3-month baseline data of this project, in which we have done nothing, just observed what we are doing presently in the community of Varanasi district. So that will be very interesting. And after Suez lecture, we are going to discuss the protocol, how we are going ahead with this project, how we can do the thrombolysis possible in a patient which is coming to us with chest pain. So that protocol we have to understand. Without that, this whole project is baseless. So we will explain regarding how to explain to the patient. So patient information sheet we are going to provide you. Hard copies are there in your envelopes. You can go through that. The patient information sheet is there in the Hindi and English both. You can provide to all the patients who are having chest pain this information sheet. After that, the patient will give you the consent. So he has to explain. He has to be explained regarding the consent clearly, that he is giving you consent regarding the treatment, further treatment for the patient, in which we are going to thrombolize. That consent is there mentioned in that paper. So consent form. So next form is consent form. You just open your envelopes, please. Open all the envelopes provided to the delegates. Please open it. You will find 3 types of paper. One is the patient information sheet, PIS. Patient information sheet. In Hindi it is Sahbagi Suchna Patrak. So who is the participating? That participants information sheet, PIS. Hindi English format is there, where we are informing to the patient regarding the disease. So it's very clearly written. You please go through at home regarding that. Then after that there is a consent form, informed consent form, ICF. Participant informed consent form, PICF, something like that. You are having. So that is Sahmati Patrak, right? Participants consent form. So informed consent form. So that is there where patient will sign there, or his attendant, if he is not in the position to sign, some legal attendant with the patient can sign. And then there is a one column where some of any staff or any patient's attendant or anybody in the hospital, anybody can sign as a just open it in the PICF. Anybody can Dr. Manikant, you just tell us how many parts are there in the consent form. He was very meticulous in the baseline data. Consent taken, patient is having pain with this much of time, and this is the ECG, and typical pains is this hour, and we have done the ECG at this hour, and the patient consent is attached, and the patient is being referred. Everything was there perfectly by Dr. Manikant. As much praise his efforts. He is having that form. Just you tell us. Can you give the mic? Somebody can to the Manikant. Give the mic to Dr. Manikant. Okay. Mic. Read loudly the sign to be taken in the consent form. For anybody in the team, read loudly so that we can understand the consent. That is the legal part we are worried about. And it is informed consent. So we have to read and patient should understand whatever written in the consent form, and then he is signing on that. And just read the who is signatory there in below. On left side, first is the patient or attendant. Dr. Monica, read loudly for us.
जब कोई भी पेशेंट हमारे पास चेस्ट पेन का आता है,
You just read the who is the signatory below. जो consent form है उसके bottom में किस किस के sign है?
एक साइन होता है सिग्नेचर लेफ्ट साइड में पेशेंट,
लेफ्ट साइड में पेशेंट का या पेशेंट के अटेंडेंट का?
जी सर, पेशेंट का होता है,
पेशेंट या पेशेंट के अटेंडेंट का? जस्ट रीड इट लाउडली whatever written there.
signature left third impression. I agree to enroll myself, my child in the above study.
So that is patient or patient's attendant. If the patient is minor, it is not there in our case. All patients are more than 18 years. So the patient, read who is the signing? Left side.
Left side signature of the investigator.
Okay, right side.
Myself, doctor, who is doing examining the patient.
And below on the
below
left.
name of the participant guardian.
Okay, so who is signing on the left side? Who is signing? The name should be there then.
Yes, sir. Name and signature of the individual obtaining consent.
Yes. So who is taking the consent? Doctor,
Doctor
nursing
is taking
staff,
the consent.
doctor, nursing staff,
Or any staff.
yes, whosoever is taking the consent, that should be
Yes, sir.
that
Name
person.
and witness of signature of the witness.
Witness. So somebody should witness whole of this procedure, and he will sign. He or she will sign. So anybody of the family, patient family, or anybody from the staff also can sign there. If family members are not much enough, then so that is the part of the consent, and these should be there. And I requested all of you that to write phone numbers of the attendants, 2 or 3, because we have to follow these patients for 1 year. Every month, first month, 3 months, 6 months, and 1 year, we will call these patients telephonically or physically possible. Then they will tell the story that whatever has been done on the patient, and if they are coming physically, we will give the benefit of clinical consultation free of cost at our place, and we will give the appointments, and they will be followed up so that we will get the results that whatever efforts you have done now. And we are having 100 patients, baseline patients, in which we have not done any efforts, and they are also being followed for 1 year in this study. So at the end of the study, we will find that those patients in which we have not done any efforts, they are getting thrombolysis at very late. They are getting thrombolysis in very less numbers. Now we are taking action. Now our patients will be getting thrombolysis more. The estimated time is less. Now the patient, how many lives we have saved? Both the lines will be go parallel for 1 year, and then we will find how many patients we have saved. So that will be the part of this STEMI ACT project, and we will get the information that efforts done in this project by all of you, how much better results we have got by giving the thrombolysis in time in a appropriate patient who is needing it. So that is consent form. Then third part is the CRF, very important part. One page CRF is there, that is case record form, in which we have to enter patient's detail very meticulously, patient's address, patient's phone number, because phone number gets changed and by address we can reach to the patient, we can find that patient for the follow-up. So proper address of the patient and 2-3 phone numbers of patient and patient's attendant should be there on this paper. Even the mobile number is written, but mobile numbers should be there so that we can follow this patient for 1 year, and we get the information for 1 year for this patient so that we can prove that we have done something good for them. So that data will come and we will share, and it will be very important national data you are contributing, and that will help us to go ahead with this project in other places other than Varanasi in UP and other places in country. So this is very important data ICMR is collecting, and we have to contribute to this by giving our efforts, and the gift which we will get, that we will be confident, like my friend is doing since last When he is completed MBBS, next day he is thrombolizing. So the same thing, he just done a few months GRC in Delhi and 6 months or something, and then came back. He is doing every procedure there, every minor procedure he was doing MBBS. He was residing just behind. I've done MBBS from Gwalior. He was belongs to Gwalior, and he was doing procedures, minor procedures at home to many needy patients. So that interest should be there with all of us, that we are going to formalize a patient who is really needing it. We are not going anything against the law. We are doing it with the guideline directed therapy. So there should be no fear in giving this benefit of thrombolysis who is going to die. That data is there. It has been given to you. And these slides I will share to all of you. I promise that all the protocols I will share. And any confusion at any point, we are there to help you. So WhatsApp group is there, and that same model will be there for all of you in a whole state of UP. That is the plan by our TSU head, Dr. Basanta, and our principal secretary. So that means I think slides are set. Yeah. So we will be going ahead with the complications which are there in our mind, that what will happen with these complications. He's explaining how to handle, and you have to explain to your patients that this much you can have without thrombolysis, more chances are there. With thrombolysis, chances will be less.
Hello, good evening, everybody. My name is Dr. Suyash Tripathi. I am assistant professor in cardiology. So today is a long day for all of you, so I'll keep this short. So first and foremost, the most important thing is that if your mind knows about something, then only you can find it. So it is very important that you should be aware of the complications of ST elevation MI. So today we are going to discuss what are the complications of ST elevation MI. And so first of all, we have to look in a time frame that if a patient comes with myocardial infarction, by what time frame, what complication occurs. So that is the most important. So first one is patient comes to us after chest pain, immediate to few hours after chest pain. So the first and the foremost complication is arrhythmias. So I will discuss what is arrhythmia in short, and then within 24 hours, patient can have post-infarction angina. Post-infarction means after the infarction. That means patient had an infarction and then he is having chest pain. Then complications that are occurring 1 to 3 days after MI, that is heart failure or cardiac shock. In 3 to 7 days, it is ventricular free wall rupture, mitral valve papillary muscle rupture, or ventricular septal defect or ventricular septal rupture can be there. And then if it is more than 1 week to several weeks, post-infarction pericarditis, that is the Dressler syndrome. That's something that Dr. Alok Singh sir has already touched upon it. And then from weeks to months after the MI, patient can have left ventricular aneurysm. So we will be discussing this. We will just have an overview of all these complications. Otherwise, these complications can be large. Will take many slides. So to keep it short, we will discuss in short everything. So first complication, which is immediate to hours post MI, arrhythmias. So arrhythmia can be ventricular arrhythmia, it can be ventricular tachycardia, or it can be a bradyarrhythmia. Arrhythmia means abnormal ECG rhythm. That is all what arrhythmia means. So ventricular fibrillation, ventricular tachycardia, or a bradyarrhythmia. So these are the most complications of MI that we are going to deal with. So what is the pathophysiology? Arrhythmia occurs because there is some ischemic damage disrupting the normal electrical pathway of the heart, or there is a necrosis or cell death and inflammation that disrupts the normal heart. So what is the pathophysiology of arrhythmia? There is ischemia is there, and this leads to cell necrosis and this disruption of electrical pathway in the heart. Our conduction system is damaged. So clinical presentation, patient will have palpitations, he may have lightheadedness, shortness of breath, he may feel unconsciousness because of the reduced blood supply to the brain or the cardiac arrest. So what is the management? Immediate recognition via ECG, monitoring is crucial, and management varies based on the arrhythmia type. For example, severity includes defibrillation, antiarrhythmic drug, or potentially a pacemaker insertion. So we will see. So this is the first ECG we are seeing here. So in this ECG, we can see that we can see there's some irregular rhythm is there. This is not a normal ECG. You see, There's no QRS complex is there. So what do we understand from this? So this is the ECG of ventricular fibrillation. This is an emergency. If patient has this, you have to defibrillate this patient as soon as possible. So we must learn how to defibrillate the patient. Defibrillation in this kind of ECG, you have to make it in an unsync mode, and you have to give a DC shock. DC shock has to be given, one lead has to be placed here, and other lead has to be placed on this side of the chest, and then you give a defibrillation at the joules of 200 to 300 joules. So first complication is ventricular fibrillation. Second one, we can see this here, the heart rate is very low. We can see that heart rate is 41 represented here. And what else can we see here? We can see that there is some accumulation in lead 2 and lead 3. So there is some accumulation in lead 2 and lead 3. These are inferior leads. So this patient is having inferior wall of line with ST elevation. And there is some heart rate is low. And then we can see that with every QRS there is no P wave. This is a QRS, there is no P wave here. Then there is, we can see a P wave just after QRS, and then there is a gap, and then again there is some QRS complex, and then again in between some P wave is there. So we can, what we see here is that this patient is having complete heart block. That is, there is no synchrony between upper chamber of the heart, that is the atrium, versus the lower chamber of the heart, that is the ventricle. So this patient is in CHB, and he's having a inferior lead. So it's an inferior wall line with CHB. Inferior wall line commonly presents with complete heart block. So we have to be aware of this complication. If patient is having escalation in the inferior leads, then we should be aware that we should think that this patient can have CHB, and we should look for CHB. How do you look for that? You look for their dyssynchrony between P wave and QRS. There's no concordance between P wave and QRS. So that's how you look for it. So this is CHB. So what is the treatment for this? Treatment for this is you give an inotropic drug, and you can give a tropine for it. And if all that does not work, you have to do temporary pacemaker for this patient, and then take this patient for thrombolysis or for the revascularization procedure, whatever is indicated. Now this is another ECG which shows again what we are seeing here. We are seeing some high heart rate is there. There is some well-formed QRS is there, but it's not a normal QRS. So this is a wide QRS and tachycardia. So it's a wide QRS, tachycardia is there. This ECG is an example of ventricular tachycardia. Again, the treatment for this is we give amiodarone. So I will just come on to the treatment part. So treatment is amiodarone. We give the dosing is 150 mg IV bolus over 10 minutes, and then 1 mg per minute for 6 hours, and followed by 0.5 mg per minute for 18 hours. This is the most important dosing for amiodarone. You all should remember this dose, because if you are going to treat with patients of MI and you are going to have complications, and this is the treatment for that complication, you are very frequently going to have ventricular tachycardia or ventricular arrhythmias in the patients with MI, and this is the treatment. So remember this treatment. Again, for patients who are having low heart rate like inferior wall MI with CHB, these patients you have to give a tropine 0.5 mg bolus, and if heart rate is still less than 50, you again give 0.2 mg bolus, and total up to 2 mg you can be given of a tropine. Generally, many times we see that in practice people are giving isoprenaline for increasing the heart rate, but it's not beneficial. It increases mortality in the patients with MI. So next complication, that's something that occurs within 24 hours. That is called as post-infarction angina. So post-infarction angina, there is chest pain or discomfort due to CAD that occurs after recent MI. So patient had an initial episode of chest pain, and maybe he was thrombolized or he's not thrombolized. So and then he's having chest pain. So this is something that has happened after the MI. So it's called as post-infarction angina, and this is generally happens when there is still not enough oxygen or blood is not reaching the heart. So there is persistent blockage or new blockages occurred maybe. Suppose you have thrombolized the patient, and that patient has recanalized. As we can see from the ST elevation has come down. But again, we see that there is again the patient is having chest pain because a new blockage has come. So, so the pathophysiology is there is either incomplete reperfusion or occlusion of the infarct-related artery. So what does incomplete reperfusion mean? So thrombolysis is not everything that is going to work to give wonders to you. Thrombolysis has success rate of 50 to 60%. Even with the latest generation thrombolytics we use, the bolus thrombolytics, the success rate is around 60-70% is there only. So there can be incomplete reperfusion. There is no complete perfusion is there. Or maybe there is a reocclusion has occurred in the infarct-related artery. For example, if we have seen a previous case of inferior MI, so RCA is occluded. we have thrombolized the patient, and after thrombolysis, it has recanalized. But again, patient is having chest pain, maybe because there is reocclusion of the vessel. So, or there is progression of atherosclerosis in other coronary arteries. Maybe it is not infarct-related arteries. For example, patient is having inferior MI and there is a blockage in the other arteries, like maybe he's having a critical blockage in LED. So that can also cause a post-infarction angina. So what are the symptoms? Symptoms are typical of angina, as already discussed by Dr. Alok. Typical angina typically presents as a chest pain or a heaviness in the chest, often described as pressure or squeezing. It radiates to the left arm, neck, jaw, maybe sometimes back and in epigastric region also. So what we are seeing here, so this is the plot with fibrosis. This is that we are seeing the atherosclerosis of a blood vessel. So this is how the plot looks like in the blood vessel. Here there is narrowing, there is no occlusion is not there. So, and there is some, what happens is that some insult is there and the plot ruptures. And when the plot ruptures, there is formation of blood clot. You can see this, the blood clot is formed, and this causes the total occlusion of the blood vessel. And because it's total occlusion, we have MI, probably most likely the escalation MI occurs. And another mechanism of angina can be spasm of the coronary arteries. So these are the two mechanisms. One is occlusion, other is spasm of the coronary arteries. These are the two major mechanisms. So how do you diagnose it, the post-infarction angina? We have to take the detailed history. We have to look for the ECG and sometimes stress testing may also be required. Mind you, the stress testing should not be done in patients who had a recent MI. And EKG showing new ST elevation or a T-wave inversion during an episode of pain. So that can be suggestive of post-infarction angina. So another differential diagnosis why we have to differentiate between post-infarction angina is another diagnosis is pericarditis. So pericarditis, there is global ST elevation is there. There is no reciprocal ST depression is present. But in angina, there will be some reciprocal ST depression can be present, or there can be some T-wave inversion is present, that is present only during that episode of chest pain. So, for example, patient is having chest pain and you do the ECG, you see that there is some ST depression is there or some T-wave inversion is there. And then after you give him sorbitrate, chest pain is relieved, that STD goes away. So this is all diagnosis of post-infarction angina. What is the management? Management is, again, we have to give antiplatelets, give him rest, and nitrates, beta blockers, antiplatelets. So next complication is heart failure. These complications that occurs between 1 to 3 days after the heart attack. So it is caused when the heart muscle is severely damaged by acute MI and can no longer pump blood efficiently to meet the demand of body. So there is buildup of fluid in the lung, which causes pulmonary edema and systemic congestion manifesting as heart failure. So what are the symptoms? Patient will have fatigue, he will have shortness of breath, there is edema, or rapid or irregular heartbeat can be there. What is the management? If BP is more than 90, you give him diuretics. And second management is give him mechanical ventilation. Sometimes patients post-MI can have cardiac shock. That is their BP goes down. BP is less than 90. So depending on the various definitions, the generally accepted definition is systolic blood pressure is less than 90, there is hypotension and the patient is in shock. So this is again very important complication of patients who are having after the MI patient can have cardiac shock. So we have to be very aware of this complication. So BP is less than 90, extremities are cold, there is shortness of breath, and he is having symptoms of hypotension. What are the symptoms of hypotension? Like patient is having reduced urine output, he is having dyspnea, and altered mental status is there because no blood is reaching the oxygen. There is derangement in the creatinine. We can see on the blood report that RFT is getting delayed, so because of the hypoperfusion of the kidneys. So any symptoms of hypoperfusion, that means patient is in shock. What is the immediate management? You give iron drops. Iron drop is like a glutamine. You give vasopressors like dopamine and noradrenaline, and you do the coronary respiration for these kind of patients. When the patient is in cardiac shock, most likely the only way that he will benefit is coronary respiration. That is either by doing primary angioplasty or rescue angioplasty can be done or a CABG. So what is the role of healthcare professional in cardiac shock management? Constant monitoring of patient vital signs and symptoms are required. Prompt initiation of treatment measures to improve the patient condition. And educating patients and families about the signs of cardiac shock and the need for urgent medical attention in these signs are noted. Okay. So coming on to the next few complications that occur 3 to 7 days after MI. One is ventricular free wall rupture. So I will just explain it. What does free wall rupture mean? That the free wall of the left ventricle is ruptured because of the MI. So in this figure we can see. So what we are seeing here is that there is some defect is present here. This is the left ventricle. Some defect was present there. Yeah. So here we can see some defect is there, and this is the pericardial effusion has occurred. This is the left ventricle. So this is the complication of acute MI. So echocardiography has very important role in these kind of patients, and we have to look for serious chest X-rays. We can see the cardiomegaly is happened, patient is having low BP. So these are all the signs of ventricular free wall rupture. It is a very fatal complication. It has to be addressed immediately. So maybe this patient will require bypass surgery. So next complication is ventricular septal rupture. So it can occur in two conditions. Mostly sometimes it occurs in the anterior wall of MI and sometimes it occurs in the inferior wall of MI also. So like the posterior wall of MI. So this is the condition of an anterior wall of MI. This is the left ventricle. This is the right ventricle. This is the, we can see blood flow is communication was present. Let me show you. Yeah, so this is the ventricular septal rupture. We can communication is there between left ventricle and right ventricle. So again, how will you diagnose this? You have to do auscultation. Probably when you come for the rounds for your admitted patient, you look for the, you auscultate his heart and look for the pansystolic murmur, which shows the ventricular septal rupture is present. Measurement again is coronary respiration, and it can be done either percutaneously or by surgical method, whichever is feasible. And the third complication is papillary muscle rupture post-MI. So because of papillary muscle rupture, there is mitral regurgitation occurs. Again, how do you diagnose it? You diagnose by the signs and symptoms of heart failure, and the patient is having pansystolic murmur is present. So this is just a photograph. We can see this is left atrium, this is left ventricle. This mitral regurgitation is present. You can see that red colored blood flow is coming. So that is what is suggestive of mitral regurgitation. This is papillary muscle has ruptured. It should be attached initially at this part, but that papillary muscle has ruptured. So because of that, there is severe mitral regurgitation is present and patient is in heart failure. And next complication is post-infarction pericarditis. That is a Dressler syndrome. This is a pericarditis is inflammation of pericardium. So the sac surrounding the heart, which can occur following acute MI. So this is the body's inflammatory response to myocardial necrosis. So this is an inflammatory condition. So this is an autoimmune response, you can say like that. So symptoms include chest pain, typically sharp and versus with deep breath or lying down. There is shortness of breath. Possibly a pericardial friction rub can be heard on auscultation. So what is the management? Management again includes measures to reduce inflammation. So we have to give NSAIDs, we have to give high doses of aspirin. So we give this aspirin 625 mg QID. That is the high dose of aspirin has to be given. Sometimes steroid can be given, but mostly steroid should not be given. So this is the ECG. We can see there is global ST elevation is present. You can see all the leads are showing global ST elevation. So this is ECG of pericarditis. As compared to ECG of ST elevation MI, there should be reciprocal changes in the inferior lead, which is not present here. And last complication, the long-term complication, weeks to months after MI, left ventricular aneurysm is present. So what does left ventricular aneurysm means? So we can see this is the left ventricle. Now what we see here, image come. Yeah. So we can see this is the left ventricle. There is some dilatation is there. So this is the aneurysm part. What we can see. See, this is the left ventricle, which is aneurysmal. The ventricle is dilated. This is what happens many few weeks after MI. If the MI is not treated, the vessel is not revascularized. This kind of situation happens, and the treatment is again you have to give diuretics and antiplatelets, and these patients may require surgery most of the time for the final benefit. And what are the long-term complications? So we have to discuss the just discuss the short-term complications. Now coming on to the long-term complications after MI. First is heart failure. So if patient is in LV dysfunction and he is in heart failure, so you have to, one heart failure was the early complication that occurred within 48 hours. Now this is the one which is occurring long term. That is, patient has already had MI, he is stabilized, and now his LV function is less. He is in heart failure. So what are the symptoms? Again, patient is having fatigue, shortness of breath, edema, rapid or irregular heartbeat is there, and management includes the again diuretics and sometimes not many times, sometimes revascularization is helpful also. Another long-term complication is arrhythmia. So if patient is having LV dysfunction, especially if left ventricular ejection fraction is less than 40%. So these kind of patients can have arrhythmia like ventricular tachycardia, and it can be fatal. It can cause sudden cardiac death. So in these kind of patients, again, we have to give antiarrhythmic drugs. Sometimes intracardiac defibrillator implantation is also required. So how to prevent these complications? So the most important way of preventing the complication is primary percutaneous coronary intervention and the role of thrombolytics. These are the two most important modalities by which we can reduce these complications. And what is the pharmacological management? You have to give antiplatelets as early as possible, beta blockers, ACE inhibitors, and statins. And what is the role of lifestyle modification? He has to do smoking cessation, diet, exercise, and patient education. Any questions?
Okay, so now you are now we are more informed regarding the complications when they are happening in the patient's MI course, post MI course, and what how we can manage that. So those parts are being handled by the team, cardiologist team, the hub in the your model. They will handle the complication part. If any complication happens, patient goes into shock, patient goes into cardiac failure, we are there to help you. They are being managed at your center at spoke, or if they can be referred in a ambulance that to the hub. So if these patients coming directly with these complications, then you need not to do the thrombolysis then and there. You can refer this such patients if you cannot manage it in your setup. If the patient is not having any complication, if BP is stable, if pulse is stable, but patient is having chest pain, severe chest pain, doctor साहब दर्द हो रहा है मुझे बचा लो. Young patient, there is no contraindications. I will show you the checklist contraindications before taking patient for thrombolysis. And before that, if the patient come with the chest pain, so thanks, Dr. Suez. Suez, you should stay here, Dr. Suez. Dr. Suez, you have to stay here. We are panelists of the session. Busy schedule. I am thankful to him that he came all the way from his busy schedule, and he has to go back on the same schedule. He is bound to that. Thank you, Dr. Suez. So the WhatsApp network, we were talking about how we can help you, in taking decisions. So we have made a WhatsApp group, and that is a legal thing which we can do in telemedicine setup. So there is no legal issues in that, in taking the opinion from a cardiologist for a STEMI management. We are there to help, and we made a WhatsApp network, and in this we made a WhatsApp group. The group name is what we will do. We are going to do like go. Color like go. So so through mobile phone WhatsApp, Spoke hospital can ask the question regarding the patient problem, and we can help you in an ad hoc hospital. Ambulance person can also take the help, or patient also can take the if he has any access, given an access in our group. So in our group, patient is not there. The spoke medical officers and the other paramedics are there connected in this group. So this is the ICMR STEMI ACT Varanasi group, in which CMO sir is also there and various doctors from the spoke centers. Our the team SRF, PAL, Virender, data entry operator, everybody is there connected. Our all SR, Dr. Abhijit is here, Dr. Srishti is here. We have 14 SRs, 5 per year and 4 this year. This huge team is there, 24/7 we are having CCU, which can help in the diagnosis of your patient regarding ST elevation. And many renowned cardiologists promised, they are there, and others can promised national cardiologist, Dr. Negi and Dr. Duvini, they also consented to give the support. So what the spoke physician can do, or the paramedic who is doing ECG, they are transmitting this ECG along with the short history that patient is having. This is the clinical history. 26-year-old male, female complaining of chest pain. Pain started in the morning at about 10 a.m. Vitals stable, anxiety, restlessness, vertigo, and patient came at 1:17. So within window period, if ST elevation were there, then we can go ahead with the thrombolysis. Similarly, the 60-year-old female with acute chest pain, dyspnea, sinus tachycardia, shortness of breath, vitals are given. So the short history along with this ECG, if we get the window period in this, that what time the patient had severe chest pain of MI, suspected ACS, and what time the patient contacted you, and what time you have done the ECG, that data is very important. So if we get that, then we can help you in the diagnosis. That window period can be decided, and accordingly we can take combined decision whether we can go ahead with the thrombolysis if ST elevations are there. So ECG was having minor abnormalities here. So similarly, if the patient is having this ST elevation MI, and we have decided for the thrombolysis, and we have taken the consent, we have given the patient information sheet to the patient and explained about the procedure, and taken the informed consent. It's not simple consent, informed consent. We have informed the patient regarding the procedure and taken the consent. And now we are going to thrombolize. So we will discuss the checklist before that, and we will enter this whole data in the app same time, same day. So this is the app icon. There is a two apps. One is the STEMI ACT app for Spoke, and another is the STEMI ACT app for Hub. So this, when we click that app, we have to download this app in your phone, and we will give you the link, password, and username for each spoke center will be there. And when you open that app, you will find some such icons: patient detail, consent, history, clinical assessment, ECG, medication. Very simple steps which are there in your CRF, which we have provided in your. You can open that CRF part. Please open in your this thing envelope. There is a one page CRF is there. The similar information there in this same information is there in this app. So this will go in the national data. We will contribute to the national data to the ICMR, and it will be updated on the same date, same time to the national data registry. That's what the ICMR wants in this this thing, that the data should be uploaded same day for our patients which we are going to thrombolize. So patient detail, when we click, so we will find the incidence time when the patient had a pain. So that pain we can select, just select the date part. You will find this icon, this calendar, in which you can choose the date, and 26th May 23. You can select like that. And you can select the time. So in the clock, AM and PM is there. And in the CRF, probably you have to write in the 24-hour clock, but here AM, PM is there. The difference, minor difference is there. Then you have to enter the patient name, patient age, gender, you can select it. It's simple, one small information which can be entered easily within a 1 minute time. Patient contact detail and attendant contact. That's what I am emphasizing, that we should have 2, 3 phone numbers and patient address, so that if we lose the phone number, because patient are usually from that family or those background which are usually changes the phone numbers within a month, you will find a new phone number. So you will not, those numbers may not be working after 1 year when we are following these patients. So patient's address should be entered, proper postal address, not the address like just like the only area you have mentioned, and we cannot find the postal address should be there, so that we can post a letter that regarding the whereabouts of the patient. So follow-up is very important part of any study, and loss to follow-up should not be much in your study. That will give you very high impact of your study. So we are studying in this, that how much benefit we have provided by these efforts which we are taking whole day. We are here and discussing this thing. So we are, how many lives we have saved, we will compare. Baseline data is there, we will follow those patients and these patients which are having a timely thrombolysis and appropriate patient. So that is very important. So please do not take it lightly. You are just writing the area from which is Ramnagar only. Patient name is Tawfiq, and phone number is not there, and area is Ramnagar, which is entered by some layman. So it needs a proper postal address. It should not be only Ramnagar, right? So then patient detail we have entered, name and age and gender, and this is the consent part. Here patient signature can be taken here. This is consent, and so digital signature will also work like this. And patient's attendee consent also we can take if the patient is not giving able to give the consent. And patient medical history, so it's very simple single tick things are there. Patient is having chest pain, you take it, whether it is typical chest pain or atypical, you take it. Then dyspnea class, you have to click that, you will find dyspnea class is 2, 3, 4. If patient is lying down and having the breathlessness, class 4 dyspnea. If patient walks more than ordinary activity में उसको less than ordinary activity में हो रहा है तो class 3 dyspnea है. And in the ordinary activity में हो रहा है तो class 2 dyspnea. So dyspnea class is there. If the patient is having breathlessness even at rest, then it is class 4. So syncope, if the patient is having history of syncope or any other symptoms, you can write down. And then onset of symptoms is very important in the decision making, and this will show your efforts, combined efforts, community awareness program efforts, then your team efforts when the patient entering in your clinic, in your CSC or district hospital, and when he is getting the ECG done and thrombolysis done. These timings are very important to compare the data. One patient is having a thrombolysis at 4 hours, 6 hours, and one patient is having thrombolysis at half an hour. A lot of difference will be there in his prognosis. So comparison can only be done when we enter the time, accurate time. So it's very important. Please note down that onset symptom time when the patient had most severe pain. Patient may be having a small pain, little pain since many days. Do not count that. Well, and then he suddenly had a severe chest pain with perspiration, typically retrosternal pain radiating to arm, some typical pain or most severe pain with perspiration, maybe atypical pain, but with perspiration or with very severely disturbing to the patient along with the ECG changes. So what is the time of that onset of that pain, which is most severe one? Then any past cardiac history. So most severe one pain should be entered the time in AM PM model here. Then we have done the ECG and diagnosed that it is ST elevation MI, acute coronary syndrome. or it is only angina, no MI, no acute coronary syndrome, or nothing significant, or others. So similarly, you can enter the clinical scenario. So initial clinical assessment, patient is stable or in heart failure or in shock or hypotension or pulmonary edema. Vitals, so we have to enter pulse, BP, oxygen saturation. Then this is the saturation we are entering. Then you have to enter the ECG. So whatever ECG you have taken, you click that photo, and from your gallery you can enter the ECG. Then this is the ECG time when we have done the ECG. So patient came at what time and what time you are doing the ECG is very important. That will show the efficiency or set of your setup and benefit of the patient. If the ECG is getting delayed, we have to find out, introspect, and if there is any issues, we have to handle it. That ECG should be done within 5 to 10 minute time if possible. Within minutes it can be done, within 2 minutes it can be done if the team is there. If everybody is knowing how to do ECG, anybody who is free can do the ECG. It can be a physician. Dr. Manikant has given his name in the list of, we have asked each and every spoke that give you the list of the person who is trained in your setup to do ECG or trainable to do the ECG. And Dr. Manikant has written in the ECG technician list also his name. I'm taking his name because he has given that name. So that is showing the enthusiasm of the person that he wants to contribute. So if that enthu is there to save the life, then we can save it. So that will should be there, then only we will get the things done. So ECG date and time, is the patient on previous cardiac medications, so that we have to take if any medication he is taking for heart, like for hypertension, for anything else in the past. So that those medications should be entered. ECG we have uploaded, time we have entered. Now we have entered, we have crossed the 5 things. Now the medication part, the start date, end date. This is the summary, I think, at home. This is the summary of the patient. We are seeing the whole, whatever we have entered, we can review it in this patient detail part, patient summary. This is patient summary. So here we can see the patient detail which we have entered. If anything is to be corrected, you can go back and correct. Then ECG test and report, what the ECG says, it is enteroseptal MI or enterolateral MI or interval MI or infraval MI. Thrombolysis indicated or not, so that yes or no should be taken. For this part, we are always there to take the help in the decisions. Other finding on the ECG, so if it is STMI, then these should be taken. If it is not STMI, then it may be non-ST elevation MI, only ST depression, T wave inversion, or some tachycardia is there or not, or some bradycardia is there or not. Dr. Suez has explained regarding the possibilities of complete heart block in infraval MI or tachycardia in the interval MI. So these things are common. And then doctor's prescription. So that part should be submitted, that what medication we are prescribing, and the doctor's name should be entered here and submit. And if the bradyarrhythmia is there, complete heart block is there, or whatever arrhythmia is there, sinus bradycardia is there, or sinus tachycardia, so we can enter here. And then doctor's name, then prescription. Here is the space to type the prescription, so we can type the prescription here, whatever medications we are giving. Then doctor's signature, so he can sign the digital signature here and submit. Then enter to view message contain 3 messages from 3 chats. So like that we can see start date, end date. So this everything is there in your app, and you will find the summary of the patient. It's very simple things, just information like patient name, age, sex, what symptoms, chest pain, dyspnea, what is the ECG findings. You enter the ECG, then you get the what the medications you are going thrombolize or not going to thrombolize. So It's very simple things, which same thing is there in your CRF page, which one page we have provided. Similar thing is there in this app. We have to enter it now. In the baseline phase, we have not used this app, but in the thrombolysis phase, they told that we have to use this app. Then TNK ECG, we have to repeat the ECG after thrombolysis 15 minutes or 1 hour, so that we can upload to see the success of the thrombolysis. They have told that the more than 50% settlement of the ST segment which was elevated, if it is settled, then it is successful thrombolysis. Or if we scale the pain of the patient to 0 to 10 scale, we can ask that 0 से 10 में कितना अभी पेन बाकी है, 100 रुपए में 100 पैसे में से कितना पैसा पेन बाकी है, उसकी भाषा में हम कैसे भी पूछ सकते हैं। और वो उसके स्केल में वो बोलता है अभी 50% से ज्यादा रिजॉल्व हो गया है, 10-20% रह गया, तो दैट इज सक्सेसफुल थ्रोम्बोलिसिस, लेस देन 50% पेन ऑन द 0 to 10 scale. If it is less than 5 or mark given to the pain. So this is regarding app which we have to enter in each and every patient. Now I am going to show the things which we have to see checklist for thrombolysis. Okay, I got it. So this is the checklist for thrombolysis, and what we have to see in a patient when we are going to thrombolyze. This is the thing which we have to know in each and every patient before giving the thrombolytic agent. Is there any contraindication? So contraindication for thrombolysis is intracerebral hemorrhage history. Patient will give that सब हमें एक बार stroke हुआ था, फालिस हुआ था, जिसमें ब्रेन के अंदर खून बह गया था. उन्हें पता होता है ये कि सीटी स्कैन में क्या निकला है, या उसके पास सीटी की रिपोर्ट है, या उसको हिस्ट्री ऑफ स्ट्रोक है, then you can ask for more detail that it was hemorrhagic or not. So anytime in the life, intracerebral hemorrhage history, it's contraindication. Big no for thrombolysis, because you can have another intracerebral hemorrhage after thrombolysis. History of intracellular is AB malformations. A known case having a CT in his file came with the file where CT form or MRI finding is showing AB malformation, or patient is telling I am patient of AB malformation. Like that, you have to ask the patient that you are having any intracranial disorder which is having a AB malformation. So if the patient is telling some problem is there in my brain, you can ask specifically what is there. Intracerebral space occupying lesion, any tumor in the brain. So this is big no. There is high chance of hemorrhage. History of ischemic stroke within 6 months. If it is more than 6 months, we can go ahead with the thrombolysis. If it is less than 6 months stroke, ischemic stroke, where थक्का बना है, hemorrhage नहीं हुआ है, so then if it is less than 6 months old, do not thrombolyze. History of major surgery, trauma or head injury within 3 weeks duration. 3 हफ्ते के अंदर कोई मेजर कोई ट्रॉमा हुआ है, मेजर कोई सर्जरी हुई है, या कोई हेड इंजरी हुई है, within 3 weeks time, 3 हफ्ते के अंदर, तो हमें thrombolysis नहीं देना है. GI bleeding prior 1 month, 1 महीने के अंदर कोई GI bleed हुआ है, चेकलिस्ट है, जस्ट आपको टिक करना है. पेशेंट से पूछना है आपको कोई ब्रेन के अंदर ट्यूमर है, ब्रेन के अंदर एबी मालफॉर्मेशन है, ब्रेन के अंदर कोई हेमरेज हुआ है, कोई थक्के वाला स्ट्रोक हुआ है. पेशेंट बोलेगा नो 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 नो, यू टिक. पेशेंट बोलेगा यस यस यस, यू टिक. If any answer is yes, do not thrombolyze. Right? Bleeding disorders, aortic dissection, non-compressible puncture, liver biopsy और lumbar puncture. So यदि कोई recent में आपने उसको biopsy लिया है या puncture, lumbar puncture किया है, तो वो सब contraindications में आते हैं. तो ये checklist है. यदि इस checklist में कुछ भी yes आता है, तो then do not thrombolyze. It's contraindication for thrombolysis. Then यदि कोई contraindications नहीं है, तो हमें फिर उसको thrombolyze करना है. तो फिर हमें loading dose of aspirin देना है, हमें loading dose of clopidogrel देना है. Loading dose of clopidogrel is 300 mg. यदि more than 75 year age है, तो only 75 mg. So we do not give the loading in more than 75 year clopidogrel. Aspirin we have to give in each and every patient 325 mg chewable aspirin. यदि वो aspirin chewable नहीं है तो chew करने को बोलना है whatever aspirin you are having. 325 mg और 300 mg it's equal. So 75 वाले 4 टैबलेट चबाने को बोल दीजिए या डिस्प्रिन का एक टैबलेट डिसॉल्व करके दे दीजिए. It's same thing. So this is the checklist which you were asking. We will share this, don't worry. We will share. We have all the phone numbers and email IDs. Don't worry. So after this checklist, we have to decide the dose. You are having tenecteplase in your board, in your hospital. We will provide this injection or the state health services after finishing our stop. State health services will take over, and even before that they can take over. They are very fast and eager to give you all the logistics. They were there to assess our preparations. So tenecteplase to be calculated based on body weight, and it is given IV over 5 minutes. 5 minutes is much time. We can finish it in 5 seconds. No need to wait for this much time. Dose is injection tenecteplase. Dose is less than 60 kg, 30 mg, 60, it is 0.5 mg per kg, 60 to 70 kg, 35 mg, 70 to 80 kg, we can give 40 mg, 80 to 90 kg, 45 mg, more than 90 kg, 50 mg. इसका जो वाइल आता है वो 30 और 40 mg के उसमें आता है. तो यदि पेशेंट लेस देन 60 kg का है और आपके पास 30 mg का वाइल है तो यूज दैट ओनली. यदि पेशेंट का वेट 60 से ऊपर है तो 40 वाला वाइल यूज करिए और देन यू कैन गिव द 35 or 40 mg. And otherwise you have to open 2 vials for more than 80 mg patients. 2 vials should be opened to give the appropriate dose. So this is the checklist, and some more things we have to specify, and this we have discussed. This is the video of the same thing which I have discussed regarding the app that is there. Same thing which I have explained. It is video there. ICMR experts have provided to us. I'm just sharing it. The patient name you are entering, then patient is. It will take 1 minute time, hardly 2 minute time to enter everything. If it is to be entered in a patient going to be thrombolized, it will take 2 minute time, not more than that. You have to click the ECG. It will be ready in your gallery. You have to select it from the gallery and input. And the patient name is sex, date, time. If you have ready with the history in your CRF, same thing can be entered here. Sure, it is not moving. Sorry. I'll repeat it again. Hello? Make a sound. So it is shown here, patient name we are entering, then patient age, gender we are entering.
What is your name? हो रहा है, आ रहा है. लाइव आ रहा था. यही है ना सर.
So very simple thing which we have discussed. Same thing they are entering here, just showing it, just like a. I think you are using many apps. It's very simple to enter. If you are having the information, you can enter here. So if any questions are there regarding this CRF, you open the CRF, please ask me any clarification regarding anything you want from me to clear it. If I am not having answer, I will provide from the ICMR. So any questions, please ask me from CRF. So then ECG and feed it in the system. Which MI thrombolysis indicated or not? Yes. Tachycardia, sinus, CHP, anything, whatever is there, you can take it. Then the dose already written there. The options are there, aspirin, clopidogrel. You need not to type anything. Just single click away. Everything is only clicked. Only name and address you have to enter. I think name, address, and mobile number. That's the same thing. Other things, everything is tick, 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 tick. Only. It's very simple. If the CRF is filled properly, you can feed it very easily. And it should be done, please, it should be done on the same day from your side. It's very simple. After that, we have a 9 page to be filled. That CRF, which we are going to fill at hub. Or if you are treating the patient and discharging there and there, then you can also fill that part of information which is required from the area where the patient is finally discharged. If you are just giving the thrombolysis and discharging him, this much information enough. If you are giving further treatment, then the second 9 page CRF is there to be filled. So I will share it. It's a simple, same informations are there in more detail. The patient are staying, what medications we are giving it, and if the patient is going for an angiography and PDCA anywhere, then that information we will collect from that center. If it is coming to hub, we will feed that information. If it is not coming to hub, going to some other center, then we have to know from the patient. If you are giving us the mobile number, we will track this patient. Anywhere he is going or she is going, we will get the information with the help of CMO sir. We will have the authority to get the information from that hospital. So don't worry, patient may choose some other centers, even if you suggest for BHU. I got one information from one doctor physician that they have given written on the consent form, this patient does not want to come to BHU. So what? If he is ready to go to anywhere for the treatment, just take the consent. This consent is not for the treatment at BHU. This consent is just to take the patient's follow-up. He is ready to take the treatment and he is ready to give the consent for the follow-up. So whatever treatment you are treating, that consent is there. If you are thrombolizing that patient, the consent is there for thrombolysis, not for the referral. This consent form is not for the referral. Referral is routine part of your job that you are referring the patient. Do not write on that patient. That patient is not willing for the BHU to go to the BHU. Anywhere he is going, you just take the consent for the treatment, whatever your thrombolysis you are doing. Then you take the consent, and then if the patient is going somewhere, we will follow the patient from there. If you are giving me information of 2, 3 phone numbers and proper postal address, I can or we can follow it anywhere from the world. We'll find it out. So information should be proper so that we can follow it up. So I think Dr. Payal, she will present the whatever data we have collected, what interesting findings are there in the data she is going to present. So that is very important to know where we are. She is our senior research fellow from this ICMR STEMI project, and she will be interacting with you people at spoke centers, and you will must be having regular call during baseline data collection. is from Biostatistics Department, PhD from the फाइल के बाद कास्टिंग वीडियोस हैं जो ईसीजी कैसे लेना है, ईफिप कैसे देना है. डॉक्टर अभिजीत इज हियर, सीनियर रेजिडेंट फ्रॉम डिपार्टमेंट ऑफ कार्डियोलॉजी. He is going to explain and by through video also each and everything. So very interesting part is remaining. So please be here, and after that there is a evening tea and snacks ready. So we will, before dispersing, please do not forget for tea and snacks, and before that 2 important lectures. Please stay with us, be here with us. Sorry.
Thank you, Dharmendra sir. Good evening, everyone. Myself, Dr. Payal, working as a senior research fellow in ICMR STEMI project. And today I'm going to experience all the challenges, whatever I have experienced during the visit of CSCs, during the survey, during the data collection. So the topic is experience and challenges during mapping and baseline survey. So before starting the session, I just want to explain what is STEMI. What is the full form of STEMI? Evaluation of a health system based intervention on change in the thrombolysis rate in ST segment elevated myocardial infarctions, acute coronary syndrome across selected districts of the country. A health implementation research project. The data collection was started from 1st of September 2022, and the baseline data collected period between 15th of December 2022 to 15th of March 2023. So this is the table of the district implementation year. Total population of the Varanasi, this is the estimated population of Varanasi district, 4.5 million. And the population of greater than 18 years is 2.9 million. This is also an estimated population. And estimated number of STEMI per year is 9531. So, you can understand the burden. And the number of spoke implementing STEMI program is 12. So we have 10 CSCs and district hospitals and 2 private hospitals in this STEMI care project from Varanasi district. This table is showing the contact number of spoke hospitals. So we have 10 district hospitals and CSCs, 3 district hospitals, and remaining 7 are CSCs. So first one is Pandit Deen Dayal Upadhyay Government Hospital, Varanasi. Second one is SSPG Hospital. Third one is LVS Ramnagar. And these are the district hospitals. Then CSC Shivpur, CSC Cholapur, CSC Araji Line, SBM Hospital Bhelupur, CSC Hathi Bazar, CSC Narpalpur, and CSC Misirpur. And these are the districts from the hub center, and the name of the nodal officers from east hospitals and spoke centers. Their nodal specialty and telephone number are available. And these 2 hospitals are we are taking in a private hospital in our this STEMI project. First one is Galaxy Hospital, and second one is Trimurti Hospital. Spoke center details. So we have just contact to all the MOs and CMS from all the CSC and district hospitals. Then we have collected this information. I have also the detailed information in my next PPTs. So these are the ECG presentation or the status for each district hospital and CSCs, defibrillator machine availability, functioning or non-functioning, MOs, means what is the human resource for particularly emergency. Okay, the nurse and ECG technician and TNK availability. So you can see zero DNK is available in all the district hospitals and CSCs. This graph bar diagram is showing the spoke-wise ECG machine details. Okay, so we have one ECG machine in Deendayal Hospital, two SSPG, one in LVS Hospital, one in CSC Shivpur, one in Cholapur, two in Araji Line, two in SBM Bhelupur, and one in Hathi Bazar, Narpatpur, and Misirpur. These are the status of ECG machine availability. Then these graph diagram is showing the functioning of these ECG machine. So you can see all centers have the ECG machine availability. All ECG machines are functioning in e-centers except CSC Shivpur. And this is the defibrillator machine availability status. So we have only Deendayal Hospital and SSPG Hospital have the defibrillator machine. And this graph is showing the total number of doctors. So we have collected the data and they have taken these information, the doctor who are attending acute chest pain or suspected MI patient. So this table is showing the MO detail during the emergency. So total 10 MOs are in DDU, SSPG 8, in LVS 5, CSC in CSC Shivpur 3 are MOs will present in the emergency, and in CSC Cholapur 5 are there, Araji Line 6, Belupur 3, Hathi Bazar 2, Narpatpur 3 and 3 from Misirpur CSC. As well as we have collected the information for the nurses and for the ECG technician. So these are the status for both the thrombolytic therapy during the nurse, for the nurses and the ECG technician during the emergency period. And this ECG machine detail is for the Galaxy and Trimurti Hospital. So you can see Galaxy Hospital have 3 ECG machine and Trimurti Hospital also have 3 ECG machine. And Galaxy and DP machine status is Galaxy Hospital has 5 and Trimurti has 3. DP machine functioning is Galaxy has a 5 DP machine, and out of 3 DP machine, Trimurti have only 2 functioning. So this is the spoke checklist. So this checklist is for while we are visiting in the CSC or district hospital. So we have made this checklist under the supervision of our Dr. Dharmendra Jain and some protocol from this ICMR. So ECG machine for diagnosis, is it functioning or not functioning? If ECG machine is available, then is it functioning or not? That's more important to know. Then DFI machine is having, if that particular spoke is having, then these are functioning or not. 22 to 4 multi-parameter and hydraulic bed in a room, which is preferably for AC for CCU purpose. To identify the persons for doing ECG and physician and nursing staff for giving thrombolytic agent 24/7. ALS ambulance for post thrombolysis referred to hub, high center and tie with the 108 ambulances. So availability of drug, ECG or DP machine working or not, maintenance of cold chain, number of chest pain cases, number of STEMI cases, number of STEMI cases thrombolized, number of STEMI cases referred to hub from spoke, and name and signature of the employees of this spoke with seal. So these are the checklists we have prepared for spoke visit. This pie chart is showing the distribution of the cases from our hub. So these are the district-wide distribution of the cases from hub. So you can see majority of the cases are coming from obviously from Varanasi district, followed by Gazipur, Chandoli, and almost 7% similar percent coming from cases coming from Kamur, which is Bihar, then Bhadoi, Jaunpur, Sonbhat, Azamgarh, Balia, and others. And this is very important data we have collected during our baseline study for last 3 months. from 15th of December to 15th of March. So out of, we have collected 100 patients from our hub and spoke hospital for our baseline data collection. And out of 88 STEMI patients, 12 were 29 were patients coming from the thrombolysis, and out of 12, 8 were thrombolized. And these 12 spoke center thrombolysis status is only from the private hospital which have taken like Galaxy and Trimurti, and remaining other CSCs and district hospital and spoke hospital, we don't have data because only 1 or 2 cases were ECG were doing by their MOs and nurses. So when we have initiated this program with the help of the ICMR, and then the main effort, we have many other figures are coming right now, so they are improving day by day. So we have collected baseline data from more than 100 STEMI patients from hub and spoke hospitals. We will start the intervention phase of thrombolysis soon. According to the interim data analysis, many patients are not thrombolized. There are many challenges faced by spoke centers like manpower, ECG technicians, nursing staff, and medical officers, and logistic problem like ECG machines, different DV machines, and non-functioning of these machines. These are the problems we are facing. So now I'm going to show some pictures during the visit of district hospitals and CSCs with the team of our STEMI care project with Dharmen Jain sir, with the CMO office, Shiv Shakti sir, Atul sir, CMO sir was also there. So this picture is during the visit when we have visit SSPG hospital, Kabir Chowra. So you can see the picture, and there we have just checked the ECG machine is functioning or not. Do you have ECG machine? These are the checklists we have prepared before visiting the CSCs and district hospital. So our first question was, do you have ECG machine? If they are saying yes, we have, then what is the status? Is it functioning or not? If is it functioning, then we ask, is there any ECG technician? If is there any ECG technician, we just tell them to please do a ECG, and Dharmen sir was check that ECG machine is functioning or not. So whatever data I have presented, we just physically visit particular center or CSCs and spoke, then we have prepared the data. So these are some pictures during the ECG machine, DP machine demonstration by Dharmen sir, and this picture is from Pandit Deen Dayal Upadhyay Hospital with the CMO sir. CMO sir was also there at that time, and this picture is from CSC Shivpur. This is from Cholapur. This is from CSC Misirpur and LBS Ramnagar and Arazi line Narpalpur, and then Hathi Bazaar and SBM Bhelopur. So thank you so much.
So thank you, Dr. Nair, for enlightening us from the data baseline, little information. Detailed data will come at the end of 1 year follow-up. That we will also share in the further meetings. We will have quarterly meetings. Dr. Avjit is there. He is senior resident from cardiology, and he is going to. I'm inviting him on the dais, and he is going to explain how to take the ECG by video. Then he will explain how to use your Dept machine, and he will also going to. I have one very interesting case which is done today only. We have done the thrombolysis with tenecteplase to our faculty at 6 a.m. He had a chest pain, and we have thrombolized at around 5 a.m. he has a chest pain, and at 7 a.m. he got the thrombolysis with tenecteplase at our center. So I will show you that data also. So Dr. Avjit is going to explain, and you can ask the questions and how to how to prepare to the nursing staff there, how to prepare that thrombolytic agent. So that is two videos are there for that also. One is given by some company and another one we prepared today when we were thrombolizing our faculty. So that is also there. Okay. प्रेजेंटेशन बनाया ना डॉक्टर नाबिल को फॉर्मलाइज थोड़ा धीरे सुबह फॉर्मलाइज किया ये तो वीडियो है डेटा तो वीडियो वो खोल दो बता दो इसमें है इसमें है नहीं वर्ड ट्राई है इसमें है ये
नहीं जो भी दिया मैं डाल दूंगी ये है सर
ये है ना तो
वर्ड फाइल
कौन सा वाला ये
यहाँ लगी है 961
It's a very interesting case. Display नहीं है, share करो। यही बनाया। ये वर्ड है, what much? Screen को share कर दो। ठीक है। उस पर क्यों नहीं आ रहा है? This was a 44-year-old male patient. He is faculty here. I am not disclosing the name. So this patient was having his doctor by occupation, no addiction, family history of cousin was having MI at young age, and then parents with history of stroke. Father and mother both have a stroke. Father died of a stroke. Mother is alive. With chest pain for and came with the chest pain to the hub center. So onset of chest pain today, 5:15 a.m. He had a chest pain at home, and then he took some sublingual sorbitate and the aspirin, and then came to hospital. BHU at 5:45 a.m. After half an hour of pain, he is lucky to get the immediate admission to the hospital. ECG was done with which showed the ST elevation MI ST elevation in the infralateral leads, and he was given loading dose of aspirin, clopidogrel, and 300 mg atorvastatin, and shifted to CCU after taking history and contraindication for thrombolysis, and he was thrombolized with the tannic triplase 40 mg IV bolus at 6:10 a.m. and his chest pain was subsided and his ECG changes were reverted. So after that, we repeated the ECG. This is the cardiac markers normal initially, but ECG is showing clear-cut ST elevation MI. Anybody can tell the diagnosis? What is the ECG is showing? Anybody? Where is the ST elevation? Tell me the leads. Tell me the leads showing the ST elevation. Right, so 2, 3 AVF, V4, V5, V6 having ST elevation more than 1 mm. 2, 3 AVF and V4, V5, V6 having elevation more than 1 mm. It's infralateral MI, and then after thrombolysis, this is his only. So changes are reversed. So and pain was also relieved. So can you see that the ST elevation is totally gone, and it is timely thrombolysis can reverse the STD changes. He is having little sinus tachycardia, no STD changes. So the importance of thrombolysis, we will show you the video of preparing that thrombolytic agent. to the nursing officers available here. How to prepare it. 2 videos are there. Show that. So this is the injection available for Tenecteplase. I just share the. So Tenecteplase injection is there. It is having powder in it, and one distilled water is provided with that. Share करो. Screen share करो.
नहीं आ रहा है. नहीं चलाना है. शेयर करो. क्यों नहीं चलेगा? क्लिप हो गया क्या? कट कर दिए. नहीं चल रहा. कौन सा ये है?
Okay, so this is the Tenecteplase injection 40 mg. It's available with various companies, and it is provided with the one distilled water along with it and one syringe. So just you have to take that distilled water in the syringe, and when you are injecting it, then the jet of the water should not go directly on the powder. It should go to the wall. It's very important detail. It should go to the wall of the that vial. It should not hit the powder directly. Otherwise, there will be precipitation. So you just hit on the wall, and then he's preparing the distilled water. And after that, when we want to dissolve it, then it should be rotated in one direction only. It should not be to and fro. It should be rotated in one direction. You can put it in the table, and in one direction you have to rotate it. So in this case, it was dissolved immediately after putting it in the. So it should go through the wall, not on the powder. So it's hitting on the wall tangentially, and then it was prepared. There was no. It was prepared immediately. He is not needed to rotate, but usually we rotate it in one direction to dissolve it, and then we have taken it according to body weight and push it in 5 seconds. You can push it. There is no need to go for longer for many minutes. So within 5 seconds, you can save that patient's life and give the relief from pain. Second video is also there for preparation of this vial. One important thing, one important caution, that if the dextrose is going, if the dextrose is there in your IV line, please flush that line with the saline, and it's after giving that thrombolytic agent, then again we have to give only saline only initially. Do not mix it with the dextrose, otherwise precipitation is there. So do not give it with the dextrose line. It should be given with the saline only. Right? Before and after, there should be saline only in that venflon. No dextrose. So you flush that dextrose, then give this injection, and then again flush with the saline. Flush with the saline, remove that dextrose, give the injection, and then again flush with the saline. Right? So pre and post saline should be there. No dextrose.
Yes. You have to do is step 1. Determine the correct dose of Glaxin based on patient's weight. Step 2. Withdraw the appropriate volume of solution based on patient's weight. Step 3. Flush a dextrose-containing line with a saline-containing solution prior to and following the administration. Step 4. Administer Elaxin as an IV bolus injection over 5 seconds. Step 5. Do remember that along with Elaxin therapy, it is very important to administer the right doses of antiplatelet and antithrombin co-therapy. This is primarily to reduce re-occlusion and re-infarction rates. Dissolving the thrombus is the main focus of the thrombolytic agent, and Elaxin has a very unique mechanism of action. Now let's look at the thrombus itself. Inside the thrombus, there are strands of fibrin, the protein that forms the clot. Meshed within the fibrin is the plasminogen, the inactive precursor of plasmin. When Elaxin is administered as an IV bolus, it binds to the fibrin in the thrombus and converts plasminogen into plasmin. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, the blood flow is restored and viable tissue may be reperfused. Elaxin today is recognized as one of the most efficacious.
Go ahead with the other videos. So any questions from nursing officers regarding preparation of this injection? It's very important to know how to prepare this injection because the right dose should be chosen and it should not be mixed with the dextrose, and it should be prepared by giving the jet of the distilled water on the wall and rotating in only in one direction. These 4 things should be remembered while preparing. Any questions from nursing officers? Then we were going ahead with the ECG. So some technician and nursing staff and our physician, if any questions you have in doing ECG, please ask. Everybody should know how to do the ECG. He is trying to explain by a simple video. We have to put the electrodes on chest. We prepared nicely the actually what we are doing in routine while we are doing ECG. Electrodes should be the color coding is there in the limb electrodes. So you can remember the mnemonic was given by some nursing officer at DDU. He told that we remember it like this. Start from the right hand, lal, then pila, then kala in right lower limb, and hara. So la, pi, ka, ra. La, pi, ka. Very simple to remember. From right hand you start lal, pila, kala, and hara. No confusion. So this should not be. If we are putting the electrode in and reversing the electrode, then ECG lead will have the reverse direction when we are printing it. So the information may be in we can pick it up because we can see the problem in there in the limb lead reversal. That problem we can pick up which lead is reversed. That can, it's very simple question. First question to be asked when we are learning how to do ECG. So limb lead reversal is very common problem, and la picker is the simple thing which we can remember. Lal pila kala hara, lal pila kala hara. So after that we have to put the electrodes on chest leads. If it is having all 6 electrodes in your machine, you can put all 6 electrodes there simultaneously. We want to be 6. Where to put, Dr. Abji?
We will be putting the first lead in the right side of the sternum in the 4th intercostal space. The second lead, which is printed by yellow, in the 4th intercostal space left side, as you can see. The 4th lead is put in the 5th intercostal space in the mid-clavicular line. And the 3rd lead is put in between the first and second and the 4th lead. And the 5th lead is put in the anterior axillary line, and the 6th lead is put in the mid axillary line. As you can see, this is the 4th intercostal space.
Very simply, you can remember what he is telling the some landmarks. The 4th space for V1 in just parallel to sternum, which is the how we can identify where is the 4th space, how we calculate. Anybody from the house? How we can calculate we are at the 4th space intercostal space. What is the landmark we use to identify the space? Very simply and immediately. It should be on the right place, then you will have the right information. How we identify fourth space? So, so the second rib is there, where the junction of this maneuver, you will have some ridge on your sternum. You feel that, and that ridge is there. That is junction of manubrium sterni with the sternum. So that junction we can palpate just by putting a hand. Even you just slip the hand, you will feel that there is a hump. So that hump is there in the second space. So below that two space is the fourth space. So in the fourth space, right side you put V1, on the left side you put V2, and then V4 you have to come down below the nipple, usually mid-clavicular line. So middle of the chest, that is mid-clavicular line. That your this collarbone, middle of that is the fourth V4. Below the, usually it is below the nipple, but it can be right or left little bit. So in mid-clavicular line, that is fourth, and between second and fourth is the third. You put a line between second and fourth, and then between that there is a third. So and then fifth and sixth is anterior axillary line. So this is your armpit. So armpit line is anterior line is that is for V5, and middle of that armpit is mid axillary line. So this armpit is called axilla, you all know. So anterior axillary line, then mid axillary line. So that is in the same level where we put it the V4, same level, same horizontal level. V4, V5, V6 in same level, mid clavicular line, anterior axillary line, and mid axillary line. Mid clavicular line is the middle of your collarbone, right? Clavicle. So middle of that, below the nipple. So that is your P4 in fifth intercostal space. Then parallel to that, in same horizontal line, V5 and V6. Any questions regarding this? Because if we put it in the wrong place, we will not have that much of information which we want. So it's very simple to remember. Fourth space, right, left. Fifth space in middle of the chest, and the same line 5 and 6, and we will draw a line in between second and fourth. That will be 3. So quickly we can put it and do the ECG. Any questions regarding this? Any clarification in putting the leads? Any confusion regarding putting the leads? If we are putting all, your machine is not 108. In previous 108 machine was having a single chest lead. We have to put single lead here. Take one V, select the V lead in your machine, and then take ECG 2-3 complex. Then you have to change the place V2. Then you choose the V there, press it, take the ECG, start and then stop. 2-3 complexes. Then again put it in the V3, then V4, like V5, V6. And you have to write it on that V1, V2, all everything. Now newer machines which are having all 6 electrodes, so you will get a simultaneous early ECG in a single strip, and simultaneously you put the all 6 chest leads and 4 limb leads, and you will get the answer, the whole ECG in one button. So that is there in the machines which are having 3 channels or 12 channels simultaneously. So bigger machines are there. So other different models are there. Any questions for any model, you can ask anytime. We will show you the demo for a specific that machine if you need. It's not a rocket science. Our CMO tells that everybody should know regarding doing the ECG. So any questions regarding this, putting the electrodes, please ask. Feel free to ask. Otherwise, we are going ahead. If no questions, that means you understood the procedure of doing ECG, putting the electrodes, and you will do it to all your colleagues there. You are the trainers for them. Understood? You are trained personnel from this ICMR STEMI project, and you will going to train your colleagues at your place. That I will ensure that from your CMS or MO in charge, that they will give you opportunity to train your colleagues. so that it will be propagated to all your colleagues whosoever posted is an emergency. You will, when you are handing over your work to your next person who is coming, he should know how to do ECG. So then the purpose is over. So we are training the trainers here. You are the trainers for your center. Understood? So you feel free to ask any questions. We are there. You are trainers. This is not, this is a training programs for the trainers. To explain, Dr. Abhijit is explaining again emphasizing the same thing.
This is again a recap of the same video which you have seen. That leads first have to be placed correctly. The green is to be placed on the left lower limb. Green is the lead that contains the green color, not the clamp. And the black is to be placed on the right lower limb. As you can see, the yellow which is to be placed on the left. And the red to be placed in the right upper limb. These are the upper limb positions which you have seen. This is a very important thing. This is the most important part of this project to do an ECG properly. Otherwise, if you replace the leads differently, you can mimic as an anti-wall MI and falsely thrombolize the patient. These colors have to be remembered. This is the only thing that is important in the limb leads. This is the yellow color and this is the red color. You can also remember right for red, right hand is for red. And the chest leads, as Sir has explained very beautifully, that it is from the manual, it is from the fourth intercostal space, and on the ridge you can count 2 spaces downwards, and then place on the right side the first lead, just parallel to the sternum, and the second lead on the left side. Ideally, you should place the fourth lead first in the mid-clavicular line, as Sir has explained, and then place the third lead in between both. Then to see the axilla, the anterior axillary line, which is the front part, you place the fifth lead, and in the mid part of the axilla, you place the sixth lead. After placing the leads, you have to confirm the positions. Actually, it is color coded also, but it's very difficult to remember this color code. It is written in the leads C1, C2, C3, C4 to C6. So chest lead 1, chest lead 2, chest lead 3, 4, 5, and 6. So it becomes very easy. Don't need to remember these color codes. This is the mid-clavicular line, as you see. Fourth lead is lying in the mid. This is the anterior axillary line, where fifth lead is placed. You can see, you can switch. After connecting the leads properly, you switch on the machine. You will get, if you have a monitor on the machine, you will get a tracing to confirm that the leads are correctly placed. Otherwise, there will be, if suppose B5 is not correctly placed, then in place of B5, you will get errors. You will get zigzag lines. So you understand that B5 is loosely placed. You will have to place it correctly. Then you can print out the ECG if the pattern is okay. So coming to the next thing, which is defibrillator. This again is a very life-saving thing, a very easy thing. When I was also an MBBS, I was scared of the defibrillator. I thought it was a very big thing, but now I know it's a very simple, it's the simplest thing to do to save a life. All you have to see is that ECG pattern. If the ECG pattern is something looks like this, so this is obviously not a sinus rhythm, this is a completely bizarre rhythm. Or other wide complexes with a very high heart rate and the BP is not recordable. Then these are the rhythms which indicate ventricular fibrillation and ventricular tachycardia. All you have to do is to stop. I will tell you through a video how to how to give a shock to a patient. But once there are some rhythms which will not be shocked because it will not show any benefit, especially in asystole. When there is asystole, there is no use of defibrillating the patient. Or once there is pulseless electrical activity, then also there is no need to restore the patient. There are some mechanical electrical decoupling, so these things are not to be used. Defibrillators. Okay, so this is the simple picture showing the buttons which are there on the defibrillator. See, there are buttons which include, first is manual defib. First is manual defib, which means you have to select the energy and place the leads on the correct position and then give the shock. Okay, then I'll show you the video how it is. Then second is monitor. Monitor is just for emergency purpose. So you want to, and you don't know what is the rhythm, but you just want to see the rhythm. That you can place the leads on the chest and the pedals on the chest, and then you can see the rhythm. Obviously, there is an off button, and there is a pacer button. This is for temporary pacing. This is not for the purpose. And then there is AED. AED you have seen in the airports or other railway stations or other for automatic defibrillation. Okay, so it has patches which automatically adjust the rhythm and they shock whenever they feel their rhythm is like BT or BF. This is the entire machine how it looks like. I actually zoomed into the buttons to show you the importance. The energy select is there. I'll show the video how it is done. This is the video showing the defib. This is defib. This is the buttons that I showed you. This is the first, that is the it has been done first. So first is manual mode. Now you can see from plus and minus button, you can adjust the current which you want to give. So it is ranging from, you can still go up to the 5 millivolt and then it can go up to 360 millivolt. 360 volt it can also go. But in case of ventricular tachycardia or fibrillation, we start from the 200 and then go up to 360 if the patient is not converted. These are the pedals. These are actually fixed with a stopper in the top of the defibrillator. We have marks on the defibrillator pedals where to be placed. So there is no confusion. It's already made on the chest. See, this is the chest diagram made, and where it is to be placed, it is there. So you have to just place it, adjust the charge, and then shock the patient. This reverts the patient into the sinus rhythm most likely, and if it is not inverted, then you can increase the voltage up to 360 and then stop the patient. There are other modes which I have already told you that we can put it on monitor or AED. Any confusion until this? It is a very simple thing. You have pads, it is already mentioned with a chest diagram where it is to be kept and given the shock.
He is very nicely shown the shockable rhythm and non-shockable rhythm. So non-shockable rhythm is asystole. He has shown the straight line. Nothing is there. No complexes. Or some pulseless electrical activity where some electrical spikes are coming, but there is no pulse. They are coming at very slow pace. So that is not having a definite proper QRST complexes. So these pulseless electrical activity, not having tachycardia, and the asystole, which is straight line, no need not to do any defib. No defibrillation is required. Just you do the CPR, cardio CPR part, all you know. And shockable rhythm, here definite complexes are there. In VFib ventricular fibrillation, the rate of this is very, very high. So they are coming as a chaotic rhythm. It's not having any baseline, and it's coming. The complexes are there. Definite complexes are there, and they are coming in chaotic way, and no definite pattern and no definite QRS complexes. But we are seeing some complexes up above the baseline or below baseline, but definite complexes. But they are coming at a very high rate, so it's a ventricular fibrillation. Another one was the below. That was the ventricular tachycardia, where broad QRS is there, patient is pulseless, then you can shock it. If not pulseless, you can try some medications like Emadron, Quadron, or Zalocard or something. So antiarrhythmic. So DP is required when the patient is having shock, pulse is not palpable, and he is having hypotension. And along with that, the broad complex tachycardia, there is ventricular tachycardia is there in your ECG monitor. So that patient, when we are shocking, there is one more thing to be remembered. The button is there where we can synchronize this shock. Showing that is there. Okay, so there is a one button. If it is VT, you are having a definite QRS complex, right? In VT, it's a broad QRS tachycardia. So everything is same, rate is high, and it is having a broad QRS. So in background of coronary artery disease, all broad QRS tachycardia is ventricular tachycardia. There is no confusion. Then you have, if it is in shock, BP is not there properly, hypertension is there. Then we are going to defib. It should be synchronized from the QRS. Why to be synchronized? If we give shock and if we put it in the ascending limb of T wave, if we give shock at that time when it is ascending limb of T wave is there, then VF will precipitate. That is more dangerous thing. So whatever BP is there, that will also lost. In VF, the rate is 400, something like that, 600. So the heart is not contracting at all. It's just shivering there. So at that time, we do not want VT to be converted in VF. So we synchronize it with the QRS complex. So if definite QRS is there in your ECG, then we have to press the synchronize button and then give the synchronize. Then we give the shock. Two buttons are there in this pedal. You have to press these two buttons simultaneously. Shock will be delivered. And when we are putting these electrodes on the chest, pedals on the chest, then we have to firmly grip that pedals over the chest so that the shock is delivered rightly to the heart. And the simple rule is there that it should cross the heart. Your current should cross the heart. So when the patient is lying down, so then you have to put one pedal here on right side above the nipple. You can put it here, and here on the left side below the nipple you can put. So it will, when current is passing from this electrode to that electrode, it should pass through the heart. So that should be remembered. If we are putting it one patch front, and there is some patches also available to give the shock, so then one patch should be behind, so it should cross the heart. So options are there, and I think these buttons, yellow buttons are there. We have to press both the buttons simultaneously when we are giving the shock, and we have to give some jelly on the chest so that it should not burn your skin. If you are not having jelly, you could put the saline. So proper contact will be there, and you can put the Jalocan jelly also if you are not having any other thing. So that skin should not burn, and proper contact will be there, and you firmly grip that, and then just press the button. Shock will be delivered. Before delivering the shock, everybody should clear from the bed. Nobody should be touching the bed. CPR should be stopped for that part, and everybody should out. Do not touch the bed that time because they can also get the shock in. So everybody should be clear from the bed. That shout should be there from the person who is going to give the shock. So that shout should be clear to whole team who is attending it. That everybody should clear, then give the shock. Go ahead.
This is what I was showing, that the pedals are kept in the positions, and then manually you can shock the patient. There is a button over here, yellow color button. Simultaneously you have to press both the buttons, so the shock will be delivered. And before giving the shock, as sir has said, and you must see that nobody is touching the bed, so that the shock does not get transferred to them. And as soon as the shock is done, you should not wait for the thing. You should start CPR again, so that the circulation is restored. And then if you check the BP, the BP is okay, and the rhythm has reverted to sinus rhythm, you can again start with the other managements. So any queries from the currently use of defibrillator? Again,
Monophasic is out.
Now
Nobody is using
biphasic
monophasic. It's biphasic only available, and limit is 300 joule.
360 is the maximum.
That is not required usually. It's 50 to 100 joule usually is more than enough for a VT. For AF, we give the more joules, 150 or 200. Usually 50 to 100 we can revert the VT, and 200 and 300 that is required rarely. If first attempt is not working, then second attempt you go with the doubling that dose. So yeah, aid is a very interesting thing and can save the life at public places. So government has made mandatory to provide AED at all public places like airports. You can see that AED devices are there. It is written there in glass. That one hammer is there to break that glass, and there is a AED device in that glass. AED device is simple defibrillator which is working automatically. You need not to do any ECG. It will automatically interpret the ECG. It will take the ECG automatically inside its brain and in the circuit, and it will interpret the ECG. And if it is shockable rhythm, it will give the shock. It will tell you, it will loudly tell you that we are going to give, it's a shockable rhythm. When we connect the electrodes, just you connect the electrodes and start the machine. It will read the ECG. It will tell you loudly that it's a shockable rhythm. It will tell you that we are going to give the shock clear from the patient, and then shock is given, delivered. You have just attached the pedal and start the machine. It will do everything. It's a very simple thing. It should be known by each and every public. So it's a public place use. Every person of the country should know how to use AED. So its AED mode is there in this. It is not for our hospital purpose. AED mode is there for the public purpose. Here in the hospital, we use directly, we shock the patient. You were asking some, Dr. Sushakti, you were asking some question. No atropine. First you give the CPR for 3 minutes. When you are dealing with a patient who is having no pulse, you are giving a shock in a shockable rhythm. Immediately after giving the shock, you start the CPR. Do not try to interpret the rhythm. You just give the CPR. ECG is coming. You just interpret the ECG. After finishing that CPR part, then you interpret the ECG in between. And if it is sinus rhythm, you just try to feel the palpate the pulse. And if the pulse is there, then you can stop the CPR. If palpable pulse is there, well, means this everything is reverted, because immediately after the shock, it is stunned heart. It's not moving at all for a while. That time it needs CPR. But after that, once the rhythm regains, it you can see in the monitor pulses are there. So in that period, it needs CPR. And if suppose it's not reverted, again you see the VT, or VT is reverted and again you get the VT. The current VTs are there. Then you have to give again shock. Then you have again clear everyone, load the defib with the required dose of energy. Just you dial that part, you select that part. कितना जूल देना, जितना पहले दिया उससे double. 50 दिया है तो 100, 100 दिया तो 200. So you select that energy and give the shock again. And if it is reverted, well and good. Not reverted, you can again shock it. You can fry the patient. And I remember one patient was having some electrolyte imbalance, and By the time electro report, we have given n number of shock. Whole night I was giving the shock to the patient, saved that patient life, and next day morning patient gone home with everything okay. So there is no limit. There is nothing to be done. You see the ECG. If it is having definite QRS complex like VT, then you have to synchronize. You have to just, the button is there, synchronize. That button is there in the your defib, and that button to be pressed, synchronize. That's it. It will automatically read that QRS. Once the synchronized button is on, just you put that on that button. When you are giving the shock, it will wait till the QRS, that R wave, top of the R wave, summit of the R wave is there. It will give shock there only. It will read the ECG. आप प्रेस करेंगे, वो आपको तो प्रेस करना ही है. It will not give the shock till you have to press it. आपका शॉक जब तक डिलीवर नहीं होता आपको छोड़ना नहीं है. बटन दबा रहेंगे, वो अपना वेट, वो फ्रैक्शन ऑफ सेकेंड है बॉस. आप जब तक दबाने में टाइम लगे उतनी देर में तो कितनी वाली बीट्स निकल जाएगी. बीटी चल रहा है वहां. It's a fraction of second. Yeah, when it is shockable rhythm. If it is VF, there is no definite QRS, then no need to give that, press that button of synchronization, because there is no QRS to be synchronized. So then no need to press that button. You just give the shock. So you saved that life now. So you should know how to use it. Then only you can use it. Na? So it should be proper use, properly crossing the heart. That current should properly crossing the heart. Proper contact should be there with the skin, and it should have some jelly, ECG jelly or any Jalocan jelly or any jelly or anything should be available, so that it should not burn your skin. Otherwise, it will burn, give the burn to the skin. Sternum जो है ना, वो उसकी बजाय उसमें फोटो भी बना हुआ है. You can see that. हाँ, हमें क्रॉस करना है ना हार्ट को, तो पूरा हार्ट हमें कवर करना है ना. तो स्टर्नम के नीचे तो हार्ट है अभी इधर. हार्ट पूरा इधर नहीं है बियॉन्ड द स्टर्नम, तो हमको यहाँ रखना है थोड़ा राइट, है ना. जो स्टर्नम के राइट वाला पोर्शन है अबव द, बिकॉज ऐसा है ना हमारा हार्ट, तो ये है ऐसा, है ना, ट्राइंगल में ऐसा है. मैं उल्टा बना रहा हूँ इस वाले, यहाँ से ऐसे देखेंगे. ये अपेक्स है, हार्ट इधर है, यहाँ तक है. तो आपका जो शॉक होगा वो यहाँ से शुरू होगा, यहाँ खत्म होगा, तो पूरा हार्ट को क्रॉस करके जाएगा. वो यहाँ होगा, है ना, तो पूरा क्रॉस करेगा. हाँ, एक्सला की तरफ पूरा क्रॉस करके आएगा ना, तो करंट. समझ गए आप. इंटरपोस्टर लगा रहे हैं, पैचेस लगा रहे हैं एडी वाले, इंटरपोस्टर कर रहे हैं यदि, तो एक सामने एक बैक में, और सामने लगा रहे हैं. पेशेंट की पोजीशन तो आपको पता नहीं ना, पेशेंट से वो तो पड़ा हुआ मिला है ना आपको, जैसा है वही लगा दिया आपने, फटाफट फटाफट ऑन कर दिया, फटाफट दिया. तो उसमें टाइम बड़ा इंपॉर्टेंट है. वो शॉकेबल होगा तो ही शॉक देगा, वो स्मार्ट है एडी, वो सब रीड कर लेगा, और शॉकेबल है तो शॉक भी कर लेगा. वो उस पैच से रीड कर लेगा सब कुछ. इसमें भी दो ऑप्शन होते हैं ईसीजी रीड करने के लिए. एक मॉनिटर पे आता है ईसीजी, उसको भी ये रीड कर सकता है शॉकेबल रिदम के लिए, और एक आप पैडल वाला मोड पे डाल सकते हैं ईसीजी के लिए. तो पैडल ही ईसीजी भी दे देगा मशीन को, और वो उससे सिंक्रोनाइज करके शॉक दे देगा. तो दो मोड है इसमें आप मशीन के अंदर ईसीजी भेजने के लिए. एक तो आप मॉनिटर वाला मोड है वो चूज कर सकते हैं. आपके लिए उसके लिए मॉनिटर वाली लीड लगानी पड़ेगी, जैसे आप ईसीजी और मॉनिटर के लिए लगाते हैं, वो लीड कनेक्ट करनी होगी. यू हैव दैट मच टाइम, तो वो यूज करो. यदि इमरजेंसी है, शॉक में पेशेंट है, प्लांट शॉक नहीं है. एक तो हम प्लांट शॉक देते हैं ना समटाइम्स एट्रियल फिब्रिलेशन को रिवर्ट करने के लिए, जिसमें कि पेशेंट एफib में है और हम रिवर्ट करना चाहते हैं उसको. हमने देख लिया कि थॉम्बस नहीं है, एलए में, वो एक डिफरेंट सिनेरियो होता है जिसमें हम प्लांट शॉक देते हैं डीफib का. हाँ, वो अलग हो गया सिनेरियो. एक ही इमरजेंसी है, पेशेंट शॉक में है और हमें इमीडिएट वो शॉक देना है, तो हमें पैडल वाले ऑप्शन को यूज करना है. उसमें दोनों ऑप्शन है. पैडल विल गिव द ईसीजी टू द मशीन. पीएसवीटी में यूजुअली यदि पेशेंट शॉक में नहीं है, और we can give the drug, control the rate. Pardon? If it is shockable, we can give the shock to revert it, but usually it is not required. Drugs usually works. In more than 99% cases, it works. Just give the IV Dilgem, reverse. What are the shockable? BT. Non-shockable is the rhythm which is VF, in which there is chaotic rhythm. There is no definite QRS complex, but some complexes are there. So that is chaotic rhythm, VF, ventricular fibrillation. Clear? अभी और एक ECG हो गया, वो हो गया, all finished. Okay. So we should give clap to our senior resident, Dr. Abhijit. He prepared nicely the videos for you. It's made by efforts of all senior residents. So thanks to all of them. And I think in the agenda, okay, so we are coming to the, yeah, if any questions are there regarding this, we are available. We are available on this WhatsApp group, and through CMO sir, we can extend our services to other places if UP government asks for that. And otherwise, for this project, we are working in a hub and a spoke model, and we will going to conduct these training sessions in quarterly basis. So you can send the demand to our CMO sir, and we will have online or offline training sessions, separate training sessions for medical officers or nursing officers or ECG technicians or something like that. We can have, or we have you people who are trained now and can do ECG, can interpret ECG, can do the thrombolysis, how to prepare, what is the dose, what is the contraindication, what is the checklist, what is the complications of MI, everything you know. So now you can train and give these words to your colleagues. You can take a session in your own hospital. You can conduct those things, workshops, or you can do training of colleague staffs by giving the feedbacks that these are the points. We will give you whole protocol in PDF. Everything will be there in the regarding this project or MI management that we will share with you. Everybody has hope given the proper phone number and email address, WhatsApp number and email address, I think. And before anything ends, a very important part is the vote of thanks. So that is also responsibility given to me. So good evening, ladies and gentlemen. I stand here today as a proud and grateful person to express my heartfelt thanks to all those who have made this event possible. I would like to start by thanking our BHU management, who have always been supportive to and of our initiatives and encouraged us to strive the excellence. I would like to express my appreciation to all our guests who have taken time out of their busy schedule to grace this occasion and with their presence. Your presence has added an extra spark to this event and made it even more special. I would like to extend my gratitude to our STM dignitaries. Our VC sir was not present in the city, he could not join as a chief patron. Our chief guest came all the way from Lucknow, Partha Starkis and Sarma, Principal Secretary Medical Health. Our director sir has came from his busy schedule. I am thankful to him, Professor Dr. B.K. Shukla sir. And I would like to thank Dr. S.K. Singh could not join our director sir from IMS BHU. He was busy with his open schedule. I asked him and thankful to Dr. Professor Ashok Kumar, our Dean Research IMS BHU for various inputs time to time for this research project and this program. He is out of city, could not join us. Professor Dr. K.K. Gupta sir, MS SSS BHU, he was busy with his schedule, could not join us. And thankful to Dr. Professor Saurabh Singh, who is the professor in charge Trauma Center BHU, who has given the opportunity to use this hall. And he was present here and interacted and chaired panel sessions. So very many thanks to him. And thankful to our ICMR experts, Dr. Meenakshi Sharma, as he was the scientist, G-level senior scientist from ICMR. Division of NCD, Non-Communicable Diseases, New Delhi, and along with her, the Dr. Rupa S. She's a scientist E from ICMR, New Delhi, and Professor Dr. S.K. Dwivedi sir, Professor and Head KGMU Lucknow, and Professor P.C. Negi sir from IGMC Simla, who shared his experiences. And Dr. Basanta Kumar needs he was the executive director, TSU Medical Health UP government. He has shown us, enlightened us that how we can extend it on other districts of the UP. And then Dr. Sandeep Chaudhary is dynamic CMO of our Varanasi. We are proud of him that he is taking so much immense interest and made this event and projects going on successfully, we can say. And thankful to other panelists like Dr. Dheeraj, Dr. Dheeraj Kishore, Dr. S.K. Gautam, Dr. Abhishek Pathak, Sankas, and Ajay Pandey sir, Manoj Gupta sir. And especially thank for Dr. Alok Kumar Singh. He was the president of Heart India Charitable Trust, and he has spared time from his busy schedule. Our speaker, Dr. Suresh Tripathi, and Dr. The Swamik Ghosh, who spared time from his busy schedule and given the lectures, enlightened us. So especially thanks for them. And the other panelists like Dr. Sanjay Kumar, Dr. Anup Singh, Dr. Ramurthy Singh, Dr. Amesh Pandey, Dr. Rajpal Pradapti, who could not join us because of their engagements. And thankful to other faculties from BHU and who has been guiding the lights, imparting wisdom and knowledge to us, and training our doctors, nurses, and other staffs involved in this life-saving project by ICMR. Their unwavering support has been instrumental in the success of this training program. I would also like to thank our team members, of course, Dr. Payal Singh, who worked day and night to prepare this. I need a round of applause for the team effort of Dr. Payal, Dr. Mr. Virinder, and the other team members, and the caretaker of auditorium, catering people, decoration people, media people, and all those who have been with me to make this a success, and our senior residents who were working day and night for making this project successful. They need a special mention and applause for them. They are the person who are there in our CCU 24/7. If you ask in this SS hospital, you take the round in whole hospital, you will find some person in ICU and our CCU. They are there 24/7 for the service of this mankind, and they will be helping us in the diagnosis. Whenever they are not there, then I am there. You can call me anytime, and we will take the decision together to make this project successful and take the decisions for thrombolysis if any confusion is there. ST elevations, CMO sir has shown different type of ST elevations in MI in different phases. So if the ST elevation is there with the ST depression, that is in other leads, which are reciprocal leads. So for inferior MI 2-3 AVF is having ST elevation, maybe the V1 to V6 any lead is V1 to V4, V5, C6. Some leads are having ST depression. So whatever the lead whatever the wall is having damage, that is having ST elevation, and the opposite wall will be having ST depression, just opposite wall. So that will come in the ECG. The elevation is because of current of injury, and this ST depression is because of many causes, including the ischemia in that territory. So relative ischemia, because it's a failing heart. So elevation is there because the blood supply is not there, current of injury, and depression is there because ischemia is also there in this area, and reciprocal changes are also there. So many causes are contributing. If depression is more than the ST elevation, is very poor prognosis. That means that area is also having less supply. Means multi-vessel diseases there. So it's very poor prognosis patient. So these are the things which are very important to remember, that elevation with depression or dynamic changes. That previous ECG is normal when patient came. Now the ST elevation in front of you. So hourly ECG in a suspected ACS patient, 2-3 ECG should be there taken before leaving the patient and labeling the patient that it's not ST elevation. If the ongoing pain is there, you should repeat the ECG even at half an hour. If the patient, and one patient came, I remember, who was having pain. He was residing just nearby in Lanka area. He came with the chest pain within half an hour. He was having severe chest pain. ECG was perfectly normal. One patient, young patient, telling doctor, "मुझे बचा लो, pain हो रहा है, बचा लो." Severe pain. We were given the sorbitate, we were given the aspirin. We could not thrombolize because ST elevation is not there. Then we repeated the ECG because he was having severe pain, ongoing pain, not relieved by aspirin, by sorbitate, 1 sorbitate, 2 sorbitate, 3 sorbitate. He is having pain, ongoing pain. Then we done the second ECG, frank ST elevation MI. So then we thrombolized immediately and patient got the relief of pain. And उसी दिन से आप उस पेशेंट के लिए भगवान हो जाते हो कि डॉक्टर साहब ने मुझे बचाया था। वो चेहरा उस आदमी का नहीं भूलते हैं जिंदगी भर। You are saving some patient's life, giving the pain relief. इसमें पेशेंट को आपको पहले ये बताना है कि पेशेंट मरने वाला है because so many complications are there with MI, और हम उस कॉम्प्लिकेशन को शायद अवॉइड कर पाए by giving this injection. जितने जल्दी इंजेक्शन उतनी ज्यादा मसल सेव होगी। सर ने एक एग्जांपल सुनाया था जो हमारे सर आए थे IGMC शिमला से, डॉक्टर PC नेगी, कि वन पेशेंट वाज नॉट गिविंग कंसेंट। उसको डर लग गया कि भाई पता नहीं क्या देने वाले हैं, भाई हम नहीं लगवाएंगे, हम तो जाएंगे, हमको रेफर कर दो, आप कहाँ छोटा मोटा अस्पताल है, आप लोग नहीं संभाल पाएंगे इसको। सेम केस, नेगी सर को कॉल गया, उन्होंने फोन पे कहा मुझसे बात कराओ अटेंडेंट की। ही काउंसल्ड द पेशेंट कि आप 3 घंटे बाद मेरे पास पहुंचेंगे, आपकी मसल ऑलरेडी डेड हो गई, कोई फायदा नहीं होगा, वो जो इंजेक्शन वहां पड़ने वाला है वो हम भी देंगे तो और नुकसान करेगा, क्योंकि आप आउट ऑफ विंडो पीरियड हो जाएंगे। विंडो पीरियड के अंदर इंजेक्शन लेंगे, आपकी मसल सेव होगी, टाइमली वो खुल जाएगी नस जो बंद हुई है, तो आपकी लाइफ सेव होने का ज्यादा चांस है। वो पेशेंट ने थ्रोम्बोलिसिस कराया सिर्फ एक काउंसलिंग से। वही काउंसलिंग आप यदि, सर ने एक ही चीज बोली CMO सर ने, और एवरीबॉडी हैज टोल्ड दैट काउंसलिंग इज वेरी इंपॉर्टेंट टू सेव। यदि आपने एक्सप्लेन कर दिया ये पेशेंट मरने वाला है, मैं कभी ग्रीन ग्रीन गुडी गुडी नहीं बोलता किसी पेशेंट को, जो है वो सामने है। आपका MI है तो सडन कार्डियक डेथ का चांस नॉर्मल पर्सन से ज्यादा है। आप रोड से निकल गए तो आपको एक्सीडेंट का चांस नॉर्मल जो घर में बैठा है उससे ज्यादा है, रोड ट्रैफिक एक्सीडेंट का। सेम एग्जांपल आई गिव टू द पेशेंट दैट आपको MI हो गया है, आपको नॉर्मल पर्सन से सडन कार्डियक डेथ का चांस लाइफ टाइम के लिए ज्यादा हो गया है, बिकॉज वो एरिया जो डैमेज हुआ है वो उसमें शॉर्ट सर्किट होकर धड़कन खराब होगी, VT होगा, VF होगा, सडन डेथ होगी। 2 मिनट बाद आप हैं, 2 मिनट बाद आप नहीं हैं। यदि ये आपने एक्सप्लेन कर दिया उसको इतनी शुद्ध हिंदी में, उसके बाद आप बता दोगे कि ये दवा है, इंजेक्शन देने से थक्का बना है, वो भूल जाएगा, शायद आपको भूलने से फायदा होगा, और वो थक्का भूलने से आपका दर्द भी आराम होगा और मसल भी सेव होगी। इतना अच्छे से यदि आप काउंसिल कर पाते हैं और उसके बाद आप कंसेंट साइन कराते हैं कि मुझे सब बता दिया गया है, और आप इंजेक्शन फ्री में दे रहे हैं उसको अभी इस प्रोजेक्ट में, उसका तो पैसा भी नहीं लग रहा है भाई। बड़ी तो और सब तोड़ फोड़ तब होती है ना जब उसकी जेब से पैसा खर्च होता है, यहाँ तो पैसा भी नहीं खर्च होने वाला है, तो उतनी बड़ी की बात नहीं है। और सिंगल पुश इंजेक्शन है, बहुत तामझाम है नहीं, जस्ट यू प्रिपेयर इट, हाउ टू प्रिपेयर, आई हैव शोन इट टू सिस्टर्स, आई थिंक आई हैव एक्सप्लेन क्लियरली। एंड यदि कोई कंफ्यूजन है यू कैन आस्क अगेन एंड अगेन एनी टाइम। और जो है यू हैव गिवन द इंजेक्शन, यू पेशेंट वाज रिलीव्ड ऑफ द पेन, well and good, not relieved of the pain, it's failed thrombolysis. So even after 1 hour, if you repeat the ECG, after 2 hours you repeat the ECG, still ST are elevated and patient is having ongoing pain, it's failed thrombolysis, थक्का नहीं खुला है। So if more than 50% settlement ST segment का नहीं हुआ है, या more than 50% pain relief नहीं हुआ है, 0 to 10 के स्केल पे उसको पूछा जाए, तो फिर इसका मतलब है कि थ्रोम्बोलिसिस काम नहीं किया है, पेशेंट विल नीड सम फर्दर ट्रीटमेंट। यू कैन गिव सम नाइट्रोग्लिसरीन टू हिम, निकोरांडिल टू हिम, these are all anti-ischemic agents, or you can refer that patient to hub center. So these patients should be referred immediately, otherwise you can, if the successful thrombolysis is there, you can have that patient for 24 hours also, and then accordingly schedule the transfer if required to the hub center. as per availability of your ALS ambulance. So ALS ambulance people should also be trained regarding care. I think they are trained because UP government, I asked for this. There was one task given by ICMR that we should have a tie-up with the 108 ambulance. I don't know what is the MOU or SOP for that tie-up, but I asked, I just dialed 108, asked that somebody from Lucknow taken the call. I asked that we are having this project, how to go ahead. They told that ALS ambulance are available in the your Varanasi district, and whenever your patient need inter-hospital transfer, it's totally free, and we are having very good ALS ambulance with facilities available, which is recommended. So I think, am I right? You people from State Health Services, give me inputs regarding ALS services. I need your inputs. Please share. Okay. माइक दे दो डॉक्टर साहब. दूर से आना होता है, टाइम लग सकता है, लेकिन सर्विस मिल जाती है. If they are coming from other places, then it will take some time. By that time, you can manage the patient with anti-ischemic agents, and then we can refer that patient. So like that we do in each and every case. So I think I have justified and summarized everything today's scenario. And you are the trainers for your colleagues. Do not forget to train at least one colleague so that it can be propagated to other colleagues. So please train them, share with them whatever you have learned today, little bit. It's sensitization program. Just you are sensitized that we are now ready for the thrombolysis, and you sensitize other people that this thing is going to happen in whole city of Varanasi and whole UP, this state, as your seniors told today, and it is going to happen. It's good thing. Take positive moves and properly give the counseling to the patient before touching the patient in each and every case, not only MI, it can be anything. So counseling is very important, that you are having this disease, which is deadly. You are going to die any moment in your future life. You have higher risk than the other people, normal people who do not have MI. So this injection will reduce that risk. If you are explaining like that, and they taking the proper consent in proper way, which I explained, there is no problem. And very small form is there in the app. It's very simple app. The ICMR has prepared it for this project. So please use that and fill the data on the same day when you get it. Thank you very much. I think with that, tea, I think it's there, and you can enjoy that. And certificates, if given by ICMR, I asked them. So they told that we will ask our senior people and then give the digital signature, and then we will use that. And if they provide us, like remaining material which we have learned, I will share with all of you. And YouTube link is there. YouTube, we have recorded whole of day's program in YouTube, and link will be there. Our telemedicine people are there. I'm thankful to them also if it is left. And you can see this program anytime in future. It's there in the YouTube. That is the meaning. It will not be deleted. It is there forever. So it is there in the YouTube. I will share that link to all of you. I will save all of your numbers and then share that link, or the email IDs, and share that link. So you can see this program and share this link to all your colleagues so that they can be benefited, and just they can see at home anytime. This whole program is recorded, and your colleagues can learn, and you can also repeat and revise this by YouTube. So thank you. The special mention is there. Our the physicians from city took time, and Dr. Shiv Shakti, Dr. Atul, they are very phenomenal in success of this project from CMO office, and Dr. Other people, Dr. Nikunj and Dr. Saurabh, they have also took the interest and given some responsibilities by CMO sir. So I am thankful to CMO office staff and our CMO sir for taking this project ahead. Sir, please join us for the tea. Thank you.